agents as well. So it's an ideal candidate for backbone of combination therapy, and trials are even ongoing with novel bispecific antibodies. So coming to non-small cell lung cancer data, we have rational 307 study wherein teslelizumab plus chemo versus chemotherapy alone for advanced squamous NSCLC in first line. So if you see the study design, it included histologically confirmed locally advanced stage 3B and stage 4 squamous non-small cell lung cancer with no prior systemic therapy, no mutations, with good performance status patients were included. Randomization was 1:1. Arm A included teslelizumab 200 milligram with Pacli and carbo. Arm B included teslelizumab with nab-pacli and carboplatin, and Arm C only contained chemotherapy with maintenance teslelizumab allowed after completion of initial cycles. Stage wise and PDL1 TC score wise stratification was there. The primary endpoint was PFS by independent review committee, and secondary endpoint was ORR, DOR, OS and safety profile. And coming to the efficacy data, so if you see, if we compare arm A and arm C as well as arm B and arm C, definite significantly improved PFS was seen as compared to chemotherapy alone. In arm A, that is Pacli carbo, the reduction in risk of progression or death was 55% with hazard ratio of 0.45, as well as similar in arm B as compared to arm C, that is nab-pacli carbo, the hazard ratio was 0.43 with a 57% reduction in risk of progression or death. If you see subgroup analysis across all the pre-specified subgroup, the benefit was seen favoring teslelizumab in combination with chemo, may it be liver metastasis patient, disease stage, or even PDL1 expression. So irrespective of expression or disease state, the PFS was significantly improved in patients with teslelizumab. Even if you see the overall responses, and the duration of response, if you see, it was 87, ranging from 87 to 90% in teslelizumab arm as compared to chemotherapy alone, which was 80%, and duration of response was double 8.2 as compared to 4.2 in only chemotherapy arm. The best overall responses also were around in the range of 23 to 26 as compared to 19 in the chemotherapy arm alone. OS subgroup analysis also favored teslelizumab. So with median survival follow-up time of about 44 months, which represents an additional 30 months since the final analysis, the OS benefit in combination arm across all the pre-specified subgroup was favoring teslelizumab. Coming to safety profile, no new safety signals were seen, similar to what we see with immune checkpoint inhibitors. So immunotherapy related adverse events included skin reactions, pneumonitis, hypothyroidism, which were common, and chemotherapy associated anemia, neutropenia during the initial cycles. So concluding rational 307, long-term survival after 4 years teslelizumab plus chemo achieved durable, clinically meaningful OS benefit versus chemo alone. Consistency with prior results, OS advantage remains consistent with the final analysis despite high crossover. Subgroup benefit across all the PDL1 current former smokers, stage of the disease, patients included with liver metastasis, the subgroup benefit was favoring teslelizumab. Safety was well tolerated, no new long-term safety concerns was seen. So it's a promising first-line standard in advanced metastatic squamous NSCLC. So coming to analysis wherein patients who progressed on chemo with teslelizumab, they were further studied and they were divided into 3 groups. TPP group, which continued teslelizumab on progression. OT group was switching to another anti-cancer agent, and NT group was patients who received no treatment further. So post-progression disease OS and OS from randomization were evaluated from in these 3 groups. Even risk categories were made, wherein post-progressive disease were categorized into low risk, wherein only existing lesions were seen progression, intermediate risk where new lesions were seen as progression, and high risk, wherein both existing as well as new lesions were seen as progression. So the trial design of this was patients who received first line tezepelumab with chemo as per the RECIST criteria, who progressed on this were either continued tezepelumab post progression, given another anti-cancer agent, or patients who were not on any treatment. So such three groups were divided. Characteristics of these three groups were well matched. If you see individually, more or less similar matched population was seen across all these three groups. So if you see the median OS difference in post-progression patient was 18 months in patients who were still continued on tezepelumab, as compared to 7.9 months in other treatment and 7.2 in patients who didn't receive any treatment. And the median OS right from randomization was 28 months, 18.4 months and 14.3 months respectively. If the risk categorized groups were considered individually, then patients who benefited more were low and intermediate risk. But again, in patients who received other treatment, the benefit was still on with the patients who were continued on tezepelumab. So 22.8, 16.1 and 8.3 were respectively in low, intermediate and high risk patients, while in patients who received other treatment it was 13.6, 7 and 4.7 months. So risk of the adverse event did not increase, even though tezepelumab was continued for a longer duration. So no new safety signals were seen, and reasons for discontinuation was mostly around 6% due to adverse event, while majority of them progressed on tezepelumab. That's the reason why they were discontinued. So though it was a retrospective analysis, which is a limitation, but post progression tezepelumab might bring a survival benefit in squamous NSCLC patients. Patients with low intermediate risk tend to have longer OS, suggesting a beneficial population which could be identified, and tezepelumab can be considered, and needs a larger prospective study to see how it benefits. Coming to rationale 304, which is again tezepelumab with chemo alone in metastatic non-squamous NSCLC. So again a similar study design. These were patients with eligibility criteria, not given chemotherapy prior, and primary endpoint being PFS and secondary being ORR, DOR, OS. Wherein tezepelumab was continued. So PFS benefit, again a hazard ratio of 0.63, 37% reduction in risk was seen, and ORR again was around 57.4%, majority PR. OS benefit was 20 to 21% as compared to months as compared to the RMB. It was hazard ratio was 0.85. So response rates were higher, and response duration was longer in combination therapy versus chemotherapy alone. Coming to rationale 303 study, which is tezepelumab in second and third line therapy for advanced metastatic NSCLC. It was compared with docetaxel as the other arm. And again primary endpoint was OS, and was also studied in PDL1 population of more than 25% TC staining. Squamous and non-squamous was again stratified differently, and second versus third line therapies. So if you see the efficacy data, overall survival, prolonged significant overall survival, as well in PDL1 more than 25% population, and also in intent to treat population, hazard ratio of 0.67 here, and PDL1 more than 25%, it was 0.53. OS subgroup analysis across all the PDL1 expression subgroup, the benefit was favoring tezepelumab over docetaxel. So if you see PFS, ORR and DOR, the median PFS was 4.2 as compared to 2.6, more in PDL1 more than 25%. ORR also was 22% as compared to 7%, duration of response 13.5 as compared to 6. So demonstrated significantly prolonged PFS and DOR, and improved ORR versus docetaxel. Other lung cancer settings, NSCLC rational 315 study is going on, neoadjuvant and adjuvant setting, where the MPR, the major pathological response, was 56.2% as compared to 15%. These were the key findings, and rational 312 was in SCLC study. And these are the findings. So only PDL1 inhibitor with comprehensive benefit from late as well as to early stage across NSCLC and NSCLC we see. So coming to a network meta-analysis wherein tezepelumab was compared with anti-PDL1 agents in first and subsequent lines. So if you see for PFS, tezepelumab plus chemo was having a favorance as compared to the other single agent nivolumab, atezolizumab, chemotherapy, ati plus chemotherapy, even nivo-EP combination favored tezepelumab plus chemotherapy. If we talk about non-squamous first line, especially in PDL1 more than 50%, here also the PFS tezepelumab plus chemo was ranked as efficacious as compared to the other agents. If you see second line plus NSCLC, including any histology, again it was ranked as most efficacious as per this analysis. So guideline recommendation presently esophageal cancer first line, especially in PDL1 CPS more than 5, HER2 negative and adenocarcinoma. Even in gastric cancer, first line CPS more than 5. First line combination in squamous esophageal cancer with CPS of more than 1. Second and subsequent line as a monotherapy. Hepatocellular category 1 as first line monotherapy. In Hodgkin's lymphoma, relapsed refractory, it's combined with gemcitabine and oxaliplatin, Tecelli Gemox in refractory patients. And then nasopharynx also as first line in combination with Gemcis, and subsequent line as a monotherapy is the recommendation summary as per the NCCN guidelines. So tezepelumab is a highly active and efficacious PDL1 inhibitor, monotherapy in second line plus NSCLC, and tezepelumab plus chemo combination in first line squamous and first line non-squamous PDL1 more than 50% was found comparable or more favorable than the other PDL1 therapies as per the OS, PFS and even safety signals. These findings provide clinical evidence for benefit of tezepelumab, representing an additional immunotherapeutic options for patients in first, second line NSCLC. So I think with this I would conclude. Thank you.
Thank you, Dr. Ashwin. We now transition into our academic track, session 14, lung cancer. This session is led by our session director, Dr. Amish Vora, consultant medical oncologist, New Delhi, and our session coordinator, Dr. Mangesh Mekha, senior consultant medical oncologist, Pune, under the guidance of our chairpersons, Dr. Girish Fadke, consultant oncosurgeon, Pune, and Dr. Hari Gadade, consultant clinical oncologist, Latur. So may I request you to kindly take your seats. For our first talk, we explore how lung cancer therapy has evolved, where we started, where we are, and where we are headed. This session is supported by AstraZeneca. Please welcome Dr. Kshitij Joshi, consultant medical oncologist, Mumbai, to lead us through this journey.
Good morning, everyone. Thanks, organizer, for giving me this opportunity to present. This is the title given to me was Treatment Evolution in Medical Management of Lung Cancer, Past, Present, and the Future. And it was a big story. It was very difficult to compile everything in 15 minutes. So I tried a little bit, and I tried to compile it like you can consider a movie. It's a trailer. Everyone knows the movie, and also Dr. Shailesh Bondade sir after this in the panel will explore that movie, but this is considered just a trailer. What has happened in the past, now and future might be. So let us start without wasting time. So the journey of lung cancer treatment, I try to divide into 4 parts. One is pre-molecular era, second is early precision era, third is current, which is the IO era we can consider, and then there are the future directions. The pre-molecular era, when histology and stage were everything. In advanced NSCLC, from the 1990s, we can consider this era till early 2000, when actually all the seniors, they have started their careers during this era. The platinum doublet delivered median OS of 8 to 10 months, with 1 year OS of 30 to 35% and 5 year OS was under 5%. That was the rule in the early era when the histology was the main. Early stage post-surgery, that is a less meta-analysis, just a adjuvant cisplatin that has shown the benefit of 5 year OS of 5%. And stage 3 unresectable was CTRT was the standard of care with achieved OS of 16 to 24 months and 5 year OS of 15 to 25%. And that was the best what we were considering till our 2000 eras. So it was the histology. Then we moved to the early precision era. First crack in the one size fit for all approach. And that started after 2000, and few of the young colleagues, we started our education, and in that area, this was the era till current recent time, and we can see the discovery of actionable mutation was the most important thing, and emergence, the new initial immunotherapy advances, immunotherapy searches were there in the second line setting, which marked the beginning of the precision oncology in the lung cancer. This era proved that the oncogene addiction NSCLC behaves like a fundamentally different disease. That was the fundamentally different concept. First EGFR TKI IPASS trial, as we are aware, PFS was 9 to 10 months and PSS 4 to 6 months. The EGFR TKI was introduced. Then the ALK inhibitors, its profile trial, crizotinib, 10.9 PFS versus 7 months with response rate of 74 versus 45%. Then the immunotherapy was introduced in this early precision era, checkmate trial, keynote trial, and they have shown a second line setting, durable responses and long-term survival, almost HR 0.59 to 0.73. And then PDL1 biomarker was discovered during this era. High PDL expression correlated with the better IO benefits and introduced key biomarker concept. As we are still debating that whether it is the best biomarker or still we have a lot of things to learn, new biomarkers has come, TMB, MSI and all, but still it was the beginning was started with this PDL1. Then the biology over histology was the concept. The current era when we are treating our patient is where we consider biology over histology. This was a movement we stopped calling NSCLC the same disease. Targeted therapy and immunotherapy in the second line gave the deep responses in subset, proving that molecular biology matters more than the histology. That was the conceptual change that has happened in this area. Then in this era, let us see what has happened. We all know it is just a revision that we can consider. Adjuvant immunotherapy shifting curability earlier. So already curative setting, how we can improve the curability. The Empower 10, atezolizumab after chemo versus best supportive care, initially HR was 0.81, stage 2 to 3, PDL1 more than 1%, keynote 091 pearls, pembrolizumab versus placebo, and we can see the difference. So adjuvant immunotherapy after this was a standard of care in high risk PDL1 positive resected NSCLC with benefit even PDL1 low or unknown population as well. Then these are the list of few trials. We can consider the neoadjuvant trial here, the third one and the fourth one, the Checkmate 816 and the Checkmate 770. Checkmate 816, neoadjuvant nivolumab with chemo versus chemo. The pathological CR rate 24% versus 2.2. So this was a quite significant difference, and we see the neoadjuvant coming into the new standard of option after this. Then 770 perioperative nivo plus adjuvant, the HR is 0.58, even little more beneficial. So this proves the perioperative IO with a high risk. And last to last WCLC, the entire panel discussion everywhere and the debate everywhere was what is the right approach, perioperative, whether it's adjuvant or just going ahead with the surgery. And so that was the discussion in the recent past. This is a few more trials I just want to mention. Keynote 671, the perioperative pembro plus chemo, shown the benefit. And there is one more trial of a durvalumab and toripalimab showing the benefit. So AGA negative means biomarker negative early stage perioperative chemo IO is now the dominant paradigm pushing long-term cure rates up. So this is the change that has happened, and we are started using in the practice in last few years. I can say in the last 2 years, this approach, and we can see the better results. Then the stage 3 biology stratified consolidation. So this was about the perioperative and the adjuvant. The consolidation therapy, the AGA negative disease specific trial was the first. Concurrent CTRT followed by durvalumab versus placebo. The OS was 47.5 versus 29.1, significant HR 0.72, PFS 16.9 versus 5.6, and specifically when PDL1 more than 1%. And we all started using after this specific the durvalumab as a consolidation. Then comes the LAURA trial, EGFR mutant disease, after CTRT, which is followed by osimertinib, and the PFS was 39.1 versus 5.6, quite significant. HR is very, very significant, 0.16, 84% almost reduction. EGFR positive stage 3, so osimertinib and not the durvalumab. That was the change in the concept here. The stage 3 is now biology stratified, so current approach. Test actionable genomic alteration to determine the right consolidation strategy. That is our current approach. We don't know what will happen in the future with the whole biomarkers giving expose and the more options were available. Now coming to the metastatic disease, that is biomarker negative, the immunotherapy landscape. The immunotherapy landscape initially started, as we can see here, the PDL1 more than 50% IO monotherapy approved by Keynote 024, 5-year OS is 31.9% versus 16.3%, or chemo IO best if the burden is high. Then PDL1 in between, we try to classify it as per the PDL1, 1 to 49%. Chemo IO combination is the standard as per the Keynote 189. And PDL1 less than 1%, there is a chemo still standard, but also chemo IO and dual IO with a short course of chemo, checkmate 9LA. So these are the current approaches in the metastatic setting. We can see the difference in the survival with the addition of immunotherapy. So that's why we can call our era, current era, as the immunotherapy era, because the most remarkable achievement of the immunotherapy era is emergence of long tail survival curves, with substantial proportion of patients alive at the age of 5 years, and this was not thought in the previous era. Is it possible in the lung cancer? Something never seen in the chemotherapy era. The Keynote 024 with the pembrolizumab monotherapy, PDL1 more than 50%, almost 31.9% 5-year survival. That is quite significant. Keynote 189 with pembrolizumab plus chemo, non-squamous, 19.4%. In the checkmate 227, 5-year OS with nivolumab plus ipilimumab, the dual immunotherapy with PDL1 more than 1%, 24%, and the checkmate 9LA 5-year OS dual IO plus 2 cycles of chemotherapy is 18%. So that was when we started, it was less than 5%, and now we have reached to these numbers, and we expect as the science progresses we can get more and more numbers, and with the help of immunotherapy we may be able to achieve the cure. Survival rates present is paradigm shift. Metastatic NSCLC can now be a chronic disease with meaningful long-term survival in selected populations. Let us go to the EGFR mutant. Just revise what has happened in the EGFR mutant space. NSCLC across all the subgroups. Adjuvant ADURA, because the EGFR mutant that we all are aware that exemplifies the precision medicine across all the stages. From adjuvant therapy after resection to the first line metastatic setting, osimertinib has now become the backbone of EGFR directed therapy. Adjuvant ADURA trial, osimertinib versus placebo in resected EGFR mutant 1B to 3A, DFS, HR is 0.27, 5-year OS, HR is 0.49. Then coming to the LAURA, which the osimertinib post CTRT, we have already seen PFS 39.1 versus 5.6, and HR is very, very significant, 0.16, which is 84% reduction. And metastatic flora, osimertinib versus first generation TKI, that is long we know. And the high risk metastatic flora 2, osimertinib plus chemotherapy, PFS 25.5 versus 16.7 months with HR is 0.62. So expanding the targetable landscape, there is a long list of drugs that is coming into the market currently. Just to touch upon few, beyond EGFR and ALK we know very well. Multiple oncogenic drivers now have been approved targeted therapy transforming outcome in the patient with the rare molecular subtypes. EGFR exon 20, that most difficult. As we say, it is the percentage is very less, but still we can see a lot of EGFR 20 in our routine as we are doing more and more NGS. So the Papillon trial says the amivantamab plus chemo, PFS 11.4 versus 6.7, that is now approved. If the ALK, the lorlatinib 5-year PFS not reached versus 9.1, HR 0.19, it is like now updated the statistics, but it is quite significant in the ALK positive space, and everybody in a medical oncology field have many patients on the ALK positivity giving the excellent responses, and that has changed their disease into chronic diseases. ROS1 Trident trial, repotrectinib overall responses is 79%, PFS 35. RET, there is a Libretto trial, sulpercatinib PFS 24.8 versus 11.2% with HR significant. MET X14 tepotinib, the PFS is 8.5 months and OS is 17.1. And HER2 mutant Destiny lung trial, trastuzumab deruxtecan, and overall response is 55%, PFS 8.2. There are a few examples. So we can see, previously we used to test only few. When I remember when the practice was started, the Geftinib, not practice, my education was started, Geftinib was given to all like a female patient, non-smoker. Then we started checking only EGFR, then EGFR ALK, and now we are testing each patient with at least short panel of NGS and giving the actionable information for us. KRAS G12C, which was considered as the toughest one, is now druggable. The sotorasib and adagrasib, the overall response rate is around in the range of 50-40%, still PFS 5 to 6 months, and it is very well tolerated. Even the adagrasib is CNS penetration advantage over sotorasib. This agent represents progress. Outcome lags behind the targetable other mutation, but still combination strategy can. So how to tackle with this, with the combination strategy? Future direction. Now coming to what may happen, because the future is very unpredictable, it may happen in the other way as well, but what can happen is the surgery and the baseline ctDNA, establish molecular signature, baseline MRD status post-operatively, and that is change few treatment in colon and other cancers. It may happen in the lung. So serial MRD monitoring, we track the ctDNA during and after adjuvant therapies and decide the treatment whether we want to increase or decrease. Risk stratification, MRD positive patient receive escalated and extended therapy, and de-escalation. That is what ongoing trial like a mermaid. Yeah, I will going to complete in 3-4 slides. Ongoing trials like a mermaid 1-2 are testing whether MRD guided decisions can improve outcome while reducing unnecessary treatment exposure. That is one thing that might happen. Antibody drug conjugate, the next wave, because what next after chemotherapy fails in a actionable biomarker negative. So that cases, there are few antibody drug conjugated. One we know, trastuzumab deruxtecan, it is very well known and we have discussed, is HER2 mutant. Second is a TROP2 is directed antibodies. They are currently after docetaxel, comparing with the docetaxel, these antibodies, they are in the trial. Initial results are, they are shown some responses, may not be the best responses that we can achieve, but we can, in the future, we might have a better results, which is a TROP2 is a surface antigen exposed by many NSCLC. Then what can happen next? It is a combination strategy, pushing the boundaries. Give me 2 minutes extra. Future of a lung cancer treatment lies in the rational combination, the Mariposa, amivantamab plus lazertinib, last to last NSCLC that has approved and PFS beyond 30. Crystal combination, KRAS, G12C is a combination of immunotherapy and targeted. And it balancing the improved efficacy, and at the same time when we combine the toxicities and the cost consideration both comes into the picture, but we have to balance. Next generation staging, integrated biology, anatomical stage, molecular profile, liquid biopsy, imaging biomarkers, expanding screening beyond heavy smokers. There are few aspects, that is the risk calculators, AI-powered tools are incorporated into family history, environmental exposure, and the genetic risk factor to identify high-risk never smokers. Smokers, we know what to do. Never smokers, how to identify. AI-supported readings are there, machine learning algorithms, CT scanning, more accurate global adaptation of all these things. This is into actually current. There are apps now in the market, all, but we still have to adapt these changes. So future precision across our continuum from treat all to treat enough. So risk stratified using universal molecular testing, integrated staging, biology, mass therapy, new ADCs and MRD driven, and this all may happen in the future, but future we will see only in the future what is happening, because it is changing and expanding very rapidly. And I consider lung cancer is actually the disease which opened us to a precision oncology, and it has many aspects we have yet to uncover. Thank you very much.
Thank you, Dr. Kshitij. Continuing our NSCLC session, we now move to a panel discussion on a selected lung cancer case moderated by Dr. Shailesh Bondade, medical oncologist Nashik, with a distinguished panel joining him. I invite Dr. Shruti Gandhi, consultant medical oncologist Pune, Dr. Ajita Kendre, consultant radiation oncologist Pune, Dr. Anuradha Chaugule, consultant medical oncology molecular laboratory Mumbai, Dr. Naveen Bambani, consultant surgical oncologist Mumbai, Dr. Darshana Rane, consultant medical oncologist Mumbai, Dr. Pranav Chadda, consultant radiation oncologist Mumbai, Dr. Anup Raul, consultant medical genetics Pune, and Dr. Supriya Daga, consultant histopathologist Kolhapur.
So thank you, Dr. Kshitij, for setting the ball rolling. I think whatever he has said, we will see what the practical implications are when we are treating a case of lung cancer. And we all know that lung cancer is a poster boy for the precision oncology. So we have a distinguished panelists as well. So we'll take their help in finding out how we approach these cases. So going straight to the case. So this is a 50-year-old lady seen by me in February 22, ECOG of 1, non-smoker, non-diabetic, non-hypertensive, symptoms for around 3 months. Investigation showed extensive lung disease with bone and liver mets and also brain mets. Biopsy was suggestive of adenocarcinoma. Now I want my pathologist's help. Dr. Supriya, is she there? Yes, ma'am. When we get a histopathology report, do we have to do an IHC every time? Because you know what happens is we all know that tissue is an issue in lung cancer. We have small tumor biopsy. So number one. Number two, we normally have around 5 to 6 cores of the biopsy. Can you prepare one block for each core so that you know we have tissue remaining for further tests? And number three, do you always report the amount of tissue, malignant tissue in the sample so that you know we do the molecular markers on that?
So like you said, tissue is an issue everywhere, and 6 cores is a lot that you're telling me. More frequently what we receive is say 2 to 3 cores, but if we receive 6, it's like generous. So IHC is not employed in all the cases. If morphology is giving me a straightforward adeno or squamous, we generally...
But you do it when it is from a metastatic disease?
Yes, again, have to take into consideration the PET, what is it showing, and radiology.
For example, the patient has liver mets and the biopsy is done from the liver, not from the lung. So
but
are you comfortable?
If there is only lung and liver mets, I'm still comfortable calling it as lung primary.
Okay.
But suppose some cases what happens, say there is a mass in the colon, okay, just a colonic mass and lung mets. In those cases, mucinous carcinomas, lung primary and the colon shows similar markers. Then it gets very difficult even with IHC. because most of these will be TTF negative. Coming back to the primary question again, if there's only lung, we do not, go for IHC. Just adenosquamous, if I'm able to report on the tissue, we just send it out again for PDL1 testing and moleculars, because we try to triage the tissue and save as much as possible.
Okay, fair enough. So this is the PET-CT report, and you can make out that this is an extensive disease, lung mass, a lot of bone mets, and we have an MRI report also showing brain metastasis. Now, Dr. Ajita, patient is asymptomatic. Patient doesn't have headache, vomiting, diplopia, or any symptoms on signs of CNS involvement. It's just that the routine MRI has been done and there are brain mets. So are you interested in starting the treatment for these patients, or you want to wait? If the patient is symptomatic only, then you will treat, or you will take it in the tumor board and take an opinion of a medical oncologist as well, and then take a call of how to go ahead?
I will take this case in tumor board, and in my clinical practice, I prefer, if patient is symptomatic, then only I go ahead with palliative radiation therapy. If bone lesions are symptomatic, then for bone, or if brain lesion is symptomatic, giving headache, nausea, vomiting, convulsions, then I will prefer palliative radiation.
Does it matter where the lesion is in the brain? For example, this is the frontal lobe, so maybe you can wait and watch.
Yes,
but
sir.
Suppose if it's in an area where there are critical centers, are you inclined towards radiating,
Yes,
not
if
to
it is-
wait for the symptoms and
Yes,
just
sir.
start?
It depends on the location. If it is in critical location, then I will prefer starting upfront before the symptoms.
Dr. Shruti, is she there? Okay. Dr. Kshitij? Dr. Gaurav? Any medical oncologist here? Yeah, please. Are you comfortable sending the patient for radiation, because this patient has landed up with you, and these are or you'll wait for the molecular reports and then take a call how to go ahead?
No, sir, I will definitely send the patient to the radiation oncologist.
So for example, this patient turns out to be an ALK positive. So what is your call? I mean, will you still? Yeah, please.
I'm a radiation oncologist.
Please.
So as you said, this is in the right frontal region, and I presume it's in the non-dominant hemisphere. If the patient is right-handed, I'm just presuming. And if it's asymptomatic, and if we have good the IHCs and with regards to ALK, we can wait. The size is including the edema, right? So
Right.
if the size is close to 1 centimeter, this is what the guidelines are also. If asymptomatic, and if we have good targeted agents which can cross the blood-brain barrier, to put it in simple sort of way, we can wait. If I had to give radiation to this patient, I would have given, and since the patient is systemic therapy naive, I would like to give just radiation to this region and not to palliate. I would have been slightly more radical and focused onto this lesion itself, if I had to give, but I would like to wait, as I said.
Yeah, but because if the patient turns out to be an ALK positive, then I may not radiate. I mean, this patient goes on. Okay, fine. So this is the report what we have of the molecular status. People call this as a Janam Kundli of the tumor. So anybody. I mean, I think I just have one panelist as a medical oncologist. Yeah, please, madam, take it.
So this report says that all mutations are negative, right? If I remember.
Sorry?
So can you tell me the reports?
So there is no
All
pathogenic mutation
mutation,
detected in
right?
EGFR, MET, BRAF and ALK genes. No fusions with ALK and ROS1. PDL1 is less than 1%. So are you comfortable with this? Is that enough, or you want some more details? Because in clinical practice we usually do a limited panel. So are you okay with this?
So this is including the PDL1, right?
We have a PDL1, yeah.
Which is negative.
So that's okay with you. Is there any chance that you want more information because your treatment might change other than this?
So then, so this is comprising, I mean, I cannot, sorry, see the whatever are done actually, but if it is comprising EGFR, ALK, ROS, MET, the MET skipping exon, the HER2, I think RET mutation, NTRK123, because these are all which are available as therapeutic targets in India very easily. So beyond these 4-5 that you just mentioned, if you can do furthermore, and if you can find some clue, then we can give something orally. And so basically, for the brain lesion, there's no need of radiation because patient is asymptomatic. But considering the extensive involvement of the disease, I would definitely start off the chemotherapy while I await some mutation reports to help me out. What one says is doing a complete, the CGP, the comprehensive genomic panel, gives additional information rather than if we don't get in these, first few markers, then we can do a comprehensive genomic panel and that could guide us further.
And do you order both liquid as well as the tumor panel, or you're okay with the?
I'm okay with the solid, and only if the patient is very young, especially if the patient is non-smoker, then if I would want to find out any genetic hereditary findings, then I would think of doing those kind of tests.
Dr. Anuradha, your take on this, I mean, are you okay with such a small panel, or because we don't understand much about the profiling, so do you think a CGP is always to be done, or a spot panel is also okay?
Is definitely not sufficient because along with that we need to look for other fusions as well, like NTRK and all what has been mentioned. And main is the TP53 what is missing over here, because which is again a prognostic indicator whether it's going to respond to the treatment or not. So not CGP, but at least 15 to 20 gene panel which be a compiling of prognostic indicators along with the driver actionable mutations. That's what.
So I feel, practically, what is the point in doing the panels where we don't have the drug which is available?
Exactly. So CGP is definitely where around 200 genes and all is not sufficient. But yes, for the futuristic point of view, and if the patient is affordable, definitely we can go for the CGP, definitely.
Dr. Anup, your take on PDL1? This is less than 1%. I mean, is it possible that the patient must be having, like the picture which I have shown, that the tissue is taken from an area where unfortunately the PDL1 expression is less?
Absolutely. So this could be very well the scenario. So this limitation always exists when we are doing tissue testing and the genomic profiling. And regarding the previous point where you pointed, like what's the point doing additional genes? So there are two things. One is tumor pathway is very complex. We are just trying to started to understand it. That is one. And even when we are doing a comprehensive gene panel, or say for a limited panel, we need to look at the aspect, okay, from the lab point of view, whatever testing has been done. Say if they are saying we are doing RNA-seq, so is it open-ended, like whatever it is there, they are screening and giving you the report, that's one, that is more comprehensive. Or second, only targeted RNAs they are doing, because then you are missing out on things. So even when they are saying comprehensive, is it truly comprehensive? And even if they are saying they are doing a limited panel, say 5 gene, 20 gene, is it open-ended, like whatever is variations are going to be there that are going to be picked up, or only pinpoint where it is customized to pick up only few targeted variants, only those are going to be picked up, because that also is going to make a difference on interpretation and your management. And most importantly, such variations are becomes important when you're going to prognosticate the patient.
So, I mean, this is the NCCN guidelines, which is the minimum panel. What should be done is an EGFR, ALK, KRAS, ROS, BRAF, NTRK, MET, skipping, RET, HER2, and PDL1. So, like Kshitij said, we belong to an era where this was the curve. Whatever you do, it really didn't matter. Any chemotherapy protocol you try, the OS is not going to change. So I think the things have changed a lot from this particular thing to the specific histology, non-small cell being then treated as squamous and non-squamous. Then further molecular pathology reports were important using targeted therapy, and then came the role of immunotherapies. And now obviously we are thinking of ADCs in the future. So medical onco colleagues, what would be your line of treatment? Chemo, IO plus chemo, IO plus IO, chemo plus VEGF inhibitors, and dual IO plus chemo.
In this setting, sir, I will go ahead with the chemotherapy and along with IO, or as we know in my practice the patients are mainly non-affording, so I will go ahead with the chemo and tislelizumab.
Chemo and?
Tislelizumab.
Okay, so chemo and IO basically. So you would like to go for chemo plus IO. So for PDL1 which is negative, we look for the combination. Single agent is mainly for the PDL1s which are high. So lot of immunotherapy options. We have Pemro, Atezo, Nivo, then we have addition of CTLA4. So let's see the practical problems what we face with. As per the PDL1 expressions, we have different options which are available. If we get an additional mutations like KRAS, STK11 and KEAP1, is our plan going to change? And we have a surgeon who will take this call. What if this patient is surgically resectable lung tumor with solitary brain mets, amenable to SRS, or maybe the neurosurgeon says, why not me?
Yeah, definitely amenable to surgery. We would keep in mind a consideration for surgical resection given the young age of the patient.
However, will it change as per the nodal status as well if you have N3?
Definitely. If we are looking at a primary which is early stage, if you are barring the oligometastasis, then only we would consider surgery in a oligometastatic scenario in a young fit patient. But if there is a locally aggressive disease with a nodal burden of, I would even go to the extent of bulky N2 disease is also somewhere I would reconsider with a brain metastasis. We'll first then consider neoadjuvant chemotherapy, see how the natural history of the disease is progressing, and then consider anything as radical as neuro plus lung surgery.
Dr. Pranav, neurosurgery or SRS?
I think since it's a solitary lesion, if you mentioned
solitary,
yes, I would still like to go for a neurosurgical opinion because that will give us tissue information and then subject it to as per the two trials which were done by Dr. Brown and Dr. Anita Mahajan. But if it is resectable, even in the brain, it should.
My MedOnc colleagues, the other factors which are there: disease burden, symptoms, performance status, histology, history of autoimmunity because you are planning an IO, other comorbidities, patient goals and preferences. Patient says, I don't want chemotherapy, or he says, I want a short course of chemotherapy, or says there is no finances for immunotherapy. So all this, I mean, this is day-to-day problems what we see. So your take on these factors. Suppose there is a disease burden, patient says, I don't want chemotherapy. Are you comfortable? High disease burden.
No, sir. I still convince them for chemotherapy, definitely, because we need to prognosticate as well. We cannot go ahead directly with the neurosurgery. For that, we need to reduce the disease burden and we need to give him the symptomatic benefit first. For that, I will still convince him to go ahead with the chemotherapy.
Okay, my other colleague, what about KRAS? KRAS, STK11, KEAP1.
So currently,
will that change your line of treatment?
So currently we don't, I mean the sotorasib is very expensive and we have to.
But that's in second line anyway.
Yeah, second line. So bevacizumab can be used in such mutations, and so definitely we have to convince the patient with an extensive disease to undergo chemotherapy, and bevacizumab can be added in KRAS mutations to enhance. Plus, if they are not planning on any IO or then definitely chemotherapy is, and the subsequent whatever targeted therapy that we can get from the molecular testing, that could be pushed.
So I think these are the mutations which has got a poor prognosis. So they don't do well on single chemotherapy, or we have to have a dual treatment of IO plus chemotherapy. When you are talking about a PD-L1 negative, obviously the single agent IO is not an option, but you have different combinations of IO where this can be used. You can avoid chemotherapy with Checkmate 227. Checkmate 227 is there in the NCCN guidelines, but it is not approved by FDA. It's still there in the guidelines, and there are excellent results which I will just go through. Then Checkmate 9LA, where there are only 2 cycles of chemotherapy, you can get away with 2 cycles and then continue with immunotherapy, CTLA-4 plus an IO therapy. Then we have Posidion protocol, which has recently come up. So this is Checkmate 227, which has dual IO. In a PD-L1 less than 1%, you have dual IO, then Nivo plus chemo and chemotherapy. And that is the result. If you can see in PD-L1 negative, the median OS is around 17 months compared to chemotherapy of 12 months, which is significant. If you look at the histology, still in non-squamous, the Nivo plus EP combination without chemo does better than that of chemotherapy, but you can see an early crossovers which we need to be careful with, and that is the reason why 9LA came into picture. But this is a very interesting curve. So what happens to the patients who achieve CR or PR at the end of 6 months? So if you see the graph, it starts from 6 months onwards. So those are the patients which had done well on this protocol Checkmate 227, and those were followed up. So those patients who did well at the end of 6 months with CR and PR, you can see the 3-year survival of almost 82% in the patients with PD-L1 less than 1%, that's PD-L1 negative. So I think though this is a selected patients, this is a selected group of patients who are doing well, or you can say good prognostic, but however you can see a long-term control of 3 years of almost 82%. This is a 3-year update, and which clearly shows that the dual IO without chemotherapy does better in these patients of PD-L1 less than 1%. So when we add chemotherapy to the immunotherapy, there are many reasons why this combination is supposed to do better as compared to single agent treatment. And the hallmark of this combination is to have a long-term benefit with less toxicity and improve the treatment-free survival with a good quality of life. So because of the experience from Checkmate 227, CTLA-4 protocol was designed. I think more details will be discussed by Chetan later, Dr. Chetan. This basically randomized patient into dual IO, where EP was given 1 milligram per kg every 6 weeks, while Nivo was given every 3 weekly, along with chemotherapy for only 2 cycles. And the other arm was chemotherapy 4 cycles, and if there is pemetrexed, it was continued further. IO combination was given for 2 years. These are the early results which were published in 2020, which showed a better OS. And if you look at those with PD-L1 negative, there is a definite improvement in the overall survival in the patients which are PD-L1 negative. So the main problem what we think of dual IO is the toxicity. Any of my MedOnc colleagues has used dual IO in their practice?
Yes, I've used it very routinely for RCCs, and Nivo EP per se gives very quick and symptomatic responses even in the metastatic clear cell.
What about the toxicity?
Very early in the course, thyroid related toxicity come, and they are very common, and but otherwise long term we can have adrenal crisis and adjacent manifestating, and so occasionally one does have pulmonary toxicity, but that's not too common with this combination.
So we do expect more toxicity with dual IO, but however, there are many studies which have shown that those patients who have treatment-related adverse events with dual IO do better as compared to those who don't. This is a long-term data of the same. I will not go in the interest of the time. This is Keynote 189. Again, we know the use of IO with chemotherapy. This is the long-term 5 years data of the same. This is the pooled data of 3 Keynote studies to see what happens in PD-L1 negative patients, and this shows that the OS is better in the combination arm as compared. Important now is to discuss about the STK11 and KEAP1. I think we should try to do this because these are the patients which do not do well on treatment. So it is important for us to see the tumor mutation burden as well, because those patients with tumor mutation burden high with the wild type STK11 and KEAP1 do better as compared to that with the mutation and tumor mutation burden low. So if we know all this upfront, then we can predict the prognosis and the line of treatment in these patients. Also, the KRAS positive patient, old slide of 2020, there is a recent publication in Annals of Oncology this year, which shows that the 5-year OS is to the tune of around 18 to 20% in squamous and in non-squamous. So it is as good as those with checkmate 227 as well. So dual IO is the way to go ahead. This is another dual IO with chemotherapy. The chemotherapy cycles are 4. The CTLA4 treatment is 5 cycles. So the chemotherapy are little more as compared to 9LA. However, the CTLA4 treatment is less. And the long-term benefit in non-squamous is seen as compared to that of chemotherapy only. And what is important is they have done a sub-study to see what happens to the patients with KEAP1 and STK11 along with KRAS. And they have seen that those patients with mutation do well with dual IO along with chemotherapy versus only chemotherapy. So these are the poor prognostic patients, and they are supposed to be doing well in combination arm as compared to that of only chemotherapy. Whether it is a KRAS mutation, whether it is STK11 and KEAP1. So the current paradigm of immunotherapy in advanced NSCLC without any actionable mutation, if you look at PD-L1 less than 1, is IO plus chemotherapy, or IO plus chemotherapy, or a dual IO only without chemotherapy. So this patient was started on 3 pemetrexed and cisplat. Post 3 cycles, patient received PR, continued 6 cycles of maintenance with PEM, stopped anti-epileptics on her own, had a breakthrough convulsions in March 23. So till then she was not given radiation. She continued pemetrexed because she was reluctant for radiotherapy, had convulsions in May 23, whole brain radiotherapy was given. And this is the response, the first and the second PET scans after 6 months. So disease progressed in November 23, rebiopsy was done, NGS was done, now we did on the block as well as liquid, and this is the report. Dr. Anuradha, your take on this? She was EGFR negative to start with, now she is EGFR positive. EGFR positive.
Yeah.
Del 19.
Definitely. So EGFR exon 19 deletion is the way to go for the treatment, because it's
no, the question is she was negative to start with.
If EGFR was negative.
She was negative to start with, now she is positive.
Okay. So earlier by which method was it done?
NGS.
Both the time?
Both the time. But the lab was different. Okay. This is another lab. You can see the pattern of reporting.
Okay. And on the same tissue?
No. This was repeat biopsy which was done this time.
Okay. The first time, second time it was on the repeat biopsy.
Correct.
So definitely there are chances. The lab is, we can't blame the lab. But since it was on the repeat biopsy, on a different biopsy, we have missed the earlier. EGFR must have not been positive because of the heterogeneity pattern. And now the repeat biopsy, we must have got the EGFR positive status.
Okay. So according to you, it must be there in the beginning as well, but it was not picked up because of so many reasons what we have. Dr. Anup, your take on TP53?
Again, initially it was not there and now it is there.
Correct.
So again, for prognostication purpose, and again same thing, tumor heterogeneity, different blocks from where you are doing NGS. So that has its limitations. So if liquid biopsy, that could have been done earlier and now, comparison would be more, it will be more comparable compared to just the tissue NGS. So that is something, one option that can be explored in such a situation.
My madam colleague, any other option they would have given other than putting them on osimertinib? Or are you okay?
Yes, sir.
Okay. So, because FLORA2 is not applicable at this situation. I mean, with the brain mets, you would always like, with TP53, you would like to go for a FLORA2 regimen, but that's upfront. Now, this is the patient who has progressed on first line treatment. So, in April 25, she had a progressive disease. We did a rebiopsy. The rebiopsy didn't show anything different. There was additional PIK3CA which was seen. So she was started on ABCP regimen till July 23. Then she said that she would like to go for some naturopathy treatment, 2 months of stopping of treatment, and she progressed in lungs and developed pain at bone metastatic site. Bone lesions were radiated, and she was put on weekly docetaxel. And I think what I could see now is that she is in the best of her general condition on docetaxel with all the treatment what she has received. Any last comment from my panelists regarding any additional information would you like to give, and then we'll close this discussion.
One thing I would like to, as Dr. Anup mentioned about the liquid biopsy, yes, initially itself we should collect the blood sample. Correct. And keep it, whether we do it or not, but the plasma separation is very important. In future, it may require to do this study.
Yeah, what you are saying is right. I agree with that. But in clinical practice, that is difficult when there is a patient in front of you to the cost factor and everything comes into the picture when you are ordering this. But I take it. I mean, it's always better to have both the samples. The liquid as well as the. Yeah, please.
Just to add to it, like in germline testing, we have something known as DNA banking. So maybe we can work out with the lab where we can just extract the plasma and keep it. So that can be safeguarded, and as and when needed, at least that option is available in future if you want to go back and compare.
So okay, point well taken.
That can be a way going ahead in limited setting.
So not necessarily we should do the NGS initially.
Just keep it for the future.
On the biopsy, there is no need, but then the grammar, the whole grammar changes, so it is better to have the. So
I mean, in clinical trials, we are doing that for every patient. We have the tumor, we have the blood sample. They take everything upfront. They take the consent for future tests also. So that is routinely done in a clinical trials. But in clinical practice, at least I am not doing. My colleagues would, if they like to differ, they are most welcome. Any other comments from anybody else?
I think if there was no actionable target agent at the onset, then radiation should have been given to the brain lesion. With this case,
but she was asymptomatic, I mean, to start with.
So even if she was asymptomatic, she was given anti-epileptics.
That's prophylactic.
No, that is again so as to prevent that. That is what the whole concept of brain radiotherapy. And if there was no actionable sort of agent which could have crossed the blood-brain barrier, I repeat myself, then radiation should have been given, which wasn't. That's
okay, point well taken. So I think with that we close our panel, and I thank my panelists for a wonderful discussion and thank the organizers for giving me this opportunity. Thank you so much.
Thank you.
Thank you, Dr. Shailesh, and thank you, our panelists. We now shift focus to head and neck oncology with a talk on head and neck cancer awareness and role of Keytruda in the treatment of HNSCC patients. Please welcome Dr. Sneha Bothra, Medical Director and Consultant, Chhattisgarh, to present. This session is sponsored by MSD.
So, good morning everyone, and thank you MSD and thank you MOC for having me here and for this opportunity. So, we will be discussing about the role of IO and its sequencing strategy in the management of head and neck squamous cell carcinoma. So, just to begin with, the burden of head and neck cancer in India, it is the second most common cancer in our country. So with a huge burden of disease, these patients usually present in a locally advanced stage, and the projected numbers continue to increase because of the increasing use of alcohol and tobacco in all forms. So the relative proportion and clinical extent of disease at the time of diagnostic, as we all know, it is beyond the TNM staging. They are localized in a few patients, in a 1/4 subset of patients, and loco-regional and metastatic disease in the most common presentation in these patients. And if we go across the tumor subtypes of tongue, mouth, oropharynx, hypopharynx, nasopharynx and larynx, most of them are usually in the locally advanced disease. Now, the basic modality of treatment for head and neck cancer is surgery, systemic therapy, radiotherapy. But most of our patients, they require multimodality therapy because these are advanced patients. So about 46% patients in distant metastasis, loco-regional, localized disease, they all require multimodality therapy. Now coming to the basic survival of these patients who are advanced, recurrent or unresectable diseases who are not amenable to any other therapy, it is dismal with about 7 to 8 months with any standard line of therapy initially before the immunotherapy came into picture. So the overall survival with taxane platinum was 7.1, with cetuximab platinum was 8 months, and platinum 5-FU was also 8 months. So overall the prognosis and the outcomes have been dismal. So what changed? These are the guidelines from the head and neck cancer, the NCCN guidelines. The initial agents now have shifted from chemotherapy to chemo-IO, that is 5-FU carbo or 5-FU cis with pembro in all subset of patients, and in subsequent line if the IO has not been used, nivo or pembro. And most of these patients, if we don't have an access to these agents, then cetuximab chemo or I would say chemo alone, or single agents like capecitabine, carboplatin, cisplatin, docetaxel, and in subsequent lines, depending on what has been the first line, the agent is chosen. So this is the ESMO 2020 guidelines, and as we see, nothing particularly has changed over the last 5 years in head and neck cancers. So even in 2020, the ESMO guidelines said that if no platinum-based chemotherapy in the last 6 months and PD-L1 positive tumors, then pembro monotherapy or pembro plus platinum 5-FU. And this continues to be the standard of care for most of our patients. So now coming to the practice-changing trial, Keynote 048, which was a phase 3 study of first-line pembrolizumab for the recurrent or metastatic head and neck cancer patients. Now this was a trial in 2018, and it had the eligibility criteria of oropharyngeal, oral cavity, hypopharynx and laryngeal cancers, recurrent disease or metastatic disease incurable by local therapies. ECOG PS0 or 1, tissue sample for PD-L1 and known P16 status, and they were stratified by PD-L1, P16 and the performance status. They were randomized 1:1 in 3 arms, pembro monotherapy, pembro plus chemo versus the extreme group, that is the cetuximab plus 5-FU, cis or carbo. So now they were stratified. The study endpoints as per the stratification was OS and PFS in CPS more than 20 and CPS more than 1 and total population. That was the primary endpoint. The secondary endpoints were PFS rates at 6 and 12 months, the overall response rate and change from baseline and time to deterioration in quality of life, and safety and tolerability in all population. The key exploratory endpoints were in the CPS more than 20 and CPS 1 and total in the all population, the duration of response. So now the baseline characteristics were well matched with the median age of about 62 in the pembro arm and the pembro alone arm versus the extreme arm of 61. Most of the characteristics are well matched. Major predominantly patients were male patients with a good performance status, and they were mostly current or former smokers. P16 positivity was in 20%, and PD-L1 status, if we see, the TPS of more than 50% in about 22% patients in both arms, CPS more than 20 in about 44 versus 40%, CPS more than 1 in about 85% patients in both the arms. Most patients were metastatic, about 71% in the pembro alone arm versus the extreme arm. So now we'll divide this discussion into two groups, that is initially the pembro alone arm versus the chemo cetuximab arm, and the second discussion will be on the chemo plus pembro versus chemo plus cetuximab. So coming to the progression-free survival data of Keytruda versus the extreme group, the PFS was 3.4 versus the 5 months. As we see, we have a initial early crossover where the initial responses were low, with a median PFS about 3.4 months versus 5 months in these groups, 3.4 in the Keytruda arm. But at 12 months, if we go to see, it was 22 months in the pembro arm versus 12.4 in the pembro arm, in the cetuximab arm. In the CPS more than 1, the median PFS was 3.2 versus 5. But at 12 months, it was 19.6 versus 11.9, 19.6 in the pembro arm. So the OS, again OS at the median OS was 11.5 versus 10.7, the pembro arm being 11.5 with the hazard ratio of 0.81. At 12 months, it was 24% patients who survived versus 19.1 in the chemocetuximab arm. And OS, if we go by the stratification of PDL1 more than 20%, the median overall survival was 14.9 versus 10.8% in the pembro arm versus the cetuximab plus chemotherapy arm. And if we go to see by the CPS more than 1%, pembro was 12.3 versus 10.4 in the chemocetuximab arm with a hazard ratio of 0.71, which is statistically significant. Now coming to the duration of response. Now the duration of response had a significantly improved numbers. Like in the pembro arm, the overall response rate was 16.9%, but the median duration of response was 23.4 months versus 4.5 months in the cetuximab chemo arm. And the same thing if we go by the CPS, in CPS more than 20, pembro had about the duration of response of 23.4 versus 4.2, and in CPS 1 more than 1, it was 24.8 versus 4.5 months. Now the treatment related side effects, as we expect in the pembro alone arm, was significantly less as compared to the chemocetuximab arm, with any grade events being 58.3 versus 96.9% in the chemocetuximab arm. Discontinuation rates were low, was 1% in pembro arm and 2.8% in the extreme arm, and treatment leading to discontinuation was about 4.7 in pembro arm, but about 20% in patients who received chemocetuximab arm. Now coming to the infusion and AEs according to the immune mediated adverse events, any grade was 30.3 in pembro and 23.7 in the extreme arm, but the grade 3 and 5 events were significantly less in the pembro arm, that was 6.7% versus 10.5 in the chemocetuximab arm. Now coming to the second part of the discussion, that is the pembro chemo arm versus the cetuximab chemo arm. Now pembro plus chemotherapy given 6 cycles every 3 weeks, followed by pembro up to 29 cycles, and cetuximab plus chemotherapy every 3 weeks, followed by cetuximab weekly. Cetuximab was weekly initially and later on as well. Now coming to the progression-free survival, the PFS was, median PFS was 4.9 versus 5.1 in the Keytruda plus chemo versus the cetuximab chemo arm. But at 12 months, it was 16.7 and 12.1% in the patients who received pembro. Now, coming to the overall survival, the median overall survival was 13 months in the Keytruda arm, Keytruda plus chemo arm versus cetuximab and chemotherapy, which was about 10.7 months, with a hazard ratio of 0.71 and p-value of 0.00008. And if you look at the 12 months and the 48 months rate of the OS, that was about 29% patients in the Keytruda plus chemo arm versus about 18% in the extreme arm. But at 48 months, that is at 2 years, it was about 20% patients still survived versus 4.5% in the chemo plus cetuximab arm. Now, by stratification of CPS more than 20 and more than 1, the median survival was 14.7 versus 11.1 in the CPS more than 20 with a hazard ratio of 0.62. we see a good hazard ratio in both the groups, that is CPS more than 20 as well as CPS more than 1. That was 13.6 versus 10.6 for the cetuximab plus chemo arm. So the hazard ratio is like 0.6 in both the arms and with a significant p-value. So now coming to the duration of response, in the duration of response, the overall responses were similar, that is 36.3% in both the groups, with a median duration of response of 6.7 months in the chemo plus Keytruda arm versus 4.3 in the extreme group. Now coming to the duration of response stratified by the CPS, in CPS more than 20, the duration of response was 7 months in the pembro chemo arm and 4.2 months in the extreme group, versus the in CPS more than 1, it was 6.7 versus 4.3. Now coming to the adverse events were similar in both the groups. Any grade was about 95.3 versus 96.9. Significant grade 3 and grade 5 adverse events in both the groups, and there was significant discontinuation in both the groups. Now immune mediated adverse events were again 25.7 versus 23.7% in both the groups, and discontinuations were more in the cetuximab arm. If we look at the major differences in the adverse events, it was majorly hypothyroidism in pembro arm versus infusion reactions in the cetuximab arm. Now coming to the safety and summary, for pembro alone arm, safety has been better, that there have been less adverse events versus the extreme arm, but in the pembro plus chemo and the cetuximab plus chemo arm, it has been similar. So in long-term follow-up of confirmed statistically significant improvement in OS for pembro versus the chemocetuximab arm in PDL1, CPS more than 20 and CPS more than 1 population. Pembro plus chemo versus extreme in PDL1 and PDL1 more than 20, CPS more than 1, and in all groups. DOR, that is the duration of response with pembro or pembro with chemotherapy, remained longer with the as compared to the extreme arm, and safety was favorable for pembro versus extreme and comparable for pembro plus chemo versus extreme. So what will be the appropriate sequencing for head and neck patients in the recurrent or metastatic settings? So now this is the PFS2. Now PFS1 was the first that we saw, and PFS2 is defined by the time from randomization to objective tumor progression on next line treatment or death from any cause, whichever occurs first. So this is recommended for usage when OS cannot be measured for clinical or financial reasons, to assess the clinical benefit of agents that do not induce much responses, to assess the efficacy of maintenance therapy, to assess majorly the impact of crossover on the OS assessment, and to assess whether therapy positively or negatively affects the efficacy of the next line therapy. So we are discussing the PFS2 of this group of patients who had progressed on the pembro or chemo arms. So this was the first line subsequent therapy following the progression to pembro chemo or cetuximab, and subsequent therapy was investigator's choice. Now if we look at the subsequent therapy, any new anti-cancer treatment was received only by 50% of the patients. So the rest of the 50% patients did not end up receiving any therapy. So first line therapy becomes the mainstay of treatment for these patients. Now chemotherapy was used in 44.9% in the pembro monotherapy arm versus 88% patients in pembro plus chemo, and about 34% patients in the extreme arm. Immune checkpoint inhibitors were used in about 16.7% patients in the chemocetuximab arm at crossover. So if we look at PFS2, the PFS2 in CPS more than 20% patients median was 11.7 in the pembro arm versus the 9.4% in the chemocetuximab arm. But at 12 months and 24 months, the PFS2 was significantly better. Now for initially randomized CPS more than 1% patients, the median PFS2 was 9.4 versus 8.8 months. Now Keytruda plus chemo versus extreme, median PFS2 was 11.3 versus 9.7% patients, 9.7 months, and in CPS more than 1% population, it was 10.3 months versus 8.9 months. And the total population, it was 10.3 versus 9.9 months. Now, to conclude, Keytruda significantly improved OS versus extreme, that is the cetuximab chemo arm in the PD-L1 CPS more than 20, CPS more than 1, and in all populations. No PFS benefit for Keytruda, although Keytruda had lower overall responses were substantially more durable. And Keytruda monotherapy versus extreme, PFS2 was longer for favorable safety profile over extreme, and data supports the use of Keytruda monotherapy as a first-line standard of care for patients who express PD-L1. Coming to chemotherapy plus Keytruda versus extreme, the patients with Keytruda plus chemotherapy improved OS significantly in the total population, although no PFS or ORR benefit for Keytruda plus chemotherapy, but OS was significantly better and PFS2 was also better for these patients. Safety profile is more or less similar. So data supports the use of Keytruda plus platinum-based chemotherapy as the first-line standard of care for these patients. Thank you. Thank you for your patient hearing.
Thank you, Dr. Sneha. We now move on to our next session titled Breaking Frontiers in First-Line Metastatic NSCLC. I request our video team to kindly pause the recording for this session. This session is sponsored by Bristol Myers Squibb. I would request Dr. Chetan Deshmukh, Consultant Medical Oncologist, Pune, to moderate the discussion. I also invite our panel, Dr. Mangesh Mekhak, Senior Consultant Medical Oncologist, Pune, Dr. Nikhil Shirsi, Consultant Medical Oncologist, Pune, and Dr. Sachin Hingmire, Consultant Medical Oncologist, Pune, to join us.
Ashwin, come. Good morning, everybody. I'm back here on the last day of conference to discuss something a little unusual. Typically for metastatic disease, chemotherapy is always a given. This is one of its kind study where we are trying to move away from chemotherapy. Again, this is a session sponsored by Bristol Myers Squibb. The slides belong to BMS, and I have my 4 extremely enthusiastic, dynamic colleagues tempered with experience who will take us through this presentation. So, breaking frontiers in first line. Traditionally, chemotherapy has been the backbone of any advanced disease. But with the advent of biologics, we are now moving towards chemo-free regimes in several illnesses, not only in lung cancer, but several illnesses. So for this, lung cancer has been the poster boy for immunotherapy. So when you decide immunotherapy, let me begin with Dr. Mangesh. How do you decide your patient? What are the important factors you look at?
First of all, patient's histology.
Of course.
And if the patient is having a driver mutation or not, that we have to rule out in non-smoker, in squamous cell carcinoma as well.
Absolutely. So if
then
you have a driver
mutation, then PD-L1 status.
Yes.
Then again, the patient's pre-existing, like any autoimmune disorder, if the patient is suffering from.
So comorbidities.
Comorbidities and burden of disease as well. Performance status, age. So multiple factors we'll consider.
Yeah, so they are all listed here. Dr. Ashwin, he said, he mentioned about PD-L1. When we are dealing with lung cancer, tissue is always the issue. You have a small bit of CT guided biopsy, and then you want to test it for only selected things. You cannot often do multiple tests. So if you have a patient whose EGFR Al-cross is negative, do you wait for a PD-L1 to start treatment, or you can go ahead with the...
I think if mutation is negative, we can definitely go ahead with chemo-IO combination. But
you are okay to...
yeah, but only if we are considering single agent chemo or single agent immuno, then maybe PD-L1
you may need PD-L1.
Is required, but very less often because of the type of disease. Lung cancer is aggressive, symptomatic patients, very less often. I have seen single agent immunotherapy.
Sure. So we are going to discuss that you want to avoid chemotherapy. Is there a role where you can avoid chemotherapy? How about response rate? A lot of these drugs are giving excellent response rates. Dr. Nikhil, how important do you feel, or you feel that no matter what the response, if the drug is giving survival benefit, that's good enough?
Definitely, survival is one of the important endpoint we are searching for. But obviously, response rate we are looking, and IO combination has always shown better response compared to only chemotherapy. So if we don't have PD-L1 report, so there will be option. Usually, in practice, I start with chemotherapy, and after PD-L1, we'll decide. If PD-L1 is very high, then definitely we'll choose for.
So you begin with one modality.
Correct.
And then. So Sachin, is there a group of people where you absolutely want chemotherapy? Of course, you have a PD-L1 of say 55, 60, EGFR all-cross negative, but you want chemotherapy. Is there a group where you would prefer
Absolutely. If the tumor burden is huge, and most of the lung cancer patients will have very distressing symptoms.
Yes.
To relieve them from the symptoms, we need to have a good response, a good control over the cancer. In those patients, it's definitely mandatory to have therapy which will give us a better response rate, and obviously the survival is important.
Definitely. So this was let us begin with a case, a 65-year-old gentleman who's presented with fatigue and breathlessness. He's been an active smoker, hypertension, and he's got some dyslipidemia. His chest X-ray showed an opacity in the right lung, and a CT scan also confirmed the same with multiple other lesions. There is pleural effusion, small nodules in both lungs, and the PET CT shows that these lesions are FDG avid. There is no brain or bone metastasis. So Dr. Mangesh, you have such a patient coming to you in the OPD, largely lung related disease, multiple nodules. Do you screen for brain mets at diagnosis, or you do it if only he or she has symptoms?
Only in symptomatic patients as of now we are searching for active brain metastasis, because presence or absence of asymptomatic brain metastasis doesn't change our management.
Fair.
That's why.
So this gentleman underwent a biopsy. The mediastinal node biopsy showed an adenocarcinoma, TTF1 CK7 positive, and negative for any actionable mutation, and the PD-L1 expression was less than 1. So traditionally not a PD-L1 enriched tumor, and these are your options for this patient. So Ashwin, you have 4 options. Maybe the panelists can just take whichever option they feel comfortable.
So IO plus chemo.
IO plus chemotherapy. Any takers for 9LA because that has only 2 cycles of chemo, or any takers for only chemotherapy and leave PD-L1 for later?
So 9LA is also an option
Okay.
which we can offer, but again the age being 65 means I normally prefer giving it in more younger, fitter population.
I'm sorry, age?
Age being 65, I still.
But he is otherwise a fit gentleman, so.
I would still go ahead with
Fair. You see, your comfort level is of course important. How you are going to deal with the patient. Dr. Nikhil, Sachin, any difference of opinion?
IO as PD-L1 less than 1, IO with chemo, or even that EP and Nivo option is there. Combination is
so
also
double,
there with cycles, with 2 cycles of PEM.
So basically, combination is must. That is what we would agree to. Combination of IO plus chemo. Now, whether the patient is able to tolerate the toxicity of chemotherapy or the toxicity of a dual IO is the one that maybe have some implication on the decision making. That is one. Unfortunately, there is no head-to-head comparison between IO plus chemo versus IO plus chemo. All the trials have compared with chemotherapy, and both of them have shown better efficacy as compared to chemotherapy. So both options are valid, IO plus chemo or IO plus chemotherapy. Then, as I said, the toxicity profile is going to be different. And then, basically, as a comfort, now we have been using IO for quite a number of years. It's been the comfort with IO chemotherapy which has driven our practice right now. The more and more we'll be using IO combinations, I think the things will be better, and we'll be able to manage the toxicity of IO also. IO as well as better.
Let me come back to the statement which you made. You are worried about toxicity. So which are the features where you feel that this patient may be a potentially troublesome patient as far as toxicity is concerned? This gentleman has minimal comorbidity, dyslipidemia, hypertension, which is reasonably well controlled. PEM carbo, all of us know that it's not so troublesome. So where do you feel that the toxicity angle comes into play?
So basically, as you mentioned, he's otherwise fit. So I'm not really worried about the toxicity of chemotherapy. Would you? I think everyone would.
Yes.
Agree. We are quite comfortable in managing the toxicities of chemotherapy right
Fair.
now. The discomfort lies with combination of IO-IO.
Okay.
Particularly that skin problem, which is quite common with IO-IO and diarrhea. I think as far as I would say for myself,
okay,
I would need a more exposure to manage these side effects better. I think over the time, even that will be there. As of now, although the toxicity is not will be high mortality or morbidity, but it's quite a discomforting toxicity. The skin toxicity is absolutely quite discomforting for the patient, and then unfortunately we do not have too many good options to control that. Apart from discontinuing the drug.
Discontinuing the drug. Fair enough. So let's go through this study where they have used this combination of dual immunotherapy. This is the Checkmate 9LA study. Let us discuss this study in details. The study had stage 4 or recurrent NSCLC who were essentially treatment naive with no sensitizing mutations. Good performance status, PS 0 to 1. To my panelists, how many of your patients of lung cancer present to you with a PS 0 to 1 out of 100?
25%.
25% are PS 0 to 1 and rest are PS beyond 1.
2, 3 like that.
But some of them must be changeable 2, 3, right? Somebody who has very bad breathlessness because of pleural effusion, you tap the effusion, the PS improves from 2 to 1 or maybe 3 to 2.
Yeah.
Right? So how many are at the end of basic intervention, how many are actually PS 0 to 1? Because ultimately we are going to look at toxicity. Toxicity is something we are all concerned about. And then if the performance status of the patient at baseline is going to be high, there's going to be a problem.
After baseline management, maybe around 50% of the patients
50%.
still will be in the 0 to 1 up to 2.
Fair enough. They did not require PDL1 as an eligibility criteria. All comers were taken, and a fairly big study, more than 700 patients. They were randomized to the combination of nivolumab, ipilimumab with chemotherapy for 2 cycles. Nivolumab in the dose of 360 mg every 3 weekly, ipilimumab 1 mg per kg every 6 weekly. And the chemotherapy was standard pemetrexed carboplatin with the option of pemetrexed maintenance, and this treatment was to be continued until disease progression, toxicity, or at least 2 years for 2 years of immunotherapy. So the number of courses given in consecutive cycle, initially of course the combination arm had 4 drugs, pemetrexed, platinum, nivo EP, and then subsequent cycles it was every 3 weekly, it was only PEM carbo or PEM platinum, and then nivo EP. That too, the ipilimumab the frequency was once in 6 weeks. So number of drugs were not too many, given for 35 cycles. Baseline demography fairly well balanced. As I said, most of these patients, all of these patients had a performance status up to 1. A sizable number of patients were smoking population. Do you find that similar to your practice, or you are looking at a fair amount of non-smokers as well? Because smoking is not so much of an issue here. A lot of our patients do come, and especially females, we see them who have this kind of a presentation, but non-smokers. Metastatic pattern, widespread, a significant population had, almost 20% population had CNS metastasis. Liver mets, again, almost in 20% population, which is considered to be traditional high risk because of their aggressive biology. And bone mets are quite common. Again, a third of patients had bone mets as well. PDL1 expression, very few people had PDL1 so-called enriched population, more than 50%, 24 and 22% only, and a fair number of population had a PDL1 less than 50%. Histological subtypes were again diverse, but we nowadays don't go much by the histology, we go more by the biomarker aspect. The overall survival, we have 5-year data, the overall survival in all comers at the end of 5 years was 15.8 months with the combination of nivo EP and chemo, compared to 9.1 with only chemotherapy. So the delta is almost 6.5, almost 6-7 months of extra life. The hazard ratio being 0.73. And at the end of 5 years, there are 18% people who are still surviving. I think that's quite, that's a sizable number. Do you feel this is good? Any of the panelists can take it. How do you look at this data? The tail continues to remain long. From a disease where the average survival has been 6 to 8 months, we are now talking about 5-year survival. So what do you have to say about it?
So,
yes, Nikhil.
So definitely, sir, the curve has separated from starting and it is maintained throughout the 5 years. And
yes.
Even after end of 5 years, nearly double the, means around 18% of patients are alive who are on dual combination IO with chemotherapy compared to with those with only on chemotherapy. That is significantly a good response on overall survival.
And this response is actually across all, this was for all comers. For patients who were PD-L1 low, traditionally people believe that less than 1% PD-L1 immunotherapy may not work. That's not the case. Actually, it's far better in the PD-L1 negative population or so-called low PD-L1. The survival figures are 17.7 versus 9.8. That's a big number. You know, at 5 years, 22% of PD-L1 negative population is doing well or alive, compared to only 8%, so almost three times the survivors. So how do we explain this? With traditional immunotherapy, we always felt that it was important. So do we really now see a shift from PD-L1? If you don't have any actionable genomic mutation, you are good. Doesn't matter what the PD-L1 is. Is that where we are moving? Any one of you? Sachin, Mangesh, Ashwin, any one of you?
Yes, sir. Means if actionable mutation isn't there, then definitely we offer most of our patients combination, or we tend to add immunotherapy because these patients.
Yeah, so we'll probably end up using more immunotherapy in this group preferentially.
Yeah, and PD-L1 is not a only marker. Means the PD-L1 itself is a heterogeneous marker. We have tumor infiltrating lymphocytes. We have TMB, which is high. So there are multiple other factors which may also decide.
Ironically, in the PD-L1 positive population, more than 1%, the OS proportion at 5 years was 18% versus 11%. So, of course, the PD-L1 low population was not very great, but nevertheless, it matches with the intent to treat population, but it still means that there is some benefit.
I have one question here, that events will be happening whenever the patient is on observation or follow-up data. Patient might be recurring or they must be receiving some other form of therapy.
Quite right.
So will that decide any outcome?
Of course. So this
because we don't have the details about that.
It's quite natural that if a patient who has received only chemotherapy, in the second line he may have received some immunotherapy. That is natural. But then it's going to balance out, right? In spite of that, we can't control it. The second line therapy is not controllable. We don't. These people who are good performance status, they may have received second line chemo, immuno, or alone immuno, whatever they may have received. They may have participated in subsequent trials as well. But still, the difference is still there. It's still being maintained.
Yeah, because surprisingly in PD-L1 overexpressors, more than 1%, it has shown lesser advantage over.
So possibly those 11% who are on the chemotherapy arm, who are surviving still 5 years, possibly these are the ones who have received second line immunotherapy.
Fair enough.
We never know.
Fair enough. Squamous versus non-squamous, nowadays we don't worry much about the histology, because once we have biomarkers, whether it is squamous, non-squamous, doesn't matter. But traditionally squamous carcinoma was one of the first indications for immunotherapy. The classic indication was squamous second line smoker, and in the squamous population again the benefit is very well marked. At the end of 5 years the OS percentage is 18% versus 7%. So again a good improvement in squamous. In the non-squamous not so much. Maybe in the subsequent lines the non-squamous people may have opted for something else. Squamous traditionally is not a very chemosensitive tumor and probably did better with the immunotherapy arm. Duration of response. I believe that in the metastatic setting, having a good response is important because that brings about symptom relief. So if somebody has a great response, yes, that the response being maintained, the patient is going to have a better performance status, a better quality of life. So response continues to be an important aspect, and at the end of 5 years, the duration of response was 19% in the combination arm versus it was quite low in the non-chemo arms. Probably those patients, and again in the patient population where the PDL1 was less, the duration of response was maintained in 25% of the response was maintained in 25%, whereas 0% in the comparator arm. So that remains. So your thought, Sachin, that immunotherapy is going to give you a good response.
So this is actually the most attractive part, because see, after 2 years the treatment would be stopped.
Correct.
And that means
that response is maintained till 5 years.
3 years, patient is maintaining the response without any active treatment.
Correct.
That's the beauty of.
That's the beauty of this. Absolutely agree.
That is unexplained, because events will be happening, and whether the patient is on treatment or not, that we don't know.
But that.
Experimental. Okay.
Yeah, experimental arm, the treatment stopped at 2 years, right? So again, for patient population more than PDL1, the difference is still there, but it's being maintained. So, what was your expectation when they must have presented 9LA study? What did you expect from this study, where there are only 2 cycles of chemotherapy, a combination of Nivo-EP? What were you looking at when somebody came and told you about this study? Mangesh.
I thought the priming with dual immune checkpoint inhibitors must have initiated greater immune response, and initial chemotherapy was added just to symptomatic control, and afterwards the IO combination must have taken over for further responses.
Maybe. What matters to you? I think all of us have answered this question, that both are important. Response is important for the symptom relief and quality of life. Survival, of course, every patient wants to live longer, and so do we want it. Survival at the end of 5 years. How impressive is this, especially for the PDL1 negative population? So do you feel that almost 25% of the population is surviving at the end of 5 years? That's 1/4 of the population. Big numbers. Are you happy? Are you impressed?
Data is quite promising and appealing to use, provided we get enough exposure and experience of using the IO combination in this particular subset, because we have been using it in melanoma, RCC, the IO combination. The responses were variable, and toxicities we have experienced in that. So here I would like to maybe appeal to the BMS as well. They can have real world data of this IO combination with chemo, particularly this LA9 in lung cancer patients in India, kind of a phase 4 study, so that all of us will get the enough exposure and the confidence in using the IO combination in lung cancer patients as well.
Fair enough. Rationale for survival, well, really, do we have an answer as to how we are going to explain that the survival benefit is far well pronounced in the PDL1 less than 1% population? Any takers? Anyone?
Maybe one of the reasons could be 2 cycles prior received of chemotherapy, making the
But
tumor
that was in
more-
both the arms. Both arms had chemotherapy, right? That cannot be, may not be a very, well, it's really a mystery that less than 1%.
Basically, with 9LA, the biggest advantage was the dual combination. Nivo-EP was also been established as one of the options with Checkmate 227.
Yes.
But then the biggest problem with that was there would be few patients who would have a high disease burden and who would otherwise progress because of low response rate.
Yeah.
So that was taken care by addition of 2 cycles,
of chemotherapy.
So that was the biggest advantage of Checkmate 9LA.
Yeah, so they probably used chemotherapy very judiciously, just enough to give a symptom relief, just enough to bring about some response, and then maintain the response with this thing. So there must be some synergy, like with the anti-CTLA4, it induces, it has a different mechanism of action predominantly, and in the nivolumab, it is going to have, nivolumab is going to work in a different mechanism. With, it is suggested that this combination, one works in the periphery, one works in the tumor microenvironment, and combining the two will overcome the limitation of using either one of them as monotherapy. And if you add chemotherapy to it, chemotherapy will cause more cell death, that will probably expose more antigens, promote the activation of antigen presenting cells, and that will probably, in addition to immunotherapy, will bring about better response and survival. These are just thought processes which have happened.
Then just a question to you, maybe,
sure,
or to the audience. If we have started with Checkmate 9LA,
yes,
and patient is doing well, both from the point of view of tolerance to the chemotherapy as well as tolerance to the immunotherapy, would you be tempted to continue with chemotherapy as well?
So chemotherapy maintenance pemetrexed is always a thing which has been going on. You know, all of us have patients who have passed probably 3 years on maintenance pemetrexed. It's an extremely tempting drug to use in the maintenance setting. 10-minute infusion, doesn't cause too many toxicities. We don't even have to micromanage. Patients themselves come and tell you that this time I'm going to come after 6 weeks, 4 weeks, 5 weeks. We really don't bother about it. So yes, it is very tempting to use it, but given the excellent survival at the end of 5 years, I would be
maybe
a little...
that number will be even higher?
Yeah, maybe it will be higher. But well, that was not studied in this trial anyways. But yes, in practice we are doing it. In practice, if you have a patient who is on, say, chemotherapy plus pemetrexed, you often tend to continue pemetrexed maintenance. You don't necessarily stop if the patient is doing well. Even with TKIs, if you have a patient who is receiving TKI plus chemotherapy, you don't stop after 4 or 6 cycles or getting a great response. You don't just continue TKI, you continue pemetrexed as well. So probably continuing pemetrexed makes sense in my opinion. This is of course my opinion. This may not be what is, there is no literature to suggest that, but in practice, yes, I would continue it. Maybe seniors, Dr. Chirag sir, you can pitch in if you feel that pemetrexed should also be continued. What is your thought? Do you do it or you?
It depends on what background of immunotherapy we are using. If it is the something like 9LA, where we have initially started with carbopectly, then there is no point in continuing pemetrexed. But if it is the platinum pemetrexed to begin with, I will continue with pemetrexed.
Oh, okay. Fair enough.
So the trial which Dr. Bonade was also mentioning,
yeah,
Durva Treme Plus, that had 4 cycles of chemotherapy.
Yeah.
So unless we have direct comparison, we
won't
be able to
know.
get an answer.
What about brain mets? Brain mets traditionally has been, traditionally brain mets has been an aggressive subtype, and none of the immunotherapy drugs actually have a significant activity inside the brain. What about brain mets? Do you treat them differently? You just radiate and then continue with your regular treatment? How do you do? This trial had almost 20% population with brain mets.
Basically, usually around 20 to 25% patient present in stage 4 present with the brain mets, and usually we start, as we know that most of our immunotherapy or chemotherapy doesn't affect in the brain. So we start with radiotherapy, especially in patient, and then we go ahead with chemo or immuno. It is not obviously about targeted therapy, but especially non-actionable, we give radiation and we'll continue with.
With EGFR, a predilection towards brain is known, but in EGFR non-mutated patients, if somebody has brain mets, it probably means that the tumor is more aggressive, and that is why this question came whether these patients do behave differently. But people with baseline brain mets did still very well with the combination. The median OS is almost tripled, 6.8 versus 19.3, and without brain mets, surprisingly, the population did not do well. So maybe, coming back to the same story that less than 1% PDL1, brain mets at diagnosis, smoking population, probably more aggressive tumors, this combination approach is working better. This was reflected both in the OS as well as the PFS, and even the duration of response was better with baseline brain metastasis compared to the non-brain mets at diagnosis. Intracranial PFS at 3 years, the combination arm still had better. The curves are wide apart right from the beginning, and they remain separate for a long period. This is follow-up at the end of 3 years, so that's significant. Again, a patient of brain mets surviving 3 years is something which is unusual. development of new brain mets in patients who were having brain mets or who did not have brain mets, the combination arm still did better with the possibility of having newer brain mets. So there is OS advantage even in the population where there are brain mets, whether you, again, it is irrespective of PDL1 less than 1% or PDL1 more than 1%. What about other mutations? We all do multi-gene panel testing, so we do get KRAS, TP53. First of all, do you check for these, and if they are there, does it change your plan of action? Unusual, so-called non-actionable mutations.
In NGS report, sometimes we get such findings, but specifically we don't ask for any of such mutations.
So does it change your plan? You have planned this patient for, say, a combination of Nivo-EP plus PEM-carbo, 9LA protocol, and this is your mutation status. Does it say it shows TP53 or probably...
STK and KEEP are known to have less response to IO as well.
Okay.
So that's why we have to be.
So then will you change from
add on chemo with IO at least.
So then probably this is the type of patient where you will continue your chemotherapy. Makes sense. Yeah. So multiple mutations, as rightly discussed, this study had their fair share of new mutations, almost 64% of these population. Whether it was KRAS mutated, KRAS wild type, actually the mutated population did slightly better compared to the KRAS wild type. The KRAS wild type hazard ratio is bang 1. For TP53, again the mutated population did better. So worse is the mutation status, worse is the disease biology. This combination is probably doing better. Same is true about other mutations as well. Just one minute, again all groups put together. Let me just click at the survivor data. Survivor figures, 5-year PFS percentage 55% versus 38%, overall response rate 35 versus 18, and ongoing response at 5 years 59% versus 59 versus 46. Happy with this? No, this is the toxicity. The toxicity was something which a lot of people are worried about, and this is the toxicity of traditionally immunotherapy toxicity. Rash, diarrhea, hepatitis, pneumonitis, nephritis, renal dysfunction. All of us have encountered at least one of this toxicity. Some of us have been unfortunate enough to suffer more than, see our patients suffer from more than one of this toxicity. So which are the toxicities where you will absolutely stop immunotherapy, not take a re-challenge? Last question to the panel, and then I'll stop. Any one of these. So thyroid, I think endocrine, all of us know that we can manage it except adrenal. With adrenal insufficiency, the guidelines are still hazy what to do. If you are going to continue with maintenance dose of steroids, we really don't know how long we are going to continue, and then what happens with the maintenance dose of steroid, whether immunotherapy works as well. Rash, all of us know how to manage it. If it's very severe, if it has progressed to grade 3 and above, we often stop immunotherapy and we are a little hesitant to re-challenge. Diarrhea, colitis, especially biopsy-proven GI toxicity is a little difficult. Hepatitis, we can manage. Transaminitis, we give steroids, allow the transaminases to settle down. Pneumonitis, bad pneumonitis requiring ICU hospitalization, oxygen support and all that, very often we don't. Nephritis, definitely we don't. Cardiac problems and neurological problems, we definitely don't re-challenge with immunotherapy. For all others, you can take a judicious call. If the patient is doing well, you can continue it. I'm extremely sorry for exceeding my time. I'm sorry I couldn't finish the slides, but I think it was a very fruitful and a very absorbing discussion. Thank you very much.
Thank you, Dr. Chetan. I really apologize. I missed inviting Dr. Ashwin Rajboj to the panel. Thank you, Dr. Chetan, for inviting him. We now shift focus to interventional radiology, a discipline increasingly vital in oncology care, offering procedures that combine precision, efficacy, and minimal invasiveness. May I call the session director, Dr. Suyash Kulkarni, Professor Radiodiagnosis Mumbai and Session Coordinator, Lisa Bulsara, Consultant Pediatric Hemato-Oncologist and BMT Physician, Pune. I would also call our chairpersons, Dr. Prashant Gite, Consultant Department of Interventional Radiology, Pune, Dr. Shailendra Savle, Consultant Radiologist, Pune, and Dr. Ashay Karpe, Consultant and Medical Oncologist, Mumbai. Let's begin with a fresh look at ablative therapies and their evolving role in oncology. May I please welcome Dr. Suraj Bhamre, Consultant, Department of Interventional Radiology, Mumbai.
So, good morning everyone. Let's discuss about the recent advances in the ablative therapies. So, by definition, ablation is defined as the removal or destruction of part of body, tissue, function by evaporation, erosion, heat or chemical methods. Coming to the timeline, it started way back in 1850 where advanced breast and uterine carcinomas were treated with eye saline solutions. However, the standard care which we use in liver or any other, which is radiofrequency ablation, is started way back in 1990. But right now, with the help of AI tools, we have multiple advances in ablative therapies. What we have to offer from our ablation toolbox is that it can be either thermal based, non-thermal based or chemical based ablation therapies. In thermal base, we can fry the tissue with the help of radiofrequency ablation, that is RFA, microwave ablation, that is MWA, or high focus intensity ultrasound. We can freeze the tissue with the help of cryoablation. IRE comes as a non-thermal modality. We can use ethanol or acetic acid for chemical ablations. So, how the tissue reacts to the different body temperatures? At less than -20 degree, there will be formation of ice crystals with the which will break the cell membranes with preservation of scaffoldings. At 41 degrees Celsius, there will be vasodilation and release of heat shock proteins. 46 degrees Celsius, there will be irreversible necrosis. As the temperature increases, we usually target our ablation more than 60 degree, where the tissue will have the rapid denaturation of the protein. However, at more than 100 degrees Celsius, there will be charring of cells. So, typically for cryoablation, we target the temperature less than 20 degree, and for RFA or microwave, we target the temperature more than 60 degree. So, this is how the gross specimen looks after the ablation. You can see the central area of charring, followed by peripheral area of white zone, which is a coagulation. This is the area where you will see the dead or necrotic tissue. However, there will be, because of surrounding inflammation or reactionary reaction, you will see red zone of congestion. Apart from the primary death of cell tissue by help of apoptosis or necrosis, there is something which we have to offer, which is called as abscopal effect or immunological effect. Because of cell death by any ablation modality, there will be release of cytokines through regional or systemic production, which will go and act on the metastatic foci distant inside the body. So, even if we are treating any focal therapy, there will be always systemic immune response with the tumor foci which are present distant from the tumor primary. So, coming to the irreversible electroporation, that is IRE, this is how the treatment we usually plan. So, multiple electrodes were placed percutaneously, either with the help of ultrasound or CT guidance. We usually place these electrodes surrounding the tumor. So, after placing the electrodes, we pass high voltage electric current. Typically, this modality is offered when the tissue is in close vicinity of the blood vessel. After application of the high volt, there will be formation of pores inside the cell membrane, which will ultimately cause cell apoptosis. So, as you can see, this tumor is in close vicinity to the artery and vein, where we have limitation in offering some heat-based modalities, where IR is a good tool to offer. If after the ablation, you will see there will be release of, there will be necrosis of all the necrotic cells. However, white collagen background network is already preserved. So, over the period of time, this collagen or background meshwork will help to regenerate the tissue, where you can see there will be regeneration of the surrounding normal tissue, and ultimately you will get the cell-free tumor bed. There are multiple studies where IRE can be offered for the advanced or regional recurrence of the pancreatic cancer, even for the colorectal liver metastasis, and now it is coming in a big way in prostate cancer. Coming to the few cases which we have treated at our institute, 38-year-old gentleman, diagnosed case of locally advanced pancreatic carcinoma, post multiple lines of chemotherapy, there was progressive disease. This was a big tumor lying in a close vicinity of the gastroduodenal artery and common hepatic artery. That's why we have offered IRE for this patient. This is how multiple needles we parked under the CT scan, parallel to each other, covering the entire tumor. And on the response scanning, you will see beautifully how the tumor has undergone necrosis. Peripheral, you will see small avidity, that is because of the reactionary or inflammation which we have seen on the gross specimen priorly. This was a case of colorectal carcinoma. You can see a tumor which was in a close vicinity to the bowel. Here again, heat-based modality will have the high risk of bowel injury. We offered the IRE for this patient, and you can see post-IRE there is a good ablation response in the form of necrosis without any injury to the surrounding bowel. So this was a case of 18-year-old male presented with the upper back pain score of 8 out of 10. Biopsy turned out to be osteoblastoma. You will see the big petavid lesion inside the right D1 area, which is the area which is surrounded by the brachial plexus and all the visceral arteries. So this is how the tumor, which was in close vicinity to the nerve roots which are coming from the spinal cord and subclavian artery. This is how we planned ablation. 4 needles were placed inside the lesion, and after ablation you will see beautifully response how the tumor has undergone necrosis, and Spain core has also reduced tremendously from 8 to 1. This was a case of 30-year-old male, mediastinal seminoma post NSCT and surgery. On follow-up imaging, there was a paravertebral lesion, biopsy of which turned out to be high-grade sarcoma. Since this was lesion which is close vicinity to the aorta and heart, any ablation modality will have the risk of injury to these structures. We planned IRE for this area which is in a close proximity to the aorta and heart, and any heat-based RFA modality for the treatment of the peripheral area. So this is how multiple IRE electrodes were parked. You can see multiple needles were coming from the posterior area of the body, parked surrounding the aorta and pericardial area. Peripheral area which was away from the aorta was treated with the RFA. And you can see on follow-up beautifully how this ablation has worked, and there is a good necrosis inside this tumor. So this is how we can combine IRE with other ablation modalities. Coming to this 31-year-old female, big name gynecologist in Mumbai. She was referred to us for a case of pelvic fibromatosis, which was not responding to the sorafenib. There was new lesion which was encasing the right ureter and right VUJ junction, because of which patient had an obstructive uropathy. We did the PCN and degescenting. Degescenting helped us to allow a visualization of the ureter during the ablation. We did the IRE for the area which is surrounding to the degescent, that is the ureter area, and cryoablation for the area which is away from the ureter. So you can see how the needles were parked surrounding the degescent, that is the ureter. Ultimately, on the follow-up scan, you will see how entire tumor has melted down, and whatever you see on the post-ablation scan is a ureter, and she has become relief of the obstructive uropathy symptoms. In RFA, we have now multiple tools to offer. This is how now how the teamwork can work. 1 + 1 + 1 is always more than 3. So this is how 3 needles, which if we do the ablation simultaneously, there will be the big ablation zone area, and because of which now we can treat the tumors which are longer in size, approximately 5 to 6.5 centimeter in size. So this is how, this was a 65-year-old male, big metastasis from the colorectal primary, approx 5 centimeter in size. We did park the 3 needles surrounding this lesion. You can compare this with the octopus technique, like how the legs of octopus are wrapping around the lesion. And after the ablation, we can see there is a good necrosis, and we can now treat the lesions which are approximately 5 to 6.5 centimeter in size. We have the hybrid modality in our institute where single bed can give the access to the CT scan and fluoroscopy or DSA, which will offer to combine both of these modalities to offer treatment to the patient. So this is a area which is very high risk to target, either only on CT scan or only on ultrasound. IL grade 1 NET, which was avid on DOTA scan. So we did the CT scan, we mapped out the lesion, and under fluoroscopy we targeted the lesion. So we have combined both these modalities, CT scan and fluoroscopy, to target these lesions. Coming to the high intensity focus ultrasound, this was the biggest registry published way back in 2015. 625 patients, results is 98% failure free survival, and when you compare with the surgical techniques, there are pretty much less number of complications in the form of no incontinence and only 2 cases of fistula. So this is how HIFU works in prostate. We put the HIFU probe inside the rectum. Blue is the area of prostate, orange is the area of target. After placing the HIFU probe, it will acquire the volumes so that we will see the lesion on the ultrasound. We can fuse this ultrasound image to the MRI, and ultimately the HIFU machine will start working, and you will see how the small focal areas of ablations are created inside the targeted area. So this was a case treated at our institute, a small focal area of prostate cancer. Red is the area of tumor and blue is the normal prostate gland, and post HIFU you will see how beautifully the tumor has gone. Coming to the cryoablation, we usually use Joule-Thomson effect under the cryoablation, where you can see at the tip of the cryoprobe, the compressed cryogen gas will get depressurized at the tip, which will cause the endothermic reaction. Because of this endothermic reaction, there will be the formation of ice crystal formation at the tip. Different ice ball sizes offers us to treat different sizes of lesion. So this was a case of 52-year-old male, malignant peripheral nerve sheath tumor, post-surgery RT. Patient was having severe 10 out of 10 pain, because of which patient was having suicidal behavior, not relieved on any kind of analgesic therapy. We did the cryoneurolysis, that we packed the cryoprobes inside this sciatic nerve and we did the ablation of sciatic nerve, after which the pain score has reduced significantly from 10 to 2 and she is now pain free. 51-year-old male, case of trigeminal neuralgia. Pain was in the distribution of the mandibular nerve because of plexiform neurofibroma. Under the CT scan, we targeted the foramen ovale, because of which patient is now pain free, and post procedure now pain has reduced from 7 to 8 to 1. So this was one of the rare case which we treated. 13-year-old child, classical features of NF2, left cranial CP angle schwannoma. You can see on the MRI hyper-enhancing lesion. Post CT and RT, post surgery and RT, there was a recurrence, and child was presented with the progressive neuropathy. So under CT scan, we targeted the intracranial part of the nerve tumor with the help of cryoablation. And on the post-ablation scan, you can see how beautifully the tumor has undergone necrosis, and because of now decompression effect, the neuropathy is now improving. So in conclusion, we have multiple therapies to offer from our side: RFA, microwave, IRE, cryoablation. Either it can be heat-based, non-heat-based. There is something new which is called as abscopal effect. Apart from the primary side, the tumor can act on the distant foci, and every modality has its advantage, and we have to balance the modality according to the indication. Thank you.
Thank you, Dr. Suraj. I now request Dr. Kalpesh Prajapati, Consultant Medical Oncologist, Ahmedabad, to kindly moderate the question and answers.
Since the ablation works on the principle on heat or cold based ablation, if we see the how ablation works, there will be necrosis of tumor cells. So there can be a decreased response, or there can be some residual, but there is no lesion we have seen in our institute which have not responded to the ablation. Yes, definitely. Basically, ablation is coming in a big way. The lesions which are not responding to the chemotherapy or radiation or surgery, recurrences after surgery, where post-surgery there will be difficult to undergo that area and to operate that area. Ablation is a good tool. Percutaneously, we hardly treat with the 2 to 3 mm incision. It can be repeated and very much acceptable by patient, because since it's a less morbid procedure. Yes.
Can this be a first line of treatment, or it's only after?
Yeah. So ablation has two roles. First is we have done a definitive treatment, only single treatment for this patient. We have papers from BCLC. So HCC is the area where single or less than 3 lesions, where we can offer it as a definitive, even in colorectal or the osteoblastoma case which I have shown. Those are benign tumors. We don't want to have we don't expect recurrences. In those cases, we have the role of as a definitive treatment, and even for palliative setting or at the adjuvant setting, with the help of other modalities, we can treat these lesions.
Sir, do you have any experience with repeating IRE on a progressive tumor? Like, you've done IRE once, disease has progressed. Have you ever used IRE in the same?
As a repeat modality, yeah. So IRE are the cases which are challenging for us, because the main role of IRE is to treat the lesions which are high risk. So we have seen few cases where we have seen recurrences post IRE. Repeat that treatment as required. So we need to target the area which has recurred, and it is pretty much safe to repeat the same ablation. Okay. So in lung, we typically see infection, pulmonary hemorrhage and pneumothorax, but the rate is less than 5%. So, and even if complication happens, those are manageable, like grade 1, grade 2 complications, where patient can be discharged with the conservative management within 3 to 4 days. You need not to be worried. Yeah, thank you.
Thank you. Thank you, Dr. Suraj, and thank you, Dr. Kalpesh. Next, we explore loco-regional arterial therapies, an area offering hope for organ preservation and targeted cure. Please welcome Dr. Yadav Munde, Chief Vascular and Interventional Radiologist, Pune.
Good morning, everyone. In next 10-12 minutes, I will discuss about the transarterial loco-regional therapies in oncology. So, these are catheter-based image-guided therapies which are minimally invasive, and in this, the drugs or radiation material is directly put into the tumor-feeding arteries, so that the high local radiation will be there, local concentration will be there within the tumor, and there will be less systemic side effects. And these treatments can be repeated multiple times in unresectable tumors. The main therapies are transarterial chemoembolization, radioembolization, and bland embolization. In transarterial chemoembolization, we put chemotherapeutic agents and embolic agent. So the mechanism of action will be ischemic and cytotoxic. In radioembolization, we put yttrium-90. So there will be microembolization with the particles and they will give internal beta radiation. And in bland embolization, the mechanism is only ischemic effect. Coming to the tests, this again can be conventional tests in which we use doxorubicin and lipidol. Then DEP test where we use drug-eluting beads where the drug release can be prolonged, and B test where we use balloon catheter so that there will be precise delivery of the drug and there will be no non-target embolization. Coming to TARE, this is done in 2 steps. In first step, we do pre-treatment angiography and then technetium mass scan to see lung shunt fraction. And if the lung shunt fraction is good, then we can go for main treatment, that is Y90 treatment. In this, the mechanism is yttrium-90 microspace deliver internal radiation to the tumor, and in many studies it is studies that showed that it is superior, it has superior tumor control compared to the TACE, and it is better tolerated compared to the TACE. These are the clinical outcomes of TACE versus TARE. The response rate in TACE is 30 to 60% and 2-year survival is 50 to 60%, whereas in TARE the response rate is 65 to 70% and has superior TTP, that is more than 26 months. Coming to the transarterial therapies beyond HCCs, this can be colorectal cancer liver metastasis where we do debris test or TARE, and in this we can achieve median survival of 15 to 17 months. In neuroendocrine tumors, TARE achieves more than 90% disease control and synergizes with CAPTEM and PRRT. In intrahepatic cholangiocarcinomas, again, we can do TACE or TARE, which is superior to chemotherapy alone, and median OS of 14.9 to 26 months can be achieved. And even in gastric cancers, TACE and chemotherapy plus TKI can be given. So in most of the talk, I will discuss mainly about the HCC. because other treatments we hardly do much. So, and some combination therapies also can be done, that is TACE plus immunotherapy, TACE plus CAPTEM for neuroendocrine tumors where median OS can be more than 130 months. Radiation plus systemic therapy can be tried where we can take advantage of hypoxia-induced VEGF activation, which help in more effect of systemic therapy. And all this disease-specific selection is critical for optimal outcome. So let's discuss about HCC. Most commonly, we use the BCLC staging system. So in this BCLC staging system, you can see most of the transarterial therapies are indicated in the intermediate stage HCC, that is stage B. But there can be stage transformation, and this can be used from early stage A to late stage C, and that we will discuss further. And this is a Indian guideline, the Puri 3 recommendation published in 2023. Here you can again see the transarterial therapies are indicated for intermediate stage as well as advanced stage HCC, and sometimes as a bridge for transplantation in early stage HCC. So the basically BCLC-B intermediate is TACE is the first line option. BCLC-A early tear, mainly the ablative tear is done for the bridging to transplant, and BCLC-C systemic therapy is preferred, but sometimes we can do palliative tear. Coming to the patient selection, the patient should have unresectable HCC, preserved liver function, that is bilirubin less than 2 to 3, and have good arterial access. Coming to cautions and contraindications, it should not be done in decompensated cirrhosis. Sometimes portal vein thrombosis can be a relative contraindication and active infection. So we will see BCLC stage 1 to advanced stages. In BCLC stage 1, you can see if the patient is having tumor more than 3 centimeter to 5 centimeter, ablation plus TACE can be tried. And we'll see one example. This is a 56-year-old male, incidentally detected cirrhosis, ECOG1, bilirubin of 2.4. Tumor size was 4.39. Here, what we did, he was not feasible for any surgical treatment. So we did RFA and TACE in the same sitting, and this was the follow-up after 2 years. You can see there was complete response and tumor was completely gone. And this is a paper which shows overall survival comparing surgical resection versus radiofrequency ablation, and you can see the overall survival is almost similar. Coming to the BCLC-B intermediate stage disease, as I told earlier, chemoembolization is recommended for patients with BCLC stage B, multinodular asymptomatic tumor without vascular invasion or extrahepatic spread. This has evidence of 1A and recommendation of 1A. Let's see one case. Here you can see the large SCC involving the left lobe of the liver with cirrhotic background. The patient was referred to us for locoregional therapy. So we did TACE in this case. This is a conventional TACE with lipidol and doxorubicin. And this is the follow-up. You can see pre and post. The tumor is completely gone. There is no enhancing part in the tumor. And this is the one slide. You can see there are multiple papers showing that not all patients benefit from TACE, and the OS can vary from 26% to 66%. Coming to the intermediate stage, where we can offer transarterial chemoembolization as well as transarterial radioembolization. Let's see the case, 80-year-old male with large right lobe HCC. Here in this case, we offered transarterial radioembolization. You can see nice deposition of the atrium 90 into the tumor. And this is the pre and post follow-up. The patient's tumor is completely gone. Even the alpha fetoprotein, which was raised, has come to normal. Even pucca has come to normal. and it has shown that TARE is promising antitumoral, has promising antitumoral results and has safe profile. Coming to the advanced stage tumors, as per the Indian guidelines, we can offer this TARE in advanced stage tumor where portal vein involvement is there. And this is one of the example that SCC with portal vein thrombosis. You can see the most of the left lobe shows tumor with the tumor in the portal vein, and this is the pre-procedure. Then TARE was done. There is nice deposition of the ATM90 into the tumor, and this is the pre, and then post. You can see the tumor is completely gone. Even the portal vein shows nice recanalization. And this is one of the paper which showed TARE can be offered to all the stages of the HCC, that is early stage HCC as a bridging therapy for transplant, intermediate stage, stage B, and stage C in advanced stage with portal vein thrombosis. So to conclude, TACE is the advocated mainly for the BCLC stage B intermediate HCC. TARE can be considered for almost all BCLC stages as it has longer TTP and suitable with portal vein thrombosis. Approach should be personalized to each patient. Can consider combination therapies whenever feasible for better outcome, and multidisciplinary management gives the best outcome. Thank you.
Thank you, Dr. Yadav. I think Dr. Kunal is not present for the question and answer. If we have any questions from the audience, we can take them.
Yeah, can I ask a question?
Sadhya.
Yeah. So basically we say that portal vein thrombosis is a quite relative contraindication, when you are doing TACE. So
Yes.
which are the situation where you will go ahead with the TACE?
Yeah, so again, we should know where is the thrombus, whether it is in the main portal vein or segmental portal vein, or right or left. So if it is segmental portal vein, it should not matter much. And again, the feasibility of superselective TACE, if we can do superselective TACE go into the segmental branch, then again it is not a contraindication. We can go ahead with the TACE.
I think there are no more questions. Thank you, Dr. Yadav.
Thank you.
Our final talk in this session highlights how IR makes a life-saving difference in oncology emergencies. Please welcome Dr. Kaurabi Zade, Consultant Vascular and Interventional Radiology, Pune.
A very good morning to everyone, to all senior friends and seniors. So let's move from planned procedure to something which just add adrenaline surge to our life. So when it comes to IR, you will see all kind of different spectrum and we are on our toes. So it can be life-threatening pulmonary embolism, maybe it can be a tumor bleed, a deep venous thrombosis, a completely puffed up SVC syndrome or a broken chemoport. All these situations as an oncology practice we keep on seeing, and these are bound to happen because we know it's a disease, it is going to show its course and it happens. So I am going, in next 10 minutes, I am going to show the cases, how we deal with this kind of patients and what is the approach in most of the cases. So let's go one by one. This is a case of CA lung on regular treatment and presented with breathlessness and breathlessness and dilated 2D echo. So clinically our first diagnosis is PE, right? So when it comes to CA lung and PE, so the first thing that comes to our mind is we discuss with our oncology team, how is the prognosis of patient? If patient is going to make for next 1 year, 2 year, the survival is that way, then only we pitch in and do something. Otherwise, whatever, these are very high risk patient and we know that the mortality is too high. So we need that assurity from our oncology team. And at the same time, when it is CA lung, the tumor burden is also equally important, because that is also adding to the morbidity and suffering of the patient. So this is a case which I mentioned. So there was a big saddle thrombus. So since the survival was good, we went into the lung, took the clot out, and at least the morbidity and the life-threatening things we have taken out, and then we have scope to treat the patient further. We all know that when it comes to malignancy, the thrombogenic tendency are going to be there. And once the survival is good, patient is going to make it, we offer this kind of treatments. So this is a case of pulmonary embolism, which we took the clot out, and then further treatment was continued. So now this is another interesting case. This was a regular CA breast patient, came for regular chemotherapy, and then we got a call from Onco360 that the port is not getting flushed. So first thing comes in our mind, okay, it's fine, there can be some block or something, but one protocol what we follow is, we always take the patient, if there is any port related issue, directly to the fluoroscopy room and see then and there, because we don't know what is going inside. Like sometimes the port we have seen 10, 12 years old. So chest radiograph was done, and it suggested a broken port, and the one end of the port was broken down into the ventricle. So again we went into, sorry, can you play the video? Yeah, so again we took this broken port, because again it can add arrhythmias, and to any patient who knows that the port is broken inside her heart, it will itself add arrhythmias, right? So we took this broken port out with snare, and this was the remaining part, and this is how this port was. So these are all emergency situations. Sometimes we don't even expect that this can happen, but these are the real life challenges which we face. Then tumor bleed, we all know that any tumor, since it's a hypervascular structure, it can bleed. Sometimes bleeds are small, it gives us time with regular transfusion and stabilizing the patient. But some bleeds actually don't give us time. So again, this was a case of massive bleed. The patient was in shock, full dose of noradrenaline and supports, and you can see that the amount of bleed was, it was active exacerbation. So we immediately went in, embolized it with glue cast, and patient was stabilized on table. So these are actually adrenaline surge patients, because we know that in next half an hour, 45 minutes, patient can succumb. So this keeps on running, and we are on our toes to handle this kinds of patient. So again, same case. So the third part, last part of this emergency case series which we see is SVC syndrome. So as an oncology department at Sahyadri Hospital, we see the spectrum a lot. It can be because of tumor, it can be long indwelling catheter, or it can be thrombus. We see it a lot, and patient many a times come with puffed up face, O2 requirement, and sometimes we see that the intubations are also difficult because of SVC syndrome. They are full blown, and there is venous congestion everywhere. So this is a case where you can see complete occlusion of SVC, and there was a huge collateral, and this was because of port. So we crossed this chronic occlusion, okay. So this was because of chronic indwelling chemo port, and then we crossed it, did balloon angioplasties, and if you can see, all the collaterals are disappeared now. The response in this kind of patients are dramatic. The swelling disappears within next 2 to 3 days, and patients are out of ICU, and that because when we see this SVC syndrome, even the ICU are at on the toes, because once the patient requires intubation, even that is very difficult. It's completely congested throat. So when this kind of cases arises, we just immediately step in and do whatever we can. So this is again a case of SVC syndrome. So in short, we face this kind of emergencies very regularly, because once it is a full-fledged oncology department running, so we are also running. So any question related to emergencies, I will be more than happy to answer. Thank you.
Thank you, Dr. Kauravi. I request Dr. Rakesh Sharma, Consultant Medical Oncology, Gurugram, to kindly moderate any question and answers.
So when it is pulmonary embolism, if it is a non-oncology patient, the most important criteria for us is the right heart strain. Because though the clinically patient may be stable, but we know that if it is RA-RV dilated, patient is going to into the massive category very soon. So we don't wait for patient to drop BP, go on supports, because in that case the prognosis is really poor. So with dilated RA-RV and the tumor burden high, we immediately go and do the things. Thank you very much. Thanks a lot.
Thank you, Dr. Rakesh. We now have a panel discussion on personalizing immunotherapy in metastatic NSCLC. This session is sponsored by Roche. I invite Dr. Chirag Desai, Consultant Medical Oncologist, Ahmedabad, to moderate the session along with our panelists, Dr. Ashwin Rajbhoj, Consultant Medical Oncologist, Pune, Dr. Akshay Shivchand, Senior Consultant Medical Oncologist, Kolhapur, Dr. Nikhil Sirsi, Consultant Medical Oncologist, Pune, Dr. Vipul Doshi, Consultant Medical Oncologist, Solapur, and Dr. Bhavesh Parekh, Consultant Medical Oncologist, Ahmedabad.
Good morning, everyone. So in next about 35-40 minutes, we are going to discuss about immunotherapy in the first line in metastatic NSCLC. And the focus will actually be on atezolizumab, this being the session sponsored by Roche. But we will be trying to cover a few more aspects of immunotherapy in metastatic NSCLC as well. So we have Kardal Rathore. He is not there? No. Do we have Dr. Bhavesh Parekh? Yes. Very good. Ravi is not there. Akshay is there. Dr. Vipul Doshi and Dr. Nikhil. Okay, wonderful. So it's good. I mean, to have a fewer panelists, we can have a better discussion. Otherwise, I kept on wondering whom I have asked and whom I have missed. So with that, let us first start with our discussion. This doesn't move. Yeah. So these are the disclaimer from me as well as from Roche. Immunotherapy has transformed the management of many diseases, outcome of many diseases, including NSCLC. And NSCLC was among the first few diseases where we found the utility of immunotherapy beyond malignant melanoma. So if I can start with Dr. Nikhil. So what are the parameters which you look at therapy selection, not necessarily immunotherapy, but any therapy selection in the patient with NSCLC?
So for patient with NSCLC, therapy selection is mainly dependent on patient dependent, tissue dependent. That means which type of cancer is squamous, non-squamous. And second thing is dependent on the tumor mutation burdens, targetable mutation burdens. Is there any targetable mutation is there, or it is wild type? Second is PD-L1 score. So we usually doing to selection of immunotherapy, whether it can be used single agent or it can be used as a immunotherapy.
So if we can pass on the question to Dr. Vipul. Dr. Vipul, how important is PD-L1? How seriously you take the PD-L1 in your practice?
So now, in the current scenario, the targeted mutation negative patients, the whole management is dependent on the planned on the PD-L1 basis only. So if there is a good PD-L1 expression, high PD-L1 expression, so we can think about giving away chemotherapy and giving just immunotherapy alone. And even in cases of less PD-L1 expressions, we can give a combination therapy. even in case of brain metastasis, we can give immunotherapy more a preference. So PD-L1 expression does matter in this scenario.
Right. So Akshay, in the discussion in the morning, Chetan Deshmukh was the moderator and he had asked a couple of questions to the panelists and we didn't have a very clear answer. And in oncology, we don't have many answers clearly. Many of the facts are evolving over the years. So one thing was asked by Dr. Chetan was that if you have the mutation report which is negative, will you wait for PD-L1 to decide whether to give immunotherapy or not? So that was the question, right? So what's your answer? Quick.
So depends on patient's performance status, age. Patient is fit enough to undergo chemotherapy, then we will start with the chemotherapy and wait for the report.
So particularly to answer that particular question, usually PD-L1 report comes on 3rd or 4th day and the mutation report comes after about 10-12 days. So it's usually PD-L1 and if the PD-L1 is 70%, we ask everyone to wait till the mutation report is available. Don't jump on starting immunotherapy. That's the first thing which I wanted to discuss. And the second thing was that in that particular trial, welcome Ashwin.
I have a recent patient whose PD-L1 expression is 60%.
Right.
The block was sent because there was tissue depletion was there and a report came as ALK negative and PD-L1 70 but no EGFR was found. So again the question mark is whether that patient is EGFR positive or not.
So Ashwin, you were there in the morning in the panel discussion and Chetan had asked the question that for the PD-L1 less than 1% also there is improvement with immunotherapy and we are surprised why that happens and any guess why that could happen?
So as I told you that time also, okay, there are PD-L1 itself is a it is a heterogeneous factor, like there are multiple other factors.
So PD-L1 is an imperfect marker and we don't have any perfect marker for immunotherapy as of now. It could be MSI, it could be TMB, it could be PD-L1, it could be anything else, but there is no perfect marker. So PD-L1 is one of the most putative marker for lung cancer. Let us keep it that way and then proceed. Bhavesh, the last one, the other factor, patient wishes and physician preference and so on and so forth. How important that is in our practice. So does it ever happen that on Monday your mood is something different and Thursday your mood is something different?
No, my mood is definitely every day is same, but physician's preference and patient wishes is also very important.
Right.
And as we both are doing also clinical trials, and I think for non-small cell lung cancer, so many new immunotherapy and so many new trials also. So I think whenever, like on Monday, when new patient came of metastatic non-small cell lung cancer, this point other factor is also very important to consider my next treatment.
Right. So treatment options for the patient with NSCLC, metastatic NSCLC without actionable driver mutation, and we will be discussing about the first line treatment. So in this slide it's more than or equal to second line treatment, but we will be discussing about the first line, except TKI treated patient I will discuss in next few minutes. It's chemotherapy, it is anti-angiogenic with chemotherapy, or when I write CIT over here, it is cancer immunotherapy, it is not chemoimmunotherapy, so keep that in mind. So it is cancer immunotherapy monotherapy, or cancer immunotherapy with chemotherapy, or cancer immunotherapy doublet with or without chemotherapy. And in the second line is chemotherapy or anti-angiogenic with chemotherapy or cancer immunotherapy monotherapy. If immunotherapy was given in the first line, there is no point in continuing that in the second line. So that's it. So we are going to discuss 5 different scenarios, hypothetical scenarios: high PD-L1, platinum ineligible, prior TKI, liver metastasis, and bulky disease. Right? And in the end, I will ask all the panelists if they have any specific comments on any of the subset. But we will go with this flow. So talking about high PD-L1, 50-year female, metastatic NSCLC, bone metastasis, multiple bone metastasis, good performance status, not requiring the treatment immediately, squamous cell carcinoma, mutation testing done, all mutations are negative, and PD-L1 is 70%. Vipul, it was SP263. When you order PD-L1 testing, how often do you specify that which antibody you want to test and how do you want to test?
Actually, the concordance between the platforms are more or less similar only. So, if we prior decided like we have planning for this immunotherapy, then the ideal is to use that platform only. But even otherwise, it's okay. Like the concordance is well in between the platforms.
So, Nikhil, if you are not specified any specific antibody, which antibody your lab is giving?
DECO 142 is usually commonly used.
Right. Akshay, how often your laboratory is giving SP142 without your specifying?
Without my specifying, everybody comes with SP142 report.
SP142?
SP142.
Okay, great.
If I intervene, then SP263 because it's almost concordance has been proven for SP263.
Bhavesh?
Same as Akshay. Most of the time it is the SP142. But even most of the times our pathology is also asking a consultant whether you require specific test or not.
So my lab often is giving SP263 or 22C3. If I ask specifically for SP142, they are giving it. Rajbhog, Ashwin, what is your idea about the concordance between the different antibodies? Each of the panelists said that there is good concordance. You agree with that or you have some different idea?
Yes, I agree with that.
According to blueprint study, the concordance is maximum between SP263, 288 and 22C3. It's little less with SP142, but it's good concordance, little less with SP142. But here it was SP263. So, Vipul, will you consider immunotherapy, monotherapy for this patient?
The answer is yes, but if the PD-L1 report was not there, the idea for her would be a
So we have 70% PD-L1, it's there.
So now once the PD-L1 is very high,
Yeah.
so now we have an option that we can use immunotherapy alone and to get away all the side effects related to chemotherapy. So immunotherapy, monotherapy is ideal, she is ideal candidate for immunotherapy alone.
Nikhil, in which subset of the patient you will not give immunomonotherapy?
So basically, patient with a PD-L1 score with less than 50%, definitely
yeah.
these are with iron combination. Otherwise, patient who are above 50%, there are both options are open. Monotherapy, usually I don't prefer, only in those patients where I required instant response or patient is required early response. That time I would like to add chemotherapy along with monotherapy.
So Akshay, which are the patients where you will want to have early response?
The high tumor burden patient is symptomatic, maybe a lymphangitic spread or liver metastasis patient or bony metastasis patient, where we'll start with the chemo if we don't have a PD-L1 report, but as soon as PD-L1 comes, we can add immunotherapy.
So high bulk and more symptoms.
Yes.
Basically these two factors. And we'll come to that in the subsequent discussion.
Yes.
Bhavesh, are you convinced that immunotherapy is having better efficacy as compared to chemotherapy?
There's trials, there are comparison checkpoint inhibitor or immunotherapy, monotherapy versus chemotherapy and checkpoint inhibitor, and the efficacy is almost same. But as you rightly mentioned, in this particular patient, it's not that high tumor volume or burden. I think monotherapy is also one.
Right. So this is the list of the trial showing the more efficacy in terms of survival as compared to chemotherapy. So immunotherapy, monotherapy versus chemotherapy without immunotherapy in the first line, and all the dots are on the left side of the line of unity. So better survival, yes.
Just wanted to add one point. I think recently in ESMO 2025 they have presented some data about when a patient is having PD-L1 high, when you combine chemo and immuno, they showed survival is inferior to the only monotherapy, if I'm just remembering.
So that's the new thing which is coming up. We have to look very closely to that,
yes,
because we have now many more options. This was published in 2020.
Yeah.
And this was published in 2021.
Okay.
Right? So chemotherapy, immunotherapy versus chemo and immunotherapy. So survival is similar. right? So this was presented in 2021, and if something has come up recently, we have to keep watch on what is happening now. But largely, Ashwin, you agree with this data, right? In good patient, minimally symptomatic, minimal tumor burden, high PD-L1, there is little point in adding chemotherapy to immunotherapy. It adds to the toxicity, not to the efficacy.
Yes, yes,
right?
but very less often
Wonderful.
we get such situation. Many of the times, in fact, we start chemo and send the sample, and then the reports come. So very less often we get such a situation wherein asymptomatic or less symptom patients are there.
So Vipul, when we actually started giving immunotherapy, sometimes in 2010, 11, 12, at that time immunotherapy was mainly ipilimumab, and whatever data we were having was with melanoma, and there were many patients having hyperprogression, right? So have you seen hyperprogression in some of the patients where you treated with immunotherapy?
No, I haven't came across when
No.
recent these with these new molecules. I haven't came across cases of seeing hyperprogression with these things.
Right. So CTLA1, CTLA4 inhibitors and melanoma, these patients were having hyperprogression sometimes, but of late with PD-1, PD-L1 blockers, we don't see the hyperprogression so frequently. There are 4 positive phase 3 immunotherapy monotherapy studies in NSCLC. On the left side, it's Ipsos and IMpower 110. On the right side, Keynote 024 is phase 2 study, and Keynote 042 is the phase 3 study. And on the extreme right, the second last box is Empower Lung, which is not available over here. So we will not be discussing about that particular study. But apart from that, we have 3 phase 3 studies where there is improvement in the outcome, whether it is PFS or overall survival, with immunomonotherapy as compared to the other treatment. And Bhavesh, which will be your preference? So we have 2 drugs, Pembro and Atizo.
So, my point of view, both immunotherapy, Pembro and Atizo, both are same if I am using monotherapy in metastatic non-small cell.
Right. So if you look at IMpower 110, our purpose today is not to have head-on comparison of one versus other drug. Our focus is going to be on atezolizumab. So it is atizo monotherapy versus chemotherapy in squamous as well as non-squamous high PD-L1, and this trial had tested PD-L1 with SP142. Our patient had SP263, 70% PD-L1, and I will show that slide in a minute about the equivalence of the 2 testing. The primary endpoint was overall survival, excluding the patient who are carrying EGFR and ALK mutation. So if we look at median overall survival, it is 7 months better, 20 versus 13 months, which was the primary endpoint. There was initial overlap. Initially chemotherapy had some better survival, where there some dropout, but towards the end, the line is flattening with immunotherapy, with chemotherapy as well, but it is flattening with immunotherapy. And don't look at the extreme right corner, because if you look at the number of patients at risk in the lowest line, so at the end of 28 months, it is 6 patients and 3 patients. So with that number of patients at risk, it doesn't really carry the significance. So we have to look at the early part of the curve where there is clear separation. And this is about PFS. It is the 8.2 versus 5 months. Again, a wide separation maintained towards the end of the curves. Good response rate, 40 versus 28.6%. And if you look at the duration of response, it is 8.3 versus 38.9 months. So, Ashwin, what is the importance of duration of response for your selection of the treatment?
So when we talk about immunotherapy, I think duration of response needs to be considered, because it is said that most of the responses are durable when we add immunotherapy to the treatment.
So I will come back to this question in one of the subsequent slides. So remember, this was 40 versus 28% response rate, and 38.9 versus 8.3 months of duration of response. And I will refer to this particular point in subsequent slide, one of the subsequent slides. So 3 trials placed side by side, IM power 110 with any PDL1 expression, Keynote 024 with PDL1 more than 50%, and Keynote 042 with any PDL1 expression more than 1%. 1:1 randomization, all of them. Good number of patients. Liver metastasis, 17% of patients in IM power, and it's not specified in the other 2 trials. They were there, but it's not specified. Squamous as well as non-squamous carcinoma. And in Keynote 024, the survival was 30.3 versus 14.2 months. But only PDL1 more than 50%. Different subset. We should not be comparing the cross-trial comparison. Keynote 042 as well as IM power 110, it is 20 versus approximately 13 months, 12-13 months. And grade 3-4 toxicity is equivalent. So there is little to choose between one over other. Toxicity is slightly favorable with atezolizumab. So atezolizumab is one of the good choice. When there is more or less equivalent data, how do we select the drug? Is there any way? We will never have the head-on comparison. Nobody will do that for you. So Vipul, how do you select?
It's very difficult to answer this when they are not head-to-head compared. But if we have to compare, we look at the numbers, like which numbers are better. And with this scenario, the numbers are better with atezolizumab as compared to others.
So network meta-analysis is some sort of statistical jugglery. It's a good way of looking at it, but don't look at the network meta-analysis too seriously. Don't look at this too seriously. It depends on who does it, for whom, and how. So but there is network meta-analysis. I hope that the Roche people will not kill me for making this statement. Anyway, according to this network analysis, camiplimab is having the best difference in the 2 arms of 13 months, but atezo having the next best 10.4 months, and the other drugs, Nivo plus EP as well as pembrolizumab, compared with the comparator is having smaller benefit according to this network analysis. And the same is true for the adverse events. On the top forest plot, it is treatment related adverse event grade more than 3, where atezolizumab is showing favorable profile. Adverse event leading to treatment discontinuation, again atezo having favorable profile. Any grade immune related adverse event, and in the lower forest plot it is grade 3 and 4 immune related adverse event. So look at the adverse event, look at the efficacy. Atezo scores a little better over the other immunotherapeutic drugs. So this is the comparison of SP142 versus 22C3 versus SP263. From the samples of this particular trial, IM power 110, the samples were tested by the other methods as well. And whatever method you select, you keep on seeing the separation in the curves. So you can interchange between the different methods of testing. So IM power 110 is the positive study for squamous as well as non-squamous. For high PD-11 expressors, there is good improvement in the PFS, in the response rate as well as in the overall survival. Safety is good enough. The second subset. Now, for urothelial carcinoma, we have very clearly defined criteria for cisplatinum eligibility, for any platinum ineligibility, and so on and so forth. Do this criteria apply to NSCLC, Vipul?
There are any separate criteria for NSCLC, but for the head and neck cancer, for the bladder cancers, what criteria we apply is one is ECOG performance status, the other is a creatinine clearance of less than 40 makes them ineligible. So similar
less than 30.
We can apply it over here.
Right.
Even the if there is any sensory neural hearing loss, if there is any neuropathy. So like with these basic considerations we take. So
Nikhil, we can extrapolate, right? From the data available on formally available for urothelial carcinoma, we can extrapolate for lung cancer, for that matter any cancer as well. Forget about the criteria, Akshay. There are always some patients where you are wondering whether you will be able to give the doublet chemotherapy or not. Which are these patients?
With comorbidity,
Comorbidity,
PS2 patients, maybe age more than 70-75 years, they're having underlying COPD problem because I don't know whether they will tolerate the doublet chemotherapy or not. So these are some subset where...
And renal function.
Yeah,
right?
so renal function.
ECOG, NYHA class.
Yes.
So these are few things. Bhavesh, there is always a patient whom you think that you will not be able to give a doublet chemotherapy. And what do you do for these patients?
Most of the time when patient is ineligible for doublet chemotherapy, our clinician choice is to give immunotherapy.
Right.
Whether, like if this case is a adenocarcinoma, and our choice will be the pemetrexate and carboplatin or cisplatinum, but especially cisplatinum because of the hydration or the fluid overload. Generally more than 75 years, especially I am working in SIMS hospital where most of the patients also have cardiac morbidity also, where most of the patients is ineligible for platinum, where I will give immunotherapy, monotherapy.
Right. So Ashwin, we will discuss about immunotherapy half a minute later. If you have to give a chemotherapy, right, then you know that you will not be able to give a doublet chemotherapy. You will have to give a single agent chemotherapy. What do you give?
So single agent taxane or gemcitabine in case.
Right. So, so this patient, I am not going to the details of this patient. This patient was not eligible for doublet chemotherapy for whatever reason which have been mentioned over here. So there are several phase 2 trials and at least one phase 3 trials of docetaxel by Hainsworth in 2007, and all other are phase 2 clinical trials, and the survival in these trials ranges from 4.7 to 9.8 months, and in the particular phase 3 trial of docetaxel, the survival was 5.1 months, right? So if we look at immunotherapy, Bhavesh said that he will give immunotherapy, but we don't have very good evidence, strong evidence for a few immunotherapeutic drugs. There is no randomized phase 3 trials for pembrolizumab, and with the phase 2 trial that we have, PEPS2 trial, the survival was 7.9 months in the first line patient, and median PFS was 4.3 months in the first line patient. And I will come back to this point that we should not look so very closely to the median PFS and overall survival when we give immunotherapy, but nivolumab and ipilimumab, the trial was stopped because of poor overall survival. So was durvalumab trial, which was stopped. So now we have Ipsos study, which is a randomized trial, and these are the patient subsets. There are many patients of ECOG performance status 3. There are some patients with ECOG performance status 2 with comorbidities, more than 70 years, more than 80 years, and so on and so forth. So this is the disposition of these patients, having various reasons for not being eligible for the doublet chemotherapy. And in these patients, this is the overall survival, 10.3 versus 9.2 months. Doesn't look so very different. But the HR is 0.78, because if we look at this curve, the curve starts separating actually after 1 year, and it keeps separated till the very end. And because of this separation, the HR is better. And in immunotherapy, we see the difference beyond a point in time. So the better way to look at the difference in between the two arms is the survival at the end of 12 months, maybe 24 months, maybe 36 months, and that's where we look at the real difference between the two arms. So I think, Ashwin, I asked you about the difference in the duration of response. Yes. I asked you, and I just forgot. So here also we find that the duration of response, look at the bottom of the bars, 14 months versus 7.8 months. So are you happy with this difference?
Yes, sir.
Yes. So look at the response rate. It was 16.9 versus 7.9 months. So only occasional patient had a response, right? And in those occasional patients, when there is a difference in the duration of response, for the entire subset of the patient, entire group of the patient, it doesn't carry so huge a meaning. So if the response rate is beyond a particular point, maybe 40, 50, 60% response rate is there, then we look at the duration of response. But with response rate around 15, 16% and 7.9% in Zaram, I think the duration of response is not so very important. So I agree that for immunotherapy, it is the duration of response. But we need to have the response rate of a magnitude, then it will be very important. If you look at the safety of immunotherapy, so quickly, anyone want to say that safety of immunotherapy is equivalent or worse as compared to chemotherapy, or everyone is agreeing that safety of immunotherapy is better than chemotherapy, right? We don't want to have discussion on that. Fine. So ECOG, poor renal function, age and comorbidity, everything was taken care in the Ipsos trial. So we have phase 3 trial showing that patient where we cannot give doublet chemotherapy, it is better to give atezolizumab, phase 3 evidence having the improvement in all the parameters which were tested. So TKI progressed NSCLC. This was the patient with EGFR deletion 19. At the end of 15 months, patient could not tolerate pemetrexed, so it was discontinued. Osimertinib was continued, and in the 3 more months, so at the end of 18 months, patient had a clear progression with reasonable performance status. Fresh biopsy done and no further mutation. So let us not discuss about the fresh biopsy and more mutation and small cell transformation and so on and so forth. So Vipul, how will you treat this patient?
EGFR positive patients who has progressed on pemetrexed plus osimertinib combination, and at the further biopsy there is no additional problems, so it's the same mutation. So the one option is there in the current era is the combination of amivantamab with the lazertinib that is not available.
Lazertinib is not available, yeah.
So the most commonly used option in this scenario is using chemotherapy.
Yeah.
So other chemotherapeutic agent or chemotherapy plus VEGF inhibitions, and even the combination of the chemotherapy VEGF inhibition plus immunotherapy like the ABCP type of regimen. So there are these 3 options available with this at this point of time.
Right. So Nikhil, he said the same options which I have mentioned. What you will select and why?
Pardon, sir?
What will be your choice and why?
So definitely, if there is no further actionable mutation, and then either chemotherapy or chemotherapy along with immunotherapy, it's based on the performance status of the patient.
Chemotherapy and immunotherapy?
Means ABCP protocol, where the...
ABCP. So chemotherapy, immunotherapy and anti-VEGF. Right?
Anti-VEGF.
Okay. So Akshay, immunotherapy and chemotherapy, or you will want to add VEGF? Or only chemotherapy?
I'll prefer adding VEGF because patient has already progressed on one line of chemo plus targeted.
Right.
And I think there was some data where patient was pre-treated with EGFR, had some VEGF increased level of expression and can be benefited. Even I most of the time use docetaxel, chemo and BEV if patient is not affording for immunotherapy. So that also worked very well.
So only immunotherapy is not an option, right? On the left side of the curve, there is some scientific rationale which I have not understood. I have not tried to read on that part. But on the right side, the curve shows that there is some rationale of giving VEGF therapy to the patient with EGFR inhibitor. There is beta trial of bevacizumab and erlotinib, and then there is ramucirumab and osimertinib trial as well. So bevacizumab works in the patient who carry EGFR mutation. So it makes sense to add bevacizumab and maybe immunotherapy. And there are several trials, and IMpower 150 is one of the landmark trial where this comparison has been analyzed in more details. So out of 1200 patients on the left extreme, there are 78 patients on the right extreme with sensitizing EGFR mutation and prior TKI therapy who were taken in this trial. So small number of patients, 78, but 78, it's not 20 or 30 patients, it's 78 patients. And if we look at the PFS, and this trial was having two co-primary endpoints, PFS according to investigator as well as the overall survival. If you look at the PFS, there is 3.5 months gain with good hazard ratio of 0.59. And if you look at the overall survival of on the right side, ACP versus BCP, 14.9 versus 18 months. So ACP was actually doing worse as compared to BCP. But on the left side, ABCP versus BCP, it is 18.1 versus 27.8 months, 9.5 months gain in the overall survival. So this was not the pre-specified subset analysis. So, but there is significant clinically relevant gain in the overall survival. And if you look at the overall response rate and duration of response again, so this is 71% of overall response rate, very good, and 42% of overall response rate with BCP, and the duration of response of 4.7 versus 11.1 months makes sense over here, right? So coming to liver metastasis, and we know, Bhavesh, liver metastasis is a bad disease, right? Irrespective of whatever you do, liver metastasis is a bad disease. So any specific consideration from you how to treat patients with liver metastasis any differently from the other patients, other metastases?
We are at present discussing about the non-small cell lung cancer.
Yeah.
And like you had told so many times, like for bladder cancer or for breast cancer or for other cancer. But I think for non-small cell lung cancer, liver mets is not a different. I am treating like depend on the patient's factors or the age and the comorbidities. But I think the liver metastasis, the most important point is the tumor burden. And we consider is a high tumor burden rather than like your first case having only bone metastasis.
I will come back to you with tumor burden. Ashwin, this graph shows that if we compare with other sites of metastasis, liver metastasis is having a worse prognosis. This is not specified with the treatment offered to the patient, but in general, liver is the bad site of metastasis. You agree with that, right?
Yes, yes, sir. I agree.
So, if you look at different trials of immunotherapy, chemotherapy, and with or without bevacizumab, whatever has been given. So, in every trial, liver metastasis patients were there. But if you look at the difference in the outcomes, whether it is PFS or overall survival, the gap was smaller in the patients with liver metastasis, except in Keynote 189 and IM Power 150 studies. In Keynote 189, liver metastasis was not the pre-specified subset analysis, while it was in IM Power 150 study, and let's see what happens to this patient in IM Power 150 study. So this is the PFS difference, and there was 3 months gain, which was sustained towards the end of the curve, right, with a very good hazard ratio of 0.41, and this is the difference in the survival. 9.1 versus 13.2 months BCP versus ABCP, and 9.1 versus 7.7 months BCP versus ACP. So ABCP is having 4 months gain as compared to BCP. And again, 60.8% overall response rate with liver metastasis, 41.1 with BCP, and the duration of response was 10.7 versus 4.6 months. So 60% response rate. So here it makes more sense. So finally, bulky disease, and I think I will ask Ashwin, what do you mean by the bulk of the disease?
Liver, you can say liver, systemic organs, liver, lung, studied, or visceral crisis.
So
definition.
It's subjective. I mean, there are no objective criteria, right? Looking at the patient, looking at the performance status, and so on and so forth, symptoms, we try to assess how soon we require the response in this particular patient. Right. This patient was having KRAS mutation, and Vipul, will you give immunotherapy to the patient with KRAS mutation?
Yes, the KRAS mutation is the population where it's like poor prognostic sign, and in like with most of the possible chemotherapies, the outcomes are dismal. But it is a population where immunotherapy works in some better way. So in KRAS mutation, when the KRAS molecule inhibitor is not available, the immunotherapy should be considered.
Right. So I have 2 trials at my center, and I mean there are several centers across the country where the first line trial of KRAS inhibitors are available, and the comparator here is for patients with PD-L1 more than 50% and low tumor burden, low symptoms. It is immunotherapy versus immunotherapy plus KRAS inhibitor. And for the patient with higher tumor burden, higher symptoms, it is chemotherapy, immunotherapy with or without KRAS inhibitor drugs. So this trial is going on, but as of now the first line option is immunotherapy with or without chemotherapy, right? So bulky tumor, PD-L1 15%, KRAS mutation and systemic inflammatory sign, high LDH and CRP makes this particular patient a poor risk patient. And if you look at the outcome in the patient with sum of longest diameters and number of metastatic sites in more than or equal to third quartile, which is high burden, and low burden less than third quartile, the median overall survival, look at the second line in the gray bar, 15.5 versus 10.7 months, and it is 20.3 versus 17.1 in the low tumor burden, and number of metastatic site more than or equal to median or less than median, 17.6 versus 12.5 and 22.5 versus 21.5 months. So ABCP works better with higher risk of the patient. So we should be giving ABCP to this patient. So in summary, PD-L1 monotherapy is good enough for low risk patient, low symptom patient with high PD-L1 expression. Platinum ineligible patient as per Ipsos trial, atezo monotherapy can be given. And EGFR, I mean TKI treated patient, we can give ABCP, and high risk as well as bulky disease, liver metastasis, we can give ABCP. So any final comment from any of the panelists? We have a little less than 1 minute. Quick comment and then we can stop the discussion.
Good amount of data for single agent immunotherapy for our frail platinum ineligible patients with high metastatic burden, not willing for chemotherapy. So yes, looking at newer molecules coming up in the market, let's see how.
Let us see. Yeah.
Yeah. So immunotherapy is good.
At least we should know that how many high PD-L1 among all the patients. It may be more than 50%, 60%, might be a 20% of all the metastatic non-small cell. So high PD-L1 and high tumor burden. That subset we have to be identified and we have to treat with combo therapy. And with a low tumor burden, a monotherapy is also a good option.
Great. Wonderful. So thanks to the organizer once again, and thanks to my panelists for the wonderful discussion. Thank you very much.
Thank you, Dr. Chirag, and thank you to all our panelists. It's time to delve into metastatic breast cancer, a domain where systemic therapy, molecular profiling, and patient-centric care converge. I invite our session director, Dr. Pranjali Gargil, breast surgeon Pune, and session coordinator, Dr. Ritu Dave, consultant medical oncologist Pune, along with our chairpersons, Dr. Ajay Jadhav, consultant cancer surgeon Nashik, Dr. Shona Nag, senior medical oncologist Pune, and Dr. Priyadarshini Kulkarni, head Symbiosis Center for Supportive and Assisted Care, Pune. To start this session, may I welcome Dr. Shona Nag to discuss how molecular profiling can guide targeted therapy in metastatic breast cancer.
So good afternoon, everyone, and I've taken the liberty of changing the title a little bit. Breast cancer is not there as lung cancer is. We're not that mathematical. There are a lot of nuances in our trials, and the inclusion and exclusion criteria are really, really important when you're considering these treatments. So we're going to discuss germline and somatic testing for metastatic breast cancer, what are the evolving treatment algorithms. And I may go a minute or two up, so I request the chairpersons to bear with me. So we know it remains an incurable disease, and although the median survival has really gone up in HR positive and HER2 positive subtypes, varying from 57 to 68 months, metastatic triple negative remains dismal at 16 to 18 months. The current therapies don't only include chemo and hormones. We've also introduced targeted therapy, immunos, and ADCs. Drug resistance remains a big problem, and advances in NGS have enabled to identify certain targets which are amenable to newer therapies and in combination with IOs and ADCs. So when we look at metastatic breast cancer, it's important to differentiate de novo disease or disease that is post-adjuvant treatment. The subtype is critical. The rebiopsy of the metastatic site or a liquid biopsy, especially in discordant cases where it's not fitting in with the clinical picture, or there's been a long disease-free interval and you really want to know whether the biology has changed. And what we look for, because looking for a receptor loss is common sense. As a ER-positive disease goes on metastasizing, it's bound to lose the ER receptor. So you're looking for a receptor gain, which is even more rare and something that you can target, and the acquisition of newer molecular alterations. Previous therapies are exceedingly important here, and the time that the patient has been on this therapy is also important to factor your decisions, ECOG, symptoms, comorbidities. Tumor burden is critical. So you can continue certain treatments if there is an oligoprogression, and it's important to know that so that you can derive the best out of your newer targeted therapies. The sites of METs are critical, and liquid biopsies have really been limited now to looking at the alteration of the PIK3-mTOR pathway or the detection of ESR1 mutations, and of course, germline BRCA and PALB2 testing. So let's start with the different subtypes, and I'm going to quickly go through a few algorithms so we get an overview. It's impossible to go into each clinical trial, so I've tried to simplify it. Looking at hormone receptor positive metastatic breast cancer, in first line you have two clinical situations. You have the de novo metastatic breast, or you have the recurrence beyond 12 months of adjuvant therapy. Now that we do extended adjuvant, this situation has become even more complicated. So what you do in this case is you do a standard AI with a CDK4/6. That is still the standard of care. This is referred to as endocrine naive or sensitive disease. And you can see a doubling of the PFS almost to 2 years with all the different CDK4/6 inhibitors, and 2 out of the 3 have shown you a OS benefit as well. If we look at the endocrine therapy resistant, this is the second first line setting I'm talking about. This is recurrence while on adjuvant or within 12 months of completing adjuvant. These patients are not going to do so well. At this point, if you have a drug like inavolisib available, it is not yet available in our country, you might want to test for a PIK3 mutation, which remember is a clonal mutation, and it can come up at any time. And the combination of palbociclib, fulvestrant, and inavolisib in the INAVO 120 showed you a great PFS benefit of 10 months and a OFS benefit as well of 7 months, which is quite considerable. We know PIK3s do badly. We know they don't respond or get the same benefit from CDK4/6 inhibitors. They develop liver metastasis early. They develop bone metastasis, brain metastasis early. So it's a phenotype which is easy to recognize in the clinic. So looking at resistant disease, the partner is fulvestrant with CDK4/6. You do see a good benefit in PFS, not as great as the benefit you're seeing with more sensitive disease, and a OS benefit for some of the CDK4/6 inhibitors as well. The question then arises on a molecular basis, before there is radiological progression, can we intercept resistance? And the foundation was laid down by Nick Turner, where he looked for ESR mutations proactively in the PADA trial, and then switched over to fulvestrant instead of the AI, and found there was a PFS benefit of almost 6 months. So this strategy seemed to work. This then translated into the SERENA-6 trial, where they looked at ESR1 mutations, and what you need to remember is you can't get ESR1 immediately. You will get it after treatment on AIs for at least 6 months. So between 6 months and 3 years is the time where you will check for ESR1 mutations, and you can do this with a liquid biopsy every 3 months. So when they did this trial, what they did was they added a SERD preemptively to the CDK4/6 instead of the AI. So they replaced the AI. And yes, they did find a good PFS benefit of almost 7 months. Is this practice changing? The problem is there was no crossover in this trial. So the radiological progressors did not go on to receive camizestrant when they progressed. So we really won't know the benefit, and it is still not ready for prime time. So what are the clinical practice guidelines in the second-line setting of ER-positive disease? So this is the point at which molecular testing comes in. And if you look at the alterations of the PIK3CA pathway and you look below at AKT and mTOR, you have the Capitellos trial, which is mainly an AKT inhibitor, capivasertib. It showed a good PFS benefit of about 4 months. And then you have the Bilev in previously CDK4/6 treated patients for PIK3 mutations. Alpelisib, which I personally find is a difficult drug to give in the clinic. Beyond that, you can check for ESR1, and you have the Emerald trial in patients who had been on CDK4/6 for more than 12 or 18 months was the maximum benefit with a great PFS gain. The Ember trial used imlunestrant, a new SERD. Here, it was a very, very funny design of a study, but you found that the imlunestrant over standard of care, which was fulvestrant, and believe me, I don't think fulvestrant alone is a good drug in the second-line setting. You get very, very short PFS. And it combined, so it outdid fulvestrant, but the combination of abemaciclib and imlunestrant did even better. So perhaps this is a strategy that will work for co-mutations of PIK3 and ESR1, and we do see them in our clinic. What about BRCA mutations and PALB2 germline? Yes, you have evidence from Olympiad and Embraca. Again, a PFS benefit, no overall survival benefit, but there was a subgroup of Olympiad which received PARP inhibitors in the first-line setting, and that group, 25% of them did show an OS benefit. So if your patient prefers oral therapy, you might want to start off, and there is a low tumor burden. And I have used this strategy. They do very well with oral PARP inhibitors. And of course, don't forget Bolero-2. Many a time have I fallen back when there are no mutations, no obvious targets, to good old everolimus. It does the job, and if you look consistently in the second-line setting, you're seeing a PFS across all trials between 7 to 8 months. And surely we need to do better than that. What about continuing the strategy of CDK4/6 beyond progression? I do use this strategy. One single bone met coming up, patient has been doing well for a year. So if they progress within 6 months, it doesn't make sense, but they've had a long PFS on CDK4/6 and you suddenly get a met coming somewhere, radiate that and continue the same. I've done it for several patients. I've got young patients on CDK4/6 for 2 years who've progressed only in the breast. We do a surgery and we continue the same, and they're going on for 2-3 years more. So that's away from the data from Maintain and the post-Monarch study, which showed modest PFS gains. Nevertheless, it's a good strategy to use in the clinic. And third line and beyond, you get pretty stuck. You have to get back to cytotoxics. Can we do better? Yes, with the ADCs around. We need to check for HER2 low status. Go back, look at the reports, resend the HER2. Remember, it's a dynamic marker. It's going to change every 6 months. You need tissue for this. So if you get a 1+ or 2+ FISH negative, I'm not very happy with the ultra low data, but I do use ADCs in more hormone receptor positive resistant patients. Data is there from Destiny 4, which are one chemo treated, Destiny 6, which are chemo naive. Great PFS benefits in the range of 10 to 13 months. The Tropics use saxituzumab, another ADC. This was also a positive study, but good for HER2 0 patients. And the tropion using Dato-DXd was a negative study. So ADCs are something you can fall back on. Let's shift gears to HER2-positive metastatic breast cancer. The question on everybody's mind is, after the Destiny Breast09 results, will TDXD and pertuzumab replace the standard THP regimen? And secondly, do we treat HR-positive and negative HER2-positive patients a little differently, because they do behave differently, especially in terms of maintenance treatments? So the Destiny Breast09 had 3 arms. Remember, only 2 arms have read out. That is TDXD pertuzumab versus THP. And what you're seeing is a 40-month PFS versus 26.9. I must remind you that in Cleopatra, it was about 19 months. So even the control arm did better, and it was great responses, duration of response. I would wait a little bit. The OS is only 16% mature. The question is, a toxic drug like TDXD, are you going to continue it indefinitely? Like Traspert, we're all using Traspert. We're very happy with this drug. And we have patients going on for 3 years, 4 years, 5 years without a problem. Or are we treating over-treating ER-positive, HER2-positive disease? A lot of questions remain. There is data that you can use hormones with dual anti-HER2. The Patina had a PFS of 40 months, just adding palbociclib to the AI and the anti-HER2, similar to what you saw with the TDXD pertuzumab. So think about it. Maybe HR-positive patients need different treatment. And this is your guideline. Cleopatra still stands. The question is, I'm sorry, I'm going to take 3 minutes more. If you keep ringing the bell, I can't do that, all right? So this is important. SABCS 2 days ago read out the HER2 CLIMB-05 data, potentially practice changing. Just adding an oral tucatinib to maintenance Traspert has improved PFS significantly to 25 months, irrespective of subgroup. So maybe this is something less toxic, and this is something we can think about. And second line, you are stuck between tucatinib, trastuzumab, capecitabine versus trastuzumab, deruxtecan. You use the brain met status in the second line setting, or go back to TDM1. Nothing wrong with giving TDM1 if your patient can't afford TDXD. So these are all different options available. Third line and beyond, please use what you've not used already. Go back to trastuzumab chemotherapy, go back to LAP-CAP, go back to LAP-TRAST, and all the different combinations. The last part is triple negative, and I'll be fast. So the first line algorithm is changing. With ASCO and ESMO this year, we are even more confused than we were. So the first line de novo, or the longer responders that relapse after 6 to 12 months after completion of adjuvant, PD-L1 testing is paramount. Do not proceed without that. And there is data to show that in PD-L1 positive patients, we do use pembro chemo. We're all doing it as per 355. But now there is new data from ASCO and ASCENT-04, where saxituzumab has moved in frontline. So it has shown a PFS benefit, but the OS is immature. I'm going to wait on this. The ineligible or negative patients do a germline BRCA, offer PARP inhibitors, but again, Saxi and Dato have both moved into this first line of setting. So data was presented at ESMO and published in NEJM, ASCENT-3, Tropion B2. You have an excellent PFS benefit over chemotherapy alone. So these are your different immunotherapy trials, and what we are using is 355 more commonly. Atizo is still used in Europe, and you can consider it in some patients. What about those who are rapid relapsers? Again, goes by germline BRCA status. PARP inhibitor for lower tumor burden. If you haven't used it already, you may want to use SG in this setting. You also have saxituzumab tiromotecan, which is a Chinese ADC, which shows very good PFS benefit. And at this point, which is a difficult to treat tumor, you might want to do a CGP, but please, please look for a HER2 low status. 10% of the Destiny Breast study had triple negative patients. They were approximately 60, and they seem to derive the same benefit as HR positive patients. ADCs are the future in metastatic triple-negative cancer. They target TROP2, have a similar payload, but more important are the bispecific antibodies, and these are going to come in a very big way. PM8002 attacks both the immune checkpoints and VEGF, and this is going to be the future. So in conclusion, advances in molecular profiling and targeted therapies have translated into survival benefits, but therapy resistance and cumulative toxicity do limit long-term disease control. The treatment landscape has evolved. We have patients living for long periods with a decent QOL. Lot of work has been done, though our therapies have developed at a rapid pace. Our biomarkers have grossly lagged behind. The future, I think, is next-gen ADCs and bispecific antibodies, and real-time monitoring for relapse may soon become routine practice, especially in the early setting and especially in HR-positive metastatic breast cancer. Thank you for your attention.
Thank you, Dr. Nag. That was a very, very comprehensive.
Immunotherapy TNBC has evolved and all of us are using that. I have one small query. That in metastatic setting, PD-L1 testing before using IO in triple-negative breast cancer is mandatory. But for NSCT, whenever we are using IO with chemo as a part of NSCT TNBC, PD-L1 status is not mandatory. So what is your thought on that?
So it's important to remember when you're giving neoadjuvant chemotherapy, your nodes are still very much there. And they kind of make the tumor an immunogenic tumor. After the metastatic setting, because of different therapy selective pressures, as we know, that immunologically hot tumor turns cold. And it doesn't work that well in negative patients. And therefore, we really don't require PD-L1 testing in the earlier setting.
Thank you, Dr. Nag. That was a fabulous encapsulation of a very, very broad topic. I don't know how you do it. I do have one question. Sorry. Do you do NGS testing and molecular testing at every progression? Like, ideally, would you if costs were not an issue? Like,
so it's going to change. Like there are certain mutations that come up at certain times. So since we don't have a first-line drug like inavolisib, which would make me test for PIK3CA at the time of metastasis, at the time of second-line treatment, I do look for a panel of ESR1, PIK3, BRCA, and all these mutations. But at every relapse, if I have tissue, I will check for these mutations, if affordable, and I will definitely check the HER2 status, because wherever I can get in with deruxtecan, I will try and get in. And we know some of these are dynamic markers. PIK3 usually doesn't change. Once it's positive, it's positive. But being a clonal, it can show up at any time. ESR1 usually shows up 6 months into the treatment and not beyond 3 years. So you have that window in which you can test.
Thank you.
Thank you, ma'am. Our next talk addresses a critical yet often understated aspect, palliative care. May I invite Dr. Rutula Sonavne, Consultant Palliative Medicine, Pune, for her talk.
Hello everyone, good afternoon Chair. Thank you for the opportunity. So today I'll be briefly taking you through the 5 key take-home messages for all of you from palliative care perspective. So the first one would be to integrate palliative care as early as possible and concurrently with your ongoing disease-directed treatment. So the recent ASCO update guidelines for palliative care basically recommended involving palliative care unit or team as early as 6 to 8 weeks, and it can be done from the diagnosis itself, not as an alternative but as a complement to active ongoing treatment. It has shown certain evidence-based benefits, which basically involves significant improvement in quality of life, enhancing this symptom control throughout the treatment, which led to better treatment adherence and also survival benefits in multiple cancer types, and has also shown to reduce hospital and healthcare costs and emergency visits. So the delay in patient referrals often lead to a missed opportunity, which led to a lot of caretaker fatigue and compassionate fatigue in the vulnerable population. Second would be to maybe help with the communication, as they are primarily under the care of the oncologist, so they have a certain trust in the treating team. So communicating with them earlier becomes a key. Early conversation regarding the goals of care and the disease trajectory help them make concise and practical decisions early on, and that should be regularly reassessed, just so that the goals of care have not shifted from, let's say, a complete cure to palliation to end of life. And the use of compassionate language is important, because it is a very difficult time during the diagnosis and further down. So using empathetic, compassionate language is the key. So palliative care basically focuses on symptom management and holistic care. So the symptom management not only pertains to physical symptoms like pain, but can include psychological support, social care, and spiritual need, which lead to a lot of stress, anxiety, and depression in the patients. So this also helps to align treatment according to the patient's preferences and values and the goals of care that they have. So it's essential to regularly assess and document the evolving goals of care. It is important to adapt the treatment plans according to the priority shift that occurs during the treatment and during the trajectory of the disease. It also facilitates the family and the patient to take shared decisions regarding the treatment and further care, and also balances the curative intent with the quality of life considerations. So early integration has shown to reduce unwanted aggressive interventions, especially near the end of life, while honoring patients' autonomy throughout the disease trajectory. So certain myths about and misconceptions about palliative care is that it's equivalent to hospice care, which is not true, as hospice is just a very small part of what palliative care entails, and is generally focused on just end of life care. Palliative care also means giving up on the patient, whereas it's complete opposite, wherein we enhance hope by improving the quality of life and controlling the symptoms, wherein they are much comfortable throughout the treatment trajectory. And as it's not only for terminal patients, it benefits from the time of diagnosis to end of life, and we extend it beyond to bereavement care as well. So impact of early palliative care, there have been multiple trials on the early palliative care integration, and they have consistently demonstrated that there is superior symptom control, there is improved mood and reduced depression, higher treatment satisfaction and adherence, there is better quality of life scores, and there is more appropriate end of life care. So barriers in oncology practices is that the specialists involved in palliative care are limited, especially in the rural settings, which creates barriers for many patients. The solution for the same is that primary palliative care can be given by anyone, especially the oncologist, so which helps in better communication and symptom management. If certain symptoms aren't being managed properly, telemedicine can be used as a tool to help guide the treatment for the patient better. Practical steps would be universal screening of all the patients, proactive referrals to specialist palliative care, regular reassessments of not only the symptoms but also the goals of care involved, documenting these goals of care and treatment plans, and making changes wherever the priorities have shifted. And it should be an ongoing discussion to foster better communication with the patient and the relatives. So in conclusion, we need to embrace palliative care as an integral part of oncology to enhance the quality of care given and to make it into holistic approach to patient and not only the disease. Thank you.
Thank you, Dr. Rutula, for covering all the necessary points. Would you like to add in your practice how many patients of cancer really get referred to you and when?
So generally, I do get references from the oncologist very early on in the disease trajectory. There are certain times where it is particularly only during the end of life wherein it becomes difficult for me to kind of gain the trust from the relatives or the patient, just because I've come in very late and the symptom burden is quite a lot. So they are very resistant to whatever treatment I have been suggesting. But when they are referred earlier or in between the, while during the treatment is going on, it's a bit better. And also the improvement in their quality of life and the tolerance to the treatment also improves. So they kind of, the continuity of care, not only in the hospital, but even at home is a bit better when they are referred earlier to my care.
Thank you. Like when we planned this palliative care session, one of the struggles we have, like Dr. Nag beautifully encapsulated so many lines of therapies, but each of these, when we use them sequentially in metastatic cancers, is adding a finite period of time. Like every strategy works, it works for a finite period of time. And unless we have helped the patient achieve some short-term goal setting for this extended lifespan that we are trying to strive for, we really haven't solved for much, have we?
Yes.
Because we're extending life by giving therapy after therapy, and the family is moving from chemo to chemo and hospitalization to hospitalization. And a lot of the mindset in our culture is still to tell the patient that, you know what, wait till you're better, and then we'll get to the other aspects of living life. So I think as oncologists, what we also need to do, I mean, surgeons and medical oncologists both, is to figure out from our patients, get some sort of feedback as to what is it that they have actually solved for between their previous visit and now, between their, disease-free PET scan to their current, okay, now they have progressed, but what they do in between. And I think we're not very good at having these social conversations in our clinic setup, which I think would be great to have a partner in palliative care all the time, just helping these patients solve for short-term goals.
To that, I think I can add to that. As we have seen in Western world, I think apart from medical, surgical and radiation oncology, I think palliative consultant should be a part of team right from the diagnosis of the advanced disease and advanced cancer, and the role should be explained. And families and patients should be given the choice to go and meet them time to time as when they are going through these treatments. It helps them have that realistic hope from the hope of having new therapy, but we are unsure. From that to the hope, okay, there could be some short-term goals we can achieve even if you are going through this difficult journey.
And sometimes I just want to add in a bit. So sometimes when we say that, especially when it comes to palliative treatment that are, multiple lines that we have, sometimes their concept of getting better is very different from what we tend to mean. So it's kind of very important to explain that, this is what we mean, and we are aiming for, let's say, disease control rather than complete cure. So there's a very fine line between what we mean to say and what they understand from what we have said. So I think communication there becomes a very key
point well taken. Thank you. Thank you for a lovely talk. Thank you.
Thank you, Dr. Rutula. We request our in-house guests to kindly check out from their rooms before 1 o'clock if possible. Thank you so much. Now we move on into a panel that brings together multiple disciplines, surgical oncology, ablative therapies and systemic care, aiming to define practical strategies for oligometastatic breast cancer I invite our moderator, Dr. Pranjali Gadgil, breast surgeon Pune, with our distinguished panel, Dr. Aruna Shah Karad, consultant surgical oncologist, Chhatrapati Sambhaji Nagar, Dr. Bhavesh Parekh, consultant medical oncologist, Ahmedabad, Dr. Dattatreya Andure, consultant medical oncologist, Ahmednagar, Dr. Ninad Gadekar, consultant oncosurgeon, Ahmednagar, Dr. Shilpi Dolas, consultant breast oncoplastic surgeon, Pune, Dr. Girija Patil, senior consultant breast oncosurgeon, Pune, Dr. Shalaka Joshi, consultant surgical oncologist, Mumbai, and Dr. Varun Nagori, consultant medical oncologist, Chhatrapati Sambhaji Nagar, to please take the stage.
A warm welcome to all the panelists. Thank you to the audience for staying into the second half of the last day. I was reading all the qualifications of my panelists here, and seeing how many chiefs and heads there are, I'm feeling just like a body right now. All right. So, oligometastatic breast cancer is a subject of interest because it's the only part in metastatic disease where surgeons have something to say, or maybe we think we do. I don't know how much of a role we really have. But I'm going to have my first question for our surgeons as to how do we define oligometastatic breast cancer? Do you have a way of segregating these patients in clinic up front? When do you call them oligometastatic? Is it 1 to 3, 1 to 5, number of sites involved? Any of our surgeons can take the question.
Yeah, it's 1 to 5 number, but amenable for local treatment.
So it's not
irrespective of the site.
Okay.
I would like to add,
yes,
it would be 1 to 5 number of mets, but to localized organs, up to 3, not more than that.
So 1 to 5 mets, up to 3 organs. Dr. Shalaka, do we really have any data to say that 1 to 3 is the right answer, 1 to 5 is the right answer, 1 to 3 sites is the right answer? Or was this just the way the trials and studies were designed and that's why we stuck with it?
Pranjali, I mean, first thing I look at when we talk about oligometastatic is where we are talking about an upfront metastatic patient or somebody who has recurred after a disease-free interval of 2 years, 5 years, 6 years, anything, and that is the oligo recurrence. And the third and the newly emerging thing is metastatic to begin with, but oligo residual. So really, why this has been a data poor zone is because these 3 scenarios are very, very distinct. And it's very difficult to randomize. But anyway, we have some evidence, I'm sure you'll do that. So now, with respect to number of sites and number of organs, so yes, the advanced breast cancer guideline, the ABC guidelines, the latest update was 2022 or 3, I think. They said up to 5 and up to 3 organs. So if you have like a 1 in lung, 1 in liver, 1 in lymph node, 1 in bone, and 5 different organs, then I'm not comfortable treating that as oligometastatic. So I would restrict to at the most 3 organs and not more than 5 sites. So you should not have a widespread organ involvement also. So that's something. And 5 is a really random number, to be honest.
Yeah. And these are the different settings that you mentioned. There's the de novo oligometastatic and the induced post-treatment, either oligorecurrence, oligoprogression, oligopersistence. And a lot of the studies have looked at different subsets of these patients. But all in all, do we all agree that oligometastatic breast cancer does better than other metastatic, polymetastatic breast cancer? Any of our medical oncologists? Do we have enough data now that we're convinced that oligometastatic disease is better than polymetastatic disease?
Hello. Yeah, I think that is again depends on how is the character of the disease, whether it is hormone positive or the HER2 positive or the TNBC. Definitely the hormone positive or the HER2 positive has a better prognosis or better result compared to the TNBC.
So biology does play into it. But
from my point of view, I think the number and the poly or oligo, I always as a medical oncologist feel ultimately it is a multidisciplinary tumor board, and ultimately how my surgeon and my radiation oncologist is happy. Like इनिशियली डे 1 पे HER2 पॉजिटिव है और एक बोन मेटास्टेसिस D7 पे है, जो मेरा रेडिएशन ऑन्कोलॉजिस्ट बोल सकता है कि सर मैं इसको कवर कर लूँगा या एक liver metastasis है.
Amenable to therapy is also important.
So I feel like it's all arbitrary, or like number of 5 and number of site is not important. It is like Pune surgical oncologist might be different than Ahmedabad surgical oncologist. But I personally feel it is a multidisciplinary tumor board, and all the 3 specialties should come together to one conclusion that this oligometastasis, HR positive or TNBC is
hard,
a good
right,
biology.
to have guidelines, because it's so heterogeneous. Every one case I can discuss is different from the next case, and it's important to have that multidisciplinary tumor board helping us make decisions. But there are 2 different things. Like, one is, yes, does it do better? And we know everywhere less disease burden is better than more disease burden, right? Like T1 is better than T3, N1 is better than N3. But in metastatic disease, we seem to have it all binary, like it's M0 and then there is M1. So why is there no M1A? Or are we trying to make some of those M1As as stage 3Ds that we are hoping to accomplish a cure for? It's more a philosophical question. I know we don't have the answers.
Pranjali,
Yes.
I think other than tumor biology, stage at presentation also has a effect on the outcome in oligometastatic disease.
But once they're metastatic, right? Like, in the sense, you're talking about initial stage of presentation?
Yes, initial stage of presentation.
Okay. Now, when we're looking at data, a lot of the data on the fact that, yes, oligometastatic disease does better was, retrospective data, single institution studies, and then we had this NRG-BR002 trial that was presented at ASCO. It was supposed to be a phase 2 study, and the phase 3 got cancelled because they didn't actually show any difference. And this sort of was a real eye-opener, because we were really hoping, right? Like, we were hoping that we're able to ablate. Every radiation oncologist was telling us how much better their gamma knife is compared to the other person's knife. And this panel would have been full of those people going really gung-ho 5-6 years ago, talking about how good we are at ablating stuff. And this trial was negative in all aspects. And any of our medical oncologists can tell us that, can comment on this, that it showed no difference in PFS. It showed no difference in overall survival. Why are we still talking about this? Like, were you happy with having now seen that, okay, these were patients that were not progressing for up to a year on existing systemic therapy, and now they were chosen out to have ablative therapies, either surgery or radiation, and it made no difference, and to the point that they cancelled phase 3. So why are we still talking about this? Can we conclude that, okay, it's the systemic therapy? Here again, we underestimated the benefit of systemic therapy. So our radiation oncologists and surgeons, are we just fooling around thinking we have a role? Shalaka wants to say something.
Somebody else first, if they want to.
If we can add the ablative therapies with the ongoing current systemic treatment, it's definitely better, because ablative therapies or the surgical therapies will give us the better local control.
Local control, no doubt. Symptomatic disease, no doubt.
Compare, there are the different people has the different experiences, but there is definitely some PFS benefit. Again, how is the biology? If it is a hormone and the HER2,
and those are doing great. We just heard a beautiful talk on how many lines of therapies you have in these ER-positive metastatic disease. That's going to do well regardless. Dr. Shalaka.
So, Pranjali, I feel today, with so many options in anti-HER2 arena as well, I don't think an HR-positive MBC is doing better per se than provided you have all the money in the world, as compared to a HER2-positive MBC. And, this retrospective, prospective data we had was really age-old. Systemic therapy was very, 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 very different back then. And the rationale behind them choosing, if you saw 60% bone-only meds in NRG, 60% solitary, and 20% upfront, majority oligorecurrences, or majority where the loco-regional disease was controlled and then the metastasis appeared within 12 months and whatever their inclusion criteria were. But the point is, a 65 and 70 patient study is too small in
It
breast
is small,
cancer
and
today to
this
answer
has been
anything.
conducted in populations where de novo metastatic disease is not as common as our population.
And it is not the
which-
number of drugs available for HR positive or number of drugs available for HER2. It is a biology.
the biology
The
itself.
HER2 positive is a bad biology compared to HR
But
positive.
what we're talking about is how much is metastasis-directed therapy really adding here. So let's.
I
yeah.
was just looking at why they chose a bone-only met and that area, because the retrospective study said that the
These
HR
patients-
positive patients are doing well with the surgical treatment. Hence, they chose a subset. It's a good study in the sense that they at least restricted to a subset rather than.
And 79%
putting all
were
the
ER
eggs into the same
positives,
basket.
more than 60 were single side bone. So looking at a case similar to what, say, would have been, and you know, these are just and no one case is going to be similar to the other when it comes to oligometastatic disease. But in these cases, I've just picked are to engage in conversation, to think about what we're looking at. So this is a lady, she's a 51-year-old who's a scientist practicing in Pune. She presented with a T2 multicentric disease, node positive. And this was ER, PR, and HER2 positive. And when we got her PET, yes, there's of course multicentric breast disease. There is nodes that are lighting up, few nodes in the axilla. But there is this one single site, right eighth rib. The cancer is also on the right, and the right eighth rib has what looks like a MET. Now, there is no history of trauma. And we looked at this PET scan with multiple radiologists, and they're like, no, we're pretty sure this is a metastatic focus. And the next question is, would you get any additional investigations after this PET before you decide on how you're going to treat her, in terms of imaging, biopsy, anything else that should be done to confirm she's metastatic? Is there anything we can do for a single site bone met?
Because it is a HR positive as well as HER2
yes,
positive.
yes.
And it is a multicentric.
Yes.
So it's a clear-cut case for a NSCT. Only if I had a doubt that whether that right eighth rib or oligometastasis, whether I should proven by FNSC or biopsy, if my nuclear medicine specialist or my PET-CT
They are convinced
they are
that
clear
it's
enough.
possible.
With
Yes.
SUV, as you also mentioned, I think
Yes.
it is a very clear.
Yes.
I have no doubt to do at least FNSC from that right eighth rib.
So, and then now when you're counseling this patient in practice, are you going to, how are you going to discuss her metastatic prognosis here? She has a single site bone. You're going to tell her we're going to treat you with curative intent?
Definitely curative intent, definitely.
But we need to explain the regarding the metastatic site also and related prognosis also.
And what do you actually say when you say we're going to talk about prognosis? What are you going to tell her with the information you currently have?
So what I begin with is, obviously all of us would agree here that you begin with systemic therapy. You also put up a case which is HER2 positive.
Yes.
If she was HR positive, HER2 negative, then you would have the question of what systemic therapy you really want to consider. Would chemo help in this setting?
Yeah.
So now that she's HER2 positive, I think it's
chemo. Everybody agrees you would
with
do
the
chemo
targeted.
for this patient. And to our medical oncologist, Dr. Nagori, if you want to take this, what would be your choice of systemic therapy here for this triple positive?
So it's a case of node positive, HER2
Node positive, HER2 positive,
so
ER
clear-cut
positive.
indication for NSCT, as sir said,
Yeah.
whether or not a metastatic lesion is there or not. But considering it to be metastatic lesion and we are treating it with curative intent, NSCT would be chemo
What
along
would
with...
be your drugs? Yeah.
Yeah, I would be using taxane along with a dual anti-HER2.
And dual anti-HER2 would be pretty standard. And do most of your patients in practice afford the dual anti-HER2 therapy now?
Now we recently do have the, generic versions also on patient assistance programs on pertuzumab.
So it's not an issue
So it is,
and you're
now it
able
is quite, much better than
majority
earlier,
of your
yeah.
patients
Most
you're
of
able to
them
get
are-
them on
most of
dual
them, yeah,
anti-HER2
yeah.
therapy. Thank you. So in this patient, she was actually treated with TCH. She did not get dual anti-HER2 therapy. And she had a very good response to just TCH. So she got 6 cycles and nothing was visible anywhere. In the breast, they said maybe there's a residual, maybe not. The nodes had responded.
Can I have a quick comment
Yes.
from the audience? I'm here. Audience. In the audience, I'm here. Yeah.
Yes, hi.
Hi. So, the choice of drugs in chemotherapy depends on whether we want to consider these as metastatic or really NSCT.
Yes.
Dual anti-HER2, I mean, apart from cost constraint, we will give dual anti-HER2 in both the situations. But if we consider as metastatic, we give THP, Taxane, and dual anti-HER2. And if we consider the neoadjuvant, it is TCHP. And here, considering neoadjuvant, I will give TCHP rather than THP.
So, yes, so everybody agrees we are going to treat her with curative intent. We are going to give her NACT with TCHP would have been the choice. This lady was a scientist and she's like, you know, I know about pertuzumab. I'm just going to I'm going to reserve it for later. She had that logic. Is there a logic in that? But no, she did actually end up taking it later, but so she didn't take it up
more
front.
Like non-scientists can't afford it.
Yes.
But, so this is a common scenario that we would end up giving trastuzumab.
Giving TCH. Now, now that she has responded, everything has responded. Even the rib has responded, the breast has responded, all looks good. Now, if she were being treated as metastatic, she would have been on indefinite anti-HER2 therapy, which has again cost constraints. And now, as a surgeon, if she comes back, when she comes back, you're happy to offer her treatment with curative intent. Dr. Girija Patil, do you want to talk about what would be the surgery you would do in such a case? Would you address the rib or just the breast, nodes?
Breast and nodes, both.
Breast and nodes. And what would you do to the rib?
I suppose now that she's come back, she must have responded.
She's complete. There's no visible disease on PET.
So nothing.
Nothing. You leave it. Dr. Joshi, what about, you want to talk about your M1 data and what happens if you operate on primaries and not ablate metastasis? What?
M1 data essentially did not look at oligometastatic or solitary metastatic disease, but in that it was a clear-cut thing that if you have polymetastatic or widespread metastatic disease, surgery has no benefit in OS advantage, no advantage. Here, if she has completely responded in the rib, resecting the rib is not going to be the surgical choice. We are going to do breast surgery depending on mammography, response, BCT, mastectomy, both are acceptable. No data to say one versus the other, so going by what the patient wants. Lymph nodes also, my residents often ask us, now should we do ALND or should we do a sampling and sentinel node? Well, I don't have one answer. We do look at her profession, how much you really want to give her lymphedema risk and things like that, and sometimes even do low auxiliary sampling. If they're all complete response, I don't think removing negative nodes will add to her survival.
And you could just as well do a sentinel.
Resection is not a choice, so it goes to the radiation oncologist and they do consider SBRT. We won't observe that rib. If we are treating her with a oligometastatic intent, currently MDT or metastatic directed therapy is the thing of choice, so we would like to treat
do we have a radiation oncologist on panel right now? Anybody in the audience who's a radiation oncologist, can you ablate something that has completely responded to chemo? So there is a difference of opinion there. Some radiation oncologists say that if you can't see it, you can't ablate it, and if somebody is saying I can ablate something I can't see, then they don't know what they're talking about. Is that true? Anybody want to comment?
I think on presentation, if it is a rib metastasis is there, even if I talk in my multidisciplinary tumor board and talk on the day one radiation oncologist, when after 60 CH, if there is a complete metabolic CR and my surgeon is going to operate, my radiation oncologist will definitely cover that rib area also.
Okay. And they just go a few levels below their standard conventional PMRT and take care of it, right? Not a big deal.
No. I think SBRT is a very different technique.
Yeah.
It's not as
but
simple
in
as what I have.
so they can't see it, but they will still use SBRT.
They do MRI-based planning and things like that. They go by the previous imaging and get those images on their CT planning, and they do use fancier things nowadays. And it's not as simple as doing a chest wall RT, but they do it somehow.
So in this patient, we actually ended up doing MRM, and we did, because it was a right side rib and it was just a few levels below my MRM incision, we resected the segment that was involved, we sent it.
But how would you know where it was if the radiation oncologist also won't know where it was?
Because we went by imaging, eighth rib, it was anterior.
Anatomical presence.
It was, so we...
8th is a fused rib, very low down, so...
And we counted the ribs with intraoperative ultrasound and we went
the
there.
diaphragm.
Single rib resection should not be a big issue.
It was right there, so we resected it. So that was that. And there's no disease in the rib. They did, now that that rib was resected, they just did conventional PMRT. And now the question of what is further systemic therapy. Now you have everything. You have your HER2, you have your ER. What would you give as
so
systemic
as such,
therapy?
because it is a NSCT TCH given, not dual
Yes,
anti-HER2,
yes.
and there is a residual now 5 millimeter.
Yes, in
so
the
the
breast.
conceptualize, if there is a residual, if you use NSCT as a single agent, at least you should use TDM1.
Yes. So now this lady is actually on dual anti-HER2 in the adjuvant setting. She decided, okay, I will opt for the pertuzumab now. And but how long? Okay, we're almost done. We're using one case as our template here. But how long will you continue the anti-HER2 therapy now? 1 year. And at 1 year, you're happy that you would treat her just and then observe beyond that. Yes. If she were, okay, if she were ER negative, what would have been your duration of anti-HER2 therapy? You will treat her like an adjuvant patient and stop at 1 year. Does everybody agree in the medical oncology world that at 1 year you're comfortable stopping anti-HER2 therapy, or does your heart still race a little bit when you're doing it? Because she was M1 to begin with.
So the endocrine therapy backup along with the bisphosphonates would be, I think, a better bet for her.
Yeah, so this lady also took dual anti-HER2 therapy to complete a year, and now she's on endocrine therapy. What about duration of endocrine therapy? Like if there is no disease progression and relapse, which is what we are hoping to achieve, cure for M1 disease. 10 years, will you stop it?
At least for 10 years.
10 years, I think everybody agrees it's 10 years. All right, I think, are we over with time or can we take a case? Okay, our time is up, but thank you. And are there any pressing closing comments that anybody would like to make on this topic of oligometastatic breast cancer? It still exists, we don't have to...
So my next question to you was going to be, will you do a 6-monthly PET for her in follow-up because there was one rib met and she's at a higher risk of developing more? Anyway, there's no answer. So, and we could manage to in 20 minutes discuss only one case with bony met. So we are leaving a lot unanswered. If there were 3 mets, if there were 4 mets, if there were 4 bone mets, 2 liver mets, 1 lung met, what would we have done? And with the current availability of systemic therapy choices, I'm not sure where the surgery stands a role.
I would like to tell you the surgical rule. Basically, contralateral axilla, you can go with surgery clearance for that. Second thing is, as madam has done, resection for this single rib. Not a big problem. Single met in liver, single met in a lung. But obviously, if you have a lot nodules in liver, you cannot just go on doing hepatectomy. You need to do a tissue sparing surgery in those cases.
So we have currently almost, so we treat oligometastatic disease in Tata with a curative intent since I remember. And with a lot of our patients don't afford a lot more systemic and targeted therapy options than there are existing. So we have almost 1,000 patient data set now where we have just kept prospective audit of what's happening. We don't have a comparator and control, but what at one look, PI is Dr. Reema Pathak, it's not me, but we are just looking at 2 subsets right now, the lymph node subset, especially the mediastinal and the contralateral axilla, etc. And secondly, the molecular subtype. The triple negative ones seem to be doing worse.
Poorly regardless.
And maybe eventually we will have an answer here through our retrospective data, prospective retrospective data, is that maybe you do choose your, select your patients appropriately with, and that happens only case-based discussion. We're never going to have randomized data for each patient and shared decision making and see how it.
So I think oligometastatic disease remains a topic for tumor board on a regular basis at all our institutions, and we do need to keep putting our minds together to approach each case on a individualized, personalized basis. So
yes. Again, managing oligometastatic cases in the resources full or in metro cities or in the tier 3 cities, I think it's a different scenario, because in many cases where tier 3 cities does not afford for the pertuzumab. So we need to manage with the TCH, or if not, then paclitaxel only, and then again followed by hormonal plus single agent anti-HER2.
And sometimes by removing, like resecting oligoprogression, resecting some of these single site mets, we're actually, by converting to adjuvant regimens, we're actually saving costs, right? Because indefinite lifelong anti-HER2 therapies and or change to the next systemic therapy is a cost constraint for a lot of patients, whereby if you're resecting that single site and you can continue, get a little bit more out of your existing systemic therapy, that's helpful. So thank you all panelists. I think we're out of time. It was a lovely engaging discussion, and best wishes for the rest of the sessions. Thank you.
Thank you, Dr. Pranjali, and thank you to all our panelists. We now move to a talk on trastuzumab deruxtecan for the treatment of HR-positive, HER2-low metastatic breast cancer and HR-positive, HER2 ultra-low metastatic breast cancer. I invite Dr. Tushar Patil, medical oncologist, Pune, to present the talk. This session is sponsored by AstraZeneca.
Good afternoon, everybody. Sunday afternoon, few more talks left. I think we'll probably be late by 15 minutes. We'll try to make it up for the time loss. Patient management considerations in HR positive, HER2 negative early breast cancer. Excuse me. I think the Kashish, if you can change the presentation. It's the AstraZeneca session. N-HER2 for the management of HER2 low or HR positive, HER2 ultra low metastatic breast cancer. The slide presentation will go through all these topics: introduction, then unmet need, the mechanism of action, then the trial design of Destiny Breast 06, of course AE management guidelines, and summary and guideline recommendation. We know that this is an unmet need. Majority of the hormone receptor positive HER2 negative MBC would express clinically meaningful levels of HER2. As we can see, HR2 positive, HER2 positive account for 15 to 20%, and real triple negatives are 15%, and HR positive, HER2 negative, close to 65% of them express some or the other way the HER2. And this is how it is. IHC2 plus with H negative, IHC1 plus, but incomplete membrane staining in more than 10%, and even faint incomplete membrane staining less than 10% is the HER2 ultra low, which accounts for almost 20 to 25% of this patient subset. Absent staining would be seen in the rest of the population. So close to 85% of the HR positive, HER2 negative MBC fall into this some expression of HER2, and that is the unmet need in this patient population. If we go on to the standard treatment, first line endocrine therapy with CDK4/6 inhibitors who have not received any prior CDK4/6 inhibitors, survival of 24 to 28 months. People who are receiving endocrine and targeted therapies and then exposed to other drugs, the survival is just around 5.5 months. With endocrine monotherapy in the second line and prior CDK4/6 exposure, it stands around 2 to 2.6 months only. In the third line setting, the survivals are very poor. If the patient has taken single agent chemo, and now mostly chemo is to be received 6 to 7 months. With this population, if we add the drug deruxtecan, the survival improves to 10 months. Very important also to note that many of these patients discontinue treatment. In the second line, almost 18% of the patients would not start the treatment. The number falls further to 17% again in the third line and 18% in the fourth line. So there is a need for more efficacious targeted therapies up in the line of treatment, earlier in the treatment pathway, for better responses and survivals. How does this drug act? Trastuzumab deruxtecan, it acts by bystander anti-tumor effect, and there is a rationale for targeting HER2 low MBC. There is a highly potent topoisomerase inhibitor payload. Internalization of this drug leads to release of the DXd payload and subsequent cell death in the target tumor and neighboring tumor cells through the bystander anti-tumor effect. There is also a high 8:1 drug to antibody ratio, and there is a cleavable linker. The drug binds to the HER2, gets internalized, then there is a linker is cleaved and releasing the topoisomerase inhibitor, causing the cell death by entering the nucleus. Also, there is a membrane permeability of this payload resulting in the bystander anti-tumor effect. The trial which took this particular subset of HER2 ultra low MBC patients, this was the study design. HR positive MBCs, HER2 low, standard guidelines. They were chemotherapy naive in the MBC setting. Prior therapy or 2 or more lines of endocrine plus targeted therapies which were allowed. 1 line for MBC and progression less than 6 months on starting the first line endocrine plus CDK4/6 or recurrence within 2 years of starting the adjuvant treatment. So poor subset of patients. Stratification by previous CDK4/6 use, HER2 expression and prior taxane in the non-metastatic setting. Standard dosing of trastuzumab deruxtecan 5.4 mg per kg every 3 weeks, 436 patients, and compared to the treatment of physician choice, in which almost 60% received capecitabine or 25% received nab-paclitaxel and 15% received paclitaxel. The primary endpoint being PFS and the secondary endpoints being PFS OS in this HER2 low population and the entire intent to treat population. There were other secondary endpoints too. The demographics was pretty matched in both the arms. There were close to 32% patients which were from the Asian world taken, and yes, good performance status almost 90% of the patients. There was almost everybody was into the good performance status patients. 0 to 1 was the performance status of these patients. And as we can see, IHC presentation, IHC 1 plus in 66% almost, and IHC 2 plus with FISH negative in 32 to 33% patients. Visceral metastases were present in almost 85 to 86% patients, and liver mets accounted for almost 2/3, that is 67% of the patients. There were also 9% patients who had brain or CNS metastasis. And the number of sites, usually the median range was 3. Prior lines of endocrine therapy, people who had received more than 3 lines were close to 17 and 13%, and almost 2/3 of these patients, 67, had received at least 2 lines of these patients. There were a combination of various therapies, endocrine monotherapy, fulvestrant or ET with CDK4/6 inhibitors and other targeted therapies. Coming to the efficacy data of this trial and health related QOL, as we can see, the median PFS comparable 13.2 months versus 8.1 months for the treatment of physician choice, the delta being 5.1 months. So there is a statistically significant and improved, meaningful improvement in the PFS compared to the standard of care chemotherapy in this patient population. Hazard ratio being 0.62 and p-value being statistically significant. Similar in intent to treat population, again 13.2 versus 8.1 in the standard. If you look at OS in this HER2 low and intent to treat population, which were the secondary endpoints, again TDX fared better as compared to the treatment of physician choice, 87.6% versus 81.6%. There is almost a 6% improvement in the delta which is there, and the hazard ratio being 0.81 and 0.83. 20% of the patients in the treatment physician choice received TDXD post-treatment discontinuation, and 17.9% of the patients in the treatment physician choice received TDXD post-treatment discontinuation in the entire intent to treat population. Across all subgroups, this drug did well as compared to the treatment of physician choice, whether it was presence of liver metastasis or not, number of sites of metastasis, what drugs were used in that previously, chemotherapy as well as the hormone therapy partner. If you look at the PFS and OS in the HER2 ultra low population, which was a pre-specified analysis, the PFS here stood at 13.2 as compared to 8.3 months, delta of 4.9 months, and the OS was 84% as compared to 78.7% at 12 months. Hazard ratio of 0.75. So PFS and OS both were improved in the HER2 ultra low and were consistent with results in the HER2 low population also. There were deeper responses, as we can see, complete responses in 2.5% patients, partial and stable disease in close to 80% patients. So clinical benefit rate accounted for 76%, and the median duration of response stood at 14.1 months. If you look at the PFS by time to progression on first line endocrine therapy and resistance, as we can see, patients who lasted, endocrine therapy lasted less than 6 months, that is resistant population. Again here TDX stood tall with TDX comparison to treatment of physician choice, 14 versus 6.5 months. If the endocrine therapy duration in the first line was more 6 to 12 months, the improvement rate was 13.2 versus 6.9, and if it was more than 12 months, then the TDX did 12.9 months of PFS as compared to 8.2 months of TPC. So it improved PFS in as compared to treatment of physician choice, regardless of the time to progression on the first line endocrine therapy, or regardless of the type of endocrine resistance. In the overall intent to treat population also, time to treatment progression was far better, delta of 5.6 months, and delay in the PFS2 was clinically meaningful in favor of the drug in the intent to treat population and other subgroups. The hazard ratio here stood at 0.62, statistically significant p-value. If you look at the disease burden, that is the number of metastatic sites, less than 3 metastatic sites at baseline, the TDX 15.3 versus treatment of physician choice, which is 6.9 months. And if you look at more number of sites, and more than 3 local or metastatic sites, again 11.4 as compared to 7.2 months. So the PFS benefit with this drug was observed regardless of the disease burden, with notable efficacy in patients with lower disease burden. Safety analysis, I think the most common AEs that were associated with discontinuation were pneumonitis, which were found in TDF 5.3%, and in peripheral sensory neuropathy in treatment of physician choice, which was seen in 1.4%, and associated with dose reduction in TDX arm was 4.4%, and nausea was the predominant one. So I think, yeah, these are the commonest AEs that were seen: nausea, fatigue, alopecia, neutropenia, and transaminitis, vomiting, diarrhea, decreased appetite, leukopenia. The grade 3 AEs were fortunately, apart from neutropenia, which stood at 20%, the grade 3 AEs were quite less. And the dreaded AE, that is pneumonitis, that we are worried about, we'll come to it a little later. Yes. Median time to onset of this ILD pneumonitis was 141 days in TDX arm. Of the 49 patients with any grade ILD pneumonitis, 20 were reported as having recovered, 2 as recovered with sequelae, and 3 were reported as recovering at the analysis. Quality of life, I think ULs were all maintained throughout the treatment duration. To conclude, this trial demonstrated a statistically significant and clinically meaningful PFS benefit versus treatment of physician choice in HR positive HER2 low MBC in the early line of treatment than Destiny Breast 04. Results of HER2 ultra low are also consistent with the HER2 low population. Confirmed objective response rates of 57.3% as compared to only 31% in the intent to treat population for the treatment of physician choice. There were no new safety signals which were identified. ILD remains an important risk factor and needs to be analyzed. This trial establishes TDXD as the effective new treatment option for patients with HR positive, HER2 low and HER2 ultra low MBC following at least one endocrine therapy. As we can see, PFS in HER2 low 13.2 versus 8.1 months, and in ultra low also 13.2 versus 8.1 months. Regarding just the AE management guidelines, I think it is highly emetogenic, and we've, with the continued and more use of this drug, we've learned that it requires at least a 3-drug antiemetic regimen to be more effective in preventing nausea and vomiting than the 2-drug regimen, and that's the norm that we are using today. The other dreaded AE which we are worried about is ILD pneumonitis, and yes, any new onset cough, dyspnea, fever, worsening respiratory symptoms, consultation with the chest physician regularly, doing HRCTs at regular intervals would promptly identify and initiate the earliest treatment for ILD if it's the happening with these patients. And there are pneumonia and what we say as dosing modification and guidelines which are mentioned as per the standard criteria once we identify how is pneumonia interstitial disease happens. If the AE of ILD does not improve or recover within 28 days, probably there is a case for permanent discontinuation for these patients, and some of these may require hospitalization, early start of steroids, including high dose methylprednisolone for patients who are really sick because of this. Monitoring for resolution or worsening of ILD via regular examination, respiratory screening, O2 saturation monitoring, and higher resolution CT is mandated and required. It involves a multidisciplinary team including the chest physician, the oncologist, and patient also need to be educated in detail about this side effect so that they can come up at the earliest to report if these there. There could be patient alert cards which have been mentioned. So Enhertu outperformed chemotherapy when used post second line of endocrine and demonstrated a favorable benefit risk profile in patients with HR positive, HER2 low and HER2 ultra low MBC. Primary endpoints of PFS 13.2 versus 8.1 months, and secondary endpoints of objective response rates 56.5 versus 32.2. Efficacy in the exploratory HER2 low cohort was also consistent with the HER2 low MBC. So it also demonstrated a favorable benefit risk profile. Most common AEs were nausea, fatigue, alopecia, neutropenia. There were 5, or that is 1.2% patients with AEs leading to death, 2 attributed to ILD and 1 reached to sepsis, neutropenic sepsis and health deterioration. ILD pneumonitis occurred in 11.3% of the patients receiving Enhertu. Grade 3 or higher ILDs occurred in only 1.4% of the patients receiving Enhertu. Discontinuation rate was 14.3 with Enhertu versus 9.4% with chemotherapy. Identify eligible patients of this population, HER2 low and HER2 ultra low MBC, to provide them with the treatment opportunity with the Enhertu. And these are the ESMO guidelines which clear-cut mention that I think 1 line of endocrine therapy followed by, if there is a HER2 low or ultra low population, the drug of choice remains trastuzumab deruxtecan in the second line. Thank you for the patient listening. This was all about trastuzumab deruxtecan and its data in the HER2 low and HER2 low ultra low MBC setting. Thank you.
Thank you, Dr. Tushar. We come to a focus area that demands not just science but compassion, pediatric oncology. I invite our session director, Dr. Vibha Bhavna, pediatric hemato-oncologist, Pune, and session coordinator, Dr. Lisa Bulsara, with the chairpersons, Dr. Mukul Gharote, consultant medical oncologist, Shirdi, and Dr. Rakesh Agarwal, senior consultant radiation oncology, Sonipat. We have a panel discussion on evolving approaches and treatment for pediatric acute lymphoblastic leukemia. I invite our moderator, Dr. Shailesh Kanvinde, consultant pediatric hematologist and oncologist, Pune. With our panelists, Dr. Swati Krishna, consultant pediatric hematologist and oncologist, Pune. Dr. Deepa Trivedi, pediatric hematologist, oncologist and BMT physician, Ahmedabad. Dr. Aditi Dastane, consultant molecular pathologist, Pune. Dr. Taher, consultant histopathologist, Pune, to please join us.
Vibha, you can join up, please. So, good afternoon, everybody. I'd like to thank MOC and Dr. Tushar Patil for having us for this panel discussion on childhood ALL. I welcome all the panelists. I would encourage a free discussion, so please feel free to put in your comments as and when required. Most of you may be aware of this slide, which often gets presented during ALL talks, and this shows the great success which pediatric oncology has achieved, especially in ALL. A stepwise improvement in survival from less than 10% in the 1960s to currently in the West, at least more than 90% of these children do survive. And this has not obviously come overnight. It has not come because of any new agents, but most of the agents that have been used have been in used for last almost many decades. And overall, if you see even from the other centers in the West, the 5-year survival generally is more than 90%. When we're talking of childhood ALL or childhood cancer, we're really not just worried about the event-free survival. We're also looking at the late effects of childhood treatment and cancer treatment, and cardiotoxicity, neuropsychological effects, metabolic syndrome, osteonecrosis, some of the worrisome long-term effects that we would be facing in these children. So after having achieved a significant success in getting a good survival, we also would like these children to grow up as normal adults. And so this is one area of focus that we would be looking at for future development in childhood cancer treatment, is how do we improve survival, but at the same time reduce the late effects of treatment. We don't have too much Indian data, but we know that, okay, we are lagging behind a bit. This is a study from the ICICL group, which published in Lancet Regional Health in 2025 May, which shows that the survival ranges between 60 to 76%. And we do have a problem not just with relapse, but with treatment-related deaths. And there is considerable variation across various centers. So the 6 centers participating in this study, you can see that in the TRM as well as the cumulative incidence of relapse, there is significant variation. So this may be because of the patient population which they are treating, the logistic challenges because of overcrowding and so on. But various other factors which don't get considered in adult trials or in Western trials is malnutrition, financial insufficiency and so on. So we do have our own challenges and we need to work on them. So we have now realized that increasing our chemo intensity is not really going to help us achieve better survival. We need other things, and through this panel discussion we will be looking at some of these things, like what can we do for the diagnosis, do we have any targeted therapy, any newer agents, and so on. So just let's begin with the case. So 4-year-old, case of precursor B ALL, a baseline count was to 90,000. Cytogenetics showed a normal karyotype. FISH for BCR, ABL, MLL, ETV6, RUNX1 and 119 were negative. Her day 8 prednisolone response was good, and based on this she was stratified as intermediate risk, and we plan to assess her post-induction bone marrow MRD. So I can start off with Dr. Deepa. We've done karyotype, we've done a FISH for these 4 common mutation abnormalities, fusions. So would you think this is sufficient in our present management? Or would you like to do anything more?
Of course, if the patient can afford, we would consider NGS for looking for other rare mutations. But if this is the best, see, we must understand that we'll find more mutations, but are they targetable? Like finding a mutation and telling the family you have a mutation, but we don't have medicine for it, is also a challenge sometimes.
So yeah, that was what we really do is the other next, like we do look for pH positive ALLs, because we know there's a proven therapy which we can add and improve the outcome. Do we have enough? I think we'll come to pH like ALL a little later. And as you said, DNA and RNA sequencing is what we do in selected patients, not as a routine. But as we were discussing with Viva also, it adds to a lot of confusion rather than helping us decide what to do in those patients. So coming to Dr. Dastane, so what are the different techniques, like if you want to do NGS or if you want to look at PCR, FISH and NGS, how do you rate each of them in terms of identifying actionable alterations?
So in the beginning I would like to say that the new classification WHO has come up with, ALL NFC, that is not further classified. We should differentiate it from NOS or not otherwise specified. When we have ruled out the other abnormalities, then only we can put a label of NOS. Otherwise we have to say it's not further classified. And for that we need to rule out the basic 4 translocations by FISH which we said, but we can have an extended FISH panel to look at the translocations, the new entities like PH like LL. It has come up with ETV6 RUNX1 like ALL, and furthermore FISH can give you a quicker answer in diagnostic setting. But NGS, the problem with is it will pick up all the other mutations, the rare ones. It takes a lot of time and it is costly. But DNA, it can sequence you, depends on how many genes we have added in the panel, 40 genes. RNA, it can give you only the known transcripts, the abnormal transcript. It can't give you abnormal or a new novel transcript if it is not known yet in the literature. So RQ-PCR is reserved generally for MRD settings, but we need to know the baseline which transcript abnormal, like if it's a BCR-able one. So is it a P210 or P190? Depending on that, we need a basic baseline workup for the abnormality if we need to pick it up on MRD further.
So if you're going to do a sequencing, do we still need to do the karyotype and FISH and the sequencing, or you just can do the sequencing alone, and that can take care of the whole?
So the karyotype is now just very limited to hyperploidy actually and hypodiploidy or a near triploidy if we want to pick it up, or large deletion duplications which an NGS will miss, or a balanced translocation NGS will miss. So we need to know, FISH will pick up balanced translocation, NGS won't. So there are limitations of each technology. But karyotype, if it is not possible for some reason, we have not preserved the sample or it doesn't grow in culture, we can go in for a chromosomal microarray in that case. But as it is, FISH can give you an answer about hyperdiploidy, hypodiploidy, triploidy status. So we can avoid karyotype to a certain extent. Yes.
And what about MLPA? Please use the mic, Vibha. Can you just use the mic?
Will hypodiploidy also be picked up by FISH?
No, so it won't be picked up, but we'll just have a fair idea about the number of chromosomes because we'll see less in, if we have done an extended FISH panel and we see low copy numbers in each of the loci, like 4, 10, 7, everything is low. So we'll just have a fair idea. Yeah. MLPA is an in-between technology, in between an NGS and a microarray. So it picks up small deletion duplication, like a single exon deletion or a single exon duplication will be picked up by MLPA, which will be missed by both NGS as well as microarray. So for some cases, there is a gray area in between for which MLPA is required, very few areas.
So we should be doing the DNA sequencing, RNA sequencing and MLPA together?
Together ideally before calling every gene as a 100% normal or a wild type gene, but that is not possible in a practical setting. So if we are still suspecting something even after NGS is negative, because that's the commonest, we can follow it up by a MLPA later on the same sample.
Okay. And very often we get a lot of variants on the NGS with very low level WAF. So how do we interpret that? I mean, sometimes 2%, 6%, 10%. I mean, are we going to consider them as significant and then make our treatment modifications? Or is there a cutoff that we should be using to say that?
That's a challenge we are facing today with the standardization of all the NGS available in the market. And what panel have we chosen? How comprehensive that testing is, the coverage of each gene, and what is the depth of sequencing which each gene has undergone through. It depends from panel to panel. So ideally, the more the depth in cancer, it depends on a diagnostic setting. I think 500x is a minimum which is required to cut corners. 100x is only for germline, it is okay. So while looking at an NGS report, we need to look at if it is not enough depth of coverage, probably we need to go in for a further depth of coverage panel, so that we can pick up these low mutations. But when a mutation is reported, it is because of the depth of coverage, like even if it is 2% WAF, it is significant because it has undergone so many QC, and after the passing of those QC metrics, it has come up in the report. So
I just want to ask Aditi, what about the MLPA? I mean, MLPAs are standard panels, no? So are there very standard MLPAs available for ALL?
Yes, so standard MLPA panels are available, and we have been using that. It is for JAK2, PDGFR alpha, beta, and yeah, it's like it's mostly.
So, Dr. Swati, so in our present scenario, in the kind of patients that we get, what should be the standard of care regarding molecular profiling? How much should we really investigate? What is the minimum that we would need to do, and which will have therapeutic implications? We are not talking of a research setting, we are talking of a practical day-to-day working for a patient who walks into our clinic for a treatment.
Sir, I think the bare minimum should be karyotyping with the FISH for conventional cytogenetics, which will be MLL, BCR-ABL, ETV6 RUNX1 and TCF3 HLF, because that, I think that comes around 5,000, 6,000, like MR cost wise. So that should be the bare minimum that we offer. But if the patient is affording, like ma'am said, NGS should be the standard of care. Yes. Yeah.
Because ultimately, like when patients are there in the ward, they talk about, what was done for you, and advising a test from one ALL and not for another can sometimes land up with a little problem. So, should we really be doing NGS for all our patients if it's
maybe
feasible?
If they are high risk, like older patients coming with a high white count, prednisone poor responders, like you have stored the DNA, you can go back and look at it. So definitely yes, maybe there'll be a small subset of patients whom we think we can find a mutation and do something.
Yeah, that's a question actually I would like to ask Aditi, is we don't do anything at the diagnosis, we just do a FISH panel at the baseline. And at the end of induction, we find that MRD is positive and we want to look at NGS a little better. So is it feasible on the stored sample or?
Actually, the new NCCN guidelines, they have mandated doing an NGS for all the cases. The basic workup for molecular characterization, if we want to characterize it to the T, we have to do an NGS. But if not done for whatever reasons, we can do it at follow-up. That also NCCN guideline says, and we can do it on the preserved sample. That is possible.
But RNA isolation would be a little difficult at that sample.
It would be challenging for RNA, but DNA could be picked
DNA
up.
could be
Yes. We can for fish, the harvested cells, which generally we keep for 5 years as a rule in NABL setting. So we don't discard it. Culture won't be possible. But MLPA, anything from which DNA is extracted, MLPA, chromosomal microarrays and NGS, everything will be possible.
We have done it in those settings. I mean, the MRD has come significantly positive. We have asked for a MLPA for pH, so that is something we have found.
After chemotherapy, the patient has received induction chemotherapy. Then on the MRD sample when we do, the clones are changed, they're different.
Yes, so this is going back to the previous sample for the baseline workup. If we find something, we can check only that one in the MRD sample.
Okay.
As a follow-up.
Yes, but on that sample, the MRD sample will not be the sample for.
The mic please.
In case an extra sample was not collected, it was missed, or like in cases when we get a dry tap, initially sometimes it becomes challenging. A patient with a 95% blast, the tap itself becomes difficult.
Actually, in this case, we have used the bone marrow biopsy, also scraping and extracted DNA from the FFP tissue. So we try to, however possible, get DNA from the previous diagnostic sample, but if not.
If the MRD is positive, can we, that point of time, use the MRD and do further tests?
Yes, we can, of course, yes. So it can even be done on a ctDNA if possible, on peripheral blood. So yeah, even that is coming up, like a liquid biopsy.
We'll just take this discussion a little forward. So this has been the report. We've done the NGS for this child, and what we get here is an IKZF1 gene deletion, copy number loss with additional copy number loss for these parameters, and so we are stuck. So originally, if we hadn't done this, this would have been an intermediate risk. Good prednisone response, post-induction MRD was negative, and we would have treated this as a high risk, as an intermediate risk. Now, the child has an IKZF plus phenotype. Do we need to change? Anybody? Yeah. So it's the IKZF plus phenotype. It's not just IKZF, it is IKZF with other JAK2, CDK, and 2A mutation, copy number loss, and so on. So this has been identified as a poor prognostic category, but the poor prognosis is limited in those who have a negative MRD. So combining baseline data with MRD does make sense. So this is, but what is unclear is what should be the treatment intensity which these patients should receive post-induction. So should they continue on intermediate risk because they're MRD negative, or should they be treated as high risk? So these are some of the issues that we are going to face now a lot with newer techniques available.
See, I would say that since it is a post-induction MRD negative, I would continue with the intermediate risk. I would get a time point 2 MRD again, just to be sure. And if and when the patient relapses, we'll treat him. Because HR blocks are also not easy to give.
Okay, so this is just a summary. Now we know that with molecular testing, there are about 20 different subgroups of B precursor ALL with prognostic and therapeutic implications. And by doing NGS, we are going to get many of these. We know some of them are low risk, intermediate risk and high risk, but it's sometimes difficult to identify exactly what is to be done. So as over a period of time, I think we will have data on this. So this is where we are moving forward, but as of now, this will have a little limited application. So now coming to Dr. Tahir, we've talked about response to therapy and minimal residual disease assessment, which is now really a cornerstone of our management and risk stratification. So could you just highlight some of the current recommendations for the techniques for MRD assessment by flow cytometry, and what would be the minimum recommendations in the reporting?
So initially it was just a morphological assessment was there, whether it is a bone marrow is morphological remission or not. But now the flow cytometry is a cornerstone of the MRD. Along with if the recurrent translocations are then the RT-PCR and NGS is coming up very rapidly in the cases of the MRD. So each has its advantages and disadvantages. The most common is a multi-parameter flow cytometry. So the minimal requirement for the, it should be at least 8 to 10 color flow. It should be not diluted sample, and the event count should be at least 0.5 to 1 million count should be there. And for the RT-PCR, it should be initially it should be present as a recurrent translocation like BCR, ABL or other. And for the NGS, we don't require any, if we don't have a previous data, then again we can do NGS and find out the clonal parameters to identify whether clones are present there. Second thing is the sensitivity is different for each test. The MRD by the flow cytometry is a 10 raised to minus 4. For the RT-PCR, it is more sensitive, it is 10 raised to minus 5. And NGS can go up to the 10 raised to minus 6 to the minus 8. The NGS, the one platform is approved by the FDA, which is coming very rapidly in the practice.
So Aditi, about NGS related MRD, how feasible is it? What would be the time frame to obtain the report?
So first of all, I would like to say this NGS is different from the NGS which is done at the baseline. Here we look at the clonal IGH gene rearrangement, the heavy chain, and so we look at the VDG rearrangement. So if there are no baseline parameters or molecular markers to study, this is for generalized all patients. We can just look at the clonality and pick up 1 in a million cells. So only one FDA NGS has been approved till date, clona-seq by bioanalytics, and it has not yet come in very expensive in India, so it's not really being used. The statistical, the problems are with the standardization at the statistics level. So even though we have the library preparation and we'll have to do it at a very high depth of coverage, which will increase the cost, but it will lead to the QC parameters at the statistics, biostatistics level that needs to be standardized. That is still a challenge which we are facing.
So as I understand it, we need, for NGS, we always need the baseline sample to test, or no?
No. So in this case, no, because we will be just looking at, if we don't have any baseline also, we will, and the sample is totally normal, we'll look at any clonal IGH heavy chain or light chain gene rearrangement by looking at the VDJ gene recombination rearrangements.
And what would be the turnaround time for the test?
So NGS typically has a batch which we need to do for cost cutting, and the more the batch size, the lower the cost. So I don't know clinically how can we even wait till 1 month, because that's the average turnaround time for an NGS.
Okay. So this is just a recent development from more than 2 million events in more than 95% of the cases. And MRD detection has been up to 0.0, and results are obtained in a day or so, so significantly shorter turnaround time. And so this can help us assess MRD better. So quickly, how do you, so now having MRD, would you change the definition of remission in ALL?
Sorry, sir, I didn't.
Would you change the definition of remission? How do you assess remission in?
Yes, sir. So now, post-induction MRD assessment has been a standard of care now. So that should be like the bare minimum that we do, day 29 after induction. So our by flow cytometry, because most of the labs are standardized for MRD by flow cytometry or PCR. We don't have as such MRD by NGS. Our target would be below 0.01 at a sensitivity of 10 to the power of -4. So ideally the best would be an absent MRD. So that has the best prognostic factor, but a bare minimum, like the best otherwise would be below 0.01. So that should be the ideal cutoff for calling as remission in MRD era.
There is a,
Dr. Tahir, how important is the...
the mic, please, mic.
How important is the events that you get? Because like 2 million, 4 million...
So for the minimum event count should be at least 0.5 million, 0.5 minimum count. And the the ideally is a bone marrow. So initial bone marrow, we do a bone marrow aspiration. Initial 1 ml, 2 ml is the best thing that we can do a MRD. Yeah.
So so this was just a consensus from the Ponte di Legno Consortium regarding, and you can see that the remission definitions across various clinical groups really varies. So it's difficult to compare the various studies. And what they defined for CR should be bone marrow MRD less than 1% and or M1 cytomorphology, and the rest of the sites should be normal. So and treatment failure was defined as an event which failure to achieve CR at the end of consolidation. So this is just a recommendation or a consensus recommendation for trials to report it in a uniform way. So in this case, the MRD at the post-induction is 0.028. So how would we interpret this? Do we consider this detectable and positive, or do we say that it is less than 0.01? So we will treat this as negative.
So personally, I'd be happy because getting an absent MRD is not easy. So 0.01, I'll tell the parents that this is a good MRD. But deep in my mind, I know that absent is always better. So the patient is at a risk of relapse, but this is still good enough because otherwise I think if it is the same patient, the standard IKZ of 1.
Yes.
So I am happy with this MRD.
So this as of now, we are considering this as a negative MRD. We know that if it was 0, these were the patients where we would probably consider de-escalation of therapy rather than thinking about escalating it if it's positive at a low level. So the next part is coming to newer agents. We just discussed the diagnostic parts, coming to newer agents, and we have some new chemotherapeutic agents coming up in the last decade or so. Immunotherapy has picked up significantly, and there are a lot of targets which we have identified, and there are targeted agents developed. The most unfortunate part about all this is that most of them are either not available in India or they're very expensive. But we hope that in the next couple of years, many of them would be available at a lower cost. So let's begin with pH positive ALL. We know that this is one of the last maybe 2-3 decades now that we have been using this. So Dr. Swati, for a pH positive ALL, your choice of TKI, imatinib, dasatinib, or ponad?
Dasatinib is always better for ALL over imatinib. So I would start at 80 mg per meter square. And ideally, the best time to start is as soon as we know that this patient is pH positive. But if the patient has multiple episodes of infection or he is already going through a very tough induction, there have been studies where we do it after induction also. But it is always best if we start early. So induction till maintenance, so till the completion of therapy, we'll be continuing.
And what about the chemotherapy backbone? Would you like to de-escalate the chemo and just give the standard risk kind of chemo and along with the TKI, or would you like to intensify therapy also?
Yes, sir, I would intensify. either I would give a augmented consolidation, and definitely if I'm not giving high risk blocks, I'll give at least methotrexate at 5 gram per meter square, even if the MRD is negative.
Any role for immunotherapy? Deepa or Vibha can answer. Would you consider using Blina upfront? Because the adult data is pretty
yes, I know adult
great,
data is pretty, but
so
yeah, if second month is
and role of transplant, would you consider these patients for upfront transplant? Anybody? So
if
what
there's
would
a
it?
relapse or not.
So yeah, end of time consolidation positive MRD, those patients would be considered for transplant. And this is just the result of a ALL 0031 COG study, which showed that the outcomes between transplanted and non-transplanted children is almost the same. So definitely we can use a chemo plus TKI regimen only for most of our patients with Ph positive ALL.
Use the routine MRD or will you use the pH?
Okay, so
anything overrides one another?
No, the looking at, I mean, since I have a short of time, I'll just answer that query. The recommendation is to use the flow MRD, yeah, and not the recurrent translocation, because that can give a little confusion. So looking at pH like ALL, we know that this is a high risk subgroup. There are targets available. So should we, the same questions that we had for pH, what would you like to start? Would you like to test and would you like to start?
Yeah, I think if it's positive TKI, we would start early at the during induction. For the JAK, it is still doubtful. If you are MRD positive at the end of induction, you would try to add a JAK inhibitor. Yeah, that is the one which was published
so
recently.
The St. Jude's policy of using dasatinib on day 15 and only JAK-STAT alterations with only positive MRD, then they receive. But we still don't know the data for that, and we don't know whether it will be more toxic, it will be, so I think this is something which we'll to look at. So currently, so this does mean that we would need to do the testing to know these things. Okay, so we'll move to the next case. We are a little short of time. So this is a 6-year-old male, precursor B ALL intermediate risk, was 1221 positive, treated on the BFM backbone. And he had a late systemic relapse with a CR1 duration of 48 months. So he was offered salvage chemo, the BFM res backbone, was not offered a BMT because he had a good MRD response, and as well as it was a late relapse. And now 6 months post completion of the salvage chemotherapy, he has a second relapse and he doesn't have a matched sibling donor. So what would be your salvage strategy B?
So basically, I think we still have to do a 4-drug induction or a 3-drug induction.
So let me ask you, chemotherapy,
then
immunotherapy,
yes.
or both?
Usually we'll start with chemo, then plan for INO or BLINA depending on long term what the patient wants. How early, do we have a CAR-T trial available or not? So we start with chemo and then we do the next A, B or C as BLINA versus INO versus CAR, and then transplant of course is the gold standard.
So between the two agents, what would you prefer, BLINA or INO?
So it will depend mainly on the blast percentage. So usually if the blast is more than 25%, we start with inotuzumab, bring the blast count down, and then BLINA followed by transplant or CAR-T. So, and we also have to be cautious here. I think CNS disease is negative here.
Yes, CNS is negative.
Yeah, so BLINA is going to work well here. And if we are going to transplant the patient, we should also be cautious about sign-occlusive disease that inotuzumab can cause.
So this child was actually treated with initial 6 days of prednisolone and then was given a single agent inotuzumab, and with which 3 doses of that he achieved a MRD remission, and then with a little bridging therapy with vincristine and pegaspaginase to give the gap between the transplant and we plan to take him up for transplant. Before that, can we just Dr. Swati, role of immunotherapy in upfront, because we know most of the drugs come in the relapse setting and then slowly move upfront. So currently, do we have any data to suggest that we should be using these drugs upfront?
So in refractory ALLs we have, Blina has become the standard of care now. But in our setting, we are still, because of cost issues,
Cost constraints, definitely it's a problem.
I think another will be infant ALL.
Yeah.
Infant,
So,
they do
yeah.
well, I think, with
So 2 studies have shown a
Altogether
good
protocol, I think they are using. In one of the risk stratification, they are using Blina upfront.
So 2 studies have shown the
2017, they are using Blina to Blina.
yeah,
So
right.
upfront.
The 1731. They've shown in standard risk ALL the 3-year EFS is significantly better, but there was a caveat that the rate of grade 3 sepsis was much higher in the Blina treated arm than the others, probably because of the B cell aplasia which it produced and the immunoglobulin levels which went down. And as Deepa pointed out, infant ALL has shown quite significant results. So definitely that is one area where we need to consider Blina. Okay, discussion cannot be complete without CAR-T. So
yeah, I think it's a great time in our country. We have the multiple CAR-T trials also coming, where and commercial CAR-T is also quite affordable in the sense that compared to what it would have cost if the patient has to travel to the US. So there are a lot of trials.
So where would you position CAR-T today in the present treatment algorithm?
I think
Which patients would you pick up?
I think those early relapses, which are kind of chemo insensitive, where they won't tolerate the chemo, I think maybe CAR would be one place where you can give them CAR-T and then keep them a little better and then kind of consider transplant. So definitely those who don't tolerate much of chemo.
This child received inotuzumab, achieved MRD negative, and was planned for a transplant. But parents also said, okay, that CAR-T is also available. This child was by this time more than 15 years, so was available for regular CAR by purchasing it. So what would you recommend? He doesn't have a matched sibling. He has to go for a haploidentical transplant. So between CAR-T, which Immunact was ready to provide, versus transplant, how do we choose?
I think this is second relapse.
Yes.
Already pre-treated. Still, transplant would give him a better option than a CAR-T. I would consider.
Yes, so that's actually what we did. The only thing was that the risk of mortality and the duration of treatment was significantly lower for a CAR-T, and almost 50% of the patients would have not required a subsequent transplant. So that was one option that we had considered. But as you said, right, yeah, we decided to go for a transplant in this case. And so
So it's, currently we use, I think, the second generation CAR-Ts, which is available
yes,
in India.
uh-huh.
So usually the CARs, they get exhausted after like 6 months. So at that time, they're again at a risk of relapse. So like, isn't the standard, even if you do CAR-T, shouldn't you still transplant the...
No, that depends on the type of co-stimulatory molecule. If it is a 41BB, they tend to persist. Whereas if it's a CD28 based, then you might need to automatically consider transplant. And what they monitor is the MRD and the B cell aplasia. So early loss of B cell aplasia means this patient is likely, the CAR-T is, the constructs are going down, and those are the patients which should be transplanted. But if the B cell aplasia persists, like we have Emily Whithead, she's almost 10 years after therapy and she's not undergone a transplant and she still has B cell aplasia. So there will be, even in the Immunact study, there are about 40-50% of the patients who have
Exactly. So that was a point, that in case this child may not require a transplant, and especially that he is being heavily treated with 2 types of salvage chemotherapy, wouldn't CAR-T be a little bit on the upper than a transplant, haplotransplant?
It was considered. It was, I agree, except that the decision to go for a transplant was that, okay, CAR-T is relatively new. We don't know the long-term consequences of the particular product, and if a transplant option is already available, might as well go for a stand, because we can still use a CAR-T after transplant. That will be possible. Either way. So considering standard of care, probably still would towards a transplant rather than CAR-T, but it's open to discussion. I mean, it's on a case-to-case basis. So quickly, TALL, a little more disappointing disease to treat than precursor B, lesser survival, salvages are very rare for relapsed patients. So where do we incorporate the newer agent and just specifically focus on nelarabine, which is now available? So do you use it upfront or do you use it for salvage?
For now, salvage. We have not started using it for upfront, but I think there is a previous protocol which used bortezomib, which is not that expensive and has less adverse events in nelarabine, and that gave pretty decent results too. So I have used the bortezomib protocol for some TLs and they have done well.
For upfront setting?
Upfront, yeah.
And bortezomib in place of vincristine or along with vincristine?
Along with vincristine. There's this nelarabine protocol, uske pehle wala.
Coming to a point.
COG is giving nelarabine upfront in, yes ma'am, yeah. Correct.
So what is your practice? I mean, are you recommending nelarabine in TALs upfront for any group of patients, the high risk ones?
Not yet.
Not yet. Okay. Radiation therapy has been a pretty important component of ALL therapy over the last few decades, but most centers, most protocols are now taking it off because of its long-term effects. So in current practice, is there a role for radiation in any subgroup of patients?
So prophylactic cranial RT is coming out, but for therapeutic, definitely for CNS3 we are going to give for every patient, and TALL with a high WBC count more than 1 lakh. But in the recent BFM trials 2017, for age below 4 years they are not giving even therapeutic cranial RT. They are just going to increase the number of intrathecal methotrexate. So considering that, I think prophylactic CRT is now out of, like more and more it's getting.
So I just showed you the Indian survival curves, and we are still lagging significantly behind the Western data as far as the relapse risk is concerned. And we know that for ALL, post-relapse salvage is almost very, very difficult, almost nil. So in that situation, would you, for our patient population in a low socioeconomic strata, would you still like to give radiation? I mean, that's something, that's my thought process. I would, case by case basis, we would definitely consider it. Right.
Because we can't extrapolate everything in our setting.
I'll just skip this and move to the last question, so we should be finishing on time. So there is some interest on using flow cytometry to detect CSF, to detect the CNS disease in the blast on the CSF. So Dr. Tahir, can you just highlight how feasible is it? Are there any criteria in which patients where we can do it and we cannot do it?
The cornerstone of the CNS relapse is till now it is a morphology. We have a CSF and we identify blast by looking into the slides. But there are many false negatives are there because in cases of particularly if TLL, the blast size are small, we consider as a lymphocyte and we miss the relapse case. So when we use a flow cytometry, then the chances of getting positivity is gone almost double. The only problem with the CNS sample is the blasts are very liable and it can degenerate very rapidly. So if we are doing the flow cytometry, we should have a either process in the 1 hour or we can put into the cell preservative and we can process afterwards. The difference between the MRD and the flow cytometry in this condition is we take events, all the events into the consideration, and very few the antibodies are required and we can identify whether it is relapse or not.
So what would be the sample size and what should be the cell count for you to do it?
So see, 1 to 2 ml will suffice, and for the positive at least 10 to 20 should be the event count should be there.
So Deepa, should we be doing it? Will it make a difference? I think Vaskar's group at TMC is advocating it and I don't know whether Icicle has it on board, but
I think there was this recent publication that if you have CNS2, that is more than 5 cells on the CSF, and suspicious blast, like more than 2 blast, sometimes those cells which look like blast may be T cells, and you are falsely putting somebody in CNS2. So that flow may identify whether this is a B leukemia blast or a normal CD3 T cell. But it's still experimental, as he said, transportation, preservation, the markers, how to run it. So it will take some time to get sent. But if you have somebody who is a CNS2 and you really want to be sure, you can do it.
Okay. So if there are no comments, I think we'll just summarize. We now know that intensifying conventional chemotherapy, like we did in the past, we've reached a plateau now. It's unlikely to significantly improve outcomes and probably will increase toxicity, which for our patient population is also a major cause for worry. So we would need to use the newer targeted agents and immunotherapies to improve outcomes without increasing the toxicity. And for this, we definitely need a detailed molecular characterization and MRD. So these are the things which we will need to do as we move forward so that we achieve our goal of curing all children with ALL with minimal or no toxicity. So thank you very much. Thank you for all the panelists, and back to the organizers.
Thank you, Dr. Shailesh, and thank you to all our panelists. We now move on to our last panel discussion for our conference. I invite our moderator, Dr. Tushar Patil. He's a medical oncologist, Pune, with our panelists, Dr. Kshitij Joshi, consultant medical oncologist, Mumbai, and Dr. Ashwin Rajbhoj, medical oncologist and hemato-oncologist, Pune. This session is sponsored by Novartis. Dr. Tushar would be speaking on patient management considerations in HR positive, HER2 negative early breast cancer.
So as the metastatic breast cancer, hormone receptor positive and HER2 low, all these have gone a sea change. I think there is now a time to change for the early breast cancer, identification of the right risk factors which are there so that we can escalate or de-escalate our treatment, the hormonal treatment based on these risk factors. We have the esteemed panel of Dr. Ashwin Rajbhoj, medical oncologist, and Dr. Kshitij Joshi, medical oncologist from Mumbai. These are the disclaimers. We'll just begin with a case. Kshitij, I would like to ask you this question. 45-year-old premenopausal women who has got a stage 2B disease. There are 2 clinical node positive disease, grade 2 invasive mammary carcinoma, a 4 centimeter tumor, and a Ki-67 of 35%. The patient has undergone a oncotype DX risk scoring which is around 27. How would you interpret this report in terms of risk, and how would you go about, after she completes her systemic therapy, the planning of the adjuvant endocrine therapy?
So this is early breast cancer.
Yeah.
With nodal positivity, 2 lymph node positivity itself is a high risk factor.
Correct.
Along with there are a few other high risk factors like a recurrence scores 27. This is premenopausal.
Yes.
So these are the few other risk factors, and the size is, I think, 4 centimeters also one of the risk factor.
Yes.
So it is definitely some kind of additional treatment after conventional treatment in terms of CDK might help.
So you would consider this to be a high risk disease based on the criteria that, and you would definitely want to give her the chemotherapy advantage also, and this endocrine would come after the chemotherapy and maybe the radiation which is there.
Sure.
How do you assess the risk for such patients which is N1 or maybe just T2 or high genomic score, and what is the what we say is your criteria of making it see as a high risk in terms of size or Ki-67 or nodal status? What is there?
Okay, so the high risk feature, previously the nodal status was the main point.
Correct.
To decide whether it is a high risk or not. But as per the current evidence with the new trials, the biology is equally or even more important than the only nodal status. So sometimes even the non-nodal positivity also, if it is a high grade, size more than 5 centimeters, or even the recurrence score is high, the chances of recurrences are seen high. So we may consider even the nodal status is negative. If we have some other high risk features, then we can consider CDK4/6 inhibitor, because as we know that this kind of ERPR positivity, either there is early relapses or ekdam delayed relapses.
Correct.
And that these delayed relapses, when we see many patients were treated in the past, when they develop relapses, so we retrospectively, when we see the high risk features were present, so we could have done something different at that point of time.
Ashwin, if you could point out what was the high risk criteria for the abemaciclib or the monarch E that they had?
So for abemaciclib, the monarch trial, they included patients who had lymph node status more than 4, which were considered.
Correct.
Apart from that, if lesser amount of lymph nodes, 1 to 3 lymph nodes are there, then the other additional features like size more than 5 centimeters or grade high would be considered. So these were high risk features.
Yeah, so I think all these patients more than 5 centimeters, grade 3 tumors, more than 3 lymph nodes being positive were the only high risk features which are considered, or inadequate response to your neoadjuvant therapy, patients requiring neoadjuvant and then inadequate response which is there. But here I think with this data coming up, the other criteria have been included, as we can clearly see that even a tumor which is 2 centimeters and 5 centimeters between that criteria, but if it's a grade 3 histology, a higher Ki67, a higher genomic risk scoring would still classify as a high risk in spite of the nodes being negative. Again, if we see 1 to 2 nodes positive, yes, definitely regardless of the size of the tumor, it would fall for this high risk criteria, and 3 and more, I think it qualifies as a high risk criteria for both the drugs that can be used. So in this, probably more number of patients can be included and are included in terms of the risk scoring. And for patients which are 4 and node positive, we always know that definitely they would be high risk, and we will be able to consider them for as a high risk treatment. So as we can see, the percentage of patients that we could identify, the Nathalie eligibility represents more than 2 times the patients in this subset which are at increased risk of recurrence than the monarchy trial. These are the retrospective analysis of real world patients in this subset. Close to 7,000 patients which have been enrolled in US electronic health records. As we can see, 30% identified by the Nathalie eligible cohort, and 14.5 as by the abemaciclib monarchy eligible cohort. 2,163 out of 7,060, and here 1,023 as of out of 7,060. So more number of eligible patients, probably giving them the advantage based on the risk recurrence scoring and the risk of relapse, and possibly giving them the adjuvant escalation, right adjuvant escalation for the right time, so that the risk can be decreased. So the broader eligibility criteria of this than the monarchy encompasses 2 times more the real world patients, representing an opportunity to improve the outcomes for patients with node positive and even node negative high risk features. So if you look at the key, what we say as takeaways, if you can just elaborate, Kshitij, what was the IDFS advantage with ribociclib and in node negative and node positive patients, or intent to treat positive patients?
A few things are not properly visible, but I can see that there is a 27 to 31%. Okay, Nathalie trial, there is a 27% risk reduction.
Correct.
So that is an 31.
So there was a 31% risk reduction in the 5-year arm of ribociclib plus the non-steroidal AI arm as compared to only the non-steroidal AI arm. 90.8 compared to 88 what we say is at 36 months interval. The 5-year IDFS events and the hazard ratio being 0.716. In node positive, again, as we can see, 90.4 versus 87.7. So it will be little better in the node positive, but of course, even in node, in the entire intent to treat population, there was a advantage. There was a total 55.4 months of median IDFS follow-up that this trial had. As we can see, the Monarch E IDFS, so there was again a 32% risk reduction here at 3 years, if you can, with the timeline that ribociclib had followed, 89 versus 84.4%. if you look at the subgroup analysis, again most of these patients did benefit, but the number of patient pool that they were taking here was lesser as compared to the ribociclib or the Nutley here. How do the safety profiles of adjuvant therapies what we say as CDK4/6 therapies impact your clinical decision? Ashwin, if you can just elaborate on what
so
safety profile do you have?
CDK4/6 even in adjuvant are fairly well tolerated that way.
Yes.
We have two agents, ribociclib and abemaciclib. As we all know, we are more scared with the neutropenia which happens with ribociclib, which is not seen with abemaciclib. But I think the dosing of ribociclib in this setting is 400 milligram,
correct,
which needs maybe not that amount of patients would fall in the neutropenia setup. So I think fairly well tolerated safety profile is there, and patients do complete 2 to 3 years
so
of therapy.
I think the side effect profile is a little more different in both these drugs, and we can possibly, it will help in identifying what kind of right subset of patients to choose from. GI is the most common side effect that we see in abemaciclib. It could be diarrhea, it could be GI disturbances. Whereas in ribociclib, you rightly pointed out, 63% had grade 3 or 4 neutropenia. 60% had neutropenia. Grade 3 or more was seen in 44%. There were transaminitis which was seen, and 9% of them were grade 3 or more. And there was also a QT prolongation, but fortunately grade 3 or more was only less than 1%. Usually these AEs generally occurred in the early in the treatment, and they would settle what we say as in the coming weeks or months. 22% of the patients had ribociclib dose reductions due to AEs, most commonly neutropenia and neutrophil count decrease. Median time to the first reduction was 3.5 months, 3.15 months. 19.7 months, 7% patients discontinued the ribociclib because of AEs. Of these, 71% discontinued without prior dose reductions. And again here the transaminitis was most commonly seen. Median time to discontinuation being 4.17 months. Of course, these AEs were asymptomatic. So they were lab abnormalities, they were ECG abnormalities, and they were in the terms of neutropenia or liver abnormalities, but the patients were not symptomatic. So that was very important to see. Whereas in terms of abemaciclib toxicity, which had GI toxicity, it was more of a clinical toxicity which the patient suffered, and it was patient related outcomes which came up, and then there was a need for discontinuation or dose reduction. So this dose reduction did not impact the efficacy of this drug. In an analysis conducted after the most recent data cutoff, the IDFS in the NATALEE was similar irrespective of the dose of ribociclib. And so landmark analysis of dose reduction further supported the similar IDFS regardless of the dose of ribociclib. This was the data cutoff in 2024. Looking at the monarchy, Kshitij, if you can point out towards what we could see as the side effects related to abemaciclib. And
yeah, so in clinical practice also, as written is, the diarrhea is the most common side effect, fatigue and venous thromboembolism. Just one point that you have already pointed out, that when the patient is in ribociclib or abemaciclib, the OPD visit for a patient for a side effect will be more with abemaciclib, because diarrhea is something that almost everybody faces.
Correct.
But the ribociclib side effect that the doctor understands, because the patient is asymptomatic, and we do some tests, WBC counts and ALT, AFT sometimes get deranged.
Absolutely.
And even that, I am not sure about whether if you reduce the dose of abemaciclib, the efficacy is maintained or not.
Yeah.
But ribociclib, there is evidence. So that is the difference.
So there's a major difference. Ribociclib asymptomatic AEs, though more of lab and ECG abnormalities, whereas abemaciclib symptomatic AEs, patients coming to us reporting the side effects, and there was a 43.4% of the patients who had AE related abema dose reductions, diarrhea, neutropenia, fatigue here, and these occurred within the first 6 months. Of course, there were also 52%, 18.5% discontinuation because of this, and 52% discontinued without prior dose reduction within the 6 months. So symptomatic AEs have a negative impact on total treatment adherence, compliance, and of course there would be a loss of quality of life also, and hence possibly there is a case for the first drug based on the asymptomatic AE that we have. Another case scenario I just wanted to discuss: high risk N0 disease, 58-year-old postmenopausal female, 4 centimeters tumor, grade 3 size, a Ki67 which is 19%, and the nodes are negative. So this is a T2N0, high Ki67 and high grade tumor. Of course, she has undergone surgery, you'd like to give her some adjuvant therapy and then maybe consider her for adjuvant endocrine therapy. Again, what is your take on this patient? You would consider this to be based on the NATALEE trial data that high risk or no high risk?
So we'll consider this as high risk as well, because as you mentioned, Natalie, the eligibility for high risk has been broadened.
Yes.
And even node negative patients are now eligible, especially those with high grade or a recurrence score wherein adjuvant chemo is required. Those patients are also included.
Correct. So patients with N0 disease, that is seen here, N0 disease, additional high risk features like high Ki67, high genomic scoring or a grade 3 tumor, in spite of being node negative, have a risk profile which is similar to N1 disease. As we can see, the 7-year recurrence scoring is almost similar for them. Distant recurrence scoring also is similar for them, and the mortality also is similar for them. So probably early stage N0 T2 disease, which has a higher grade, higher Ki67 or higher genomic score, is equivalent in risk factor as compared to a node 1 node positive disease, and that is the key takeaway that we will need to understand from these trial data for such decision making. Again, as we can see, this falls into, though it is a what we say as T2 disease and N0 disease, because of the gradation and maybe the higher genomic score, this falls into a high risk criteria as per the NATALEE data, and we would definitely go in for escalated adjuvant treatment. So this was the trial design. Adult patients, HR positive, HER2 negative EBC, prior endocrine therapy was allowed up to 12 months. N0 with grade 2 and evidence of high risk in terms of Ki67 high, oncotype DX more than 26 and high risk genomic scoring or grade 3 tumor or N1 disease, and anatomical stage 2B N0 or N1, stage 3 N0, N1, N2 or N3. Total 5,000 patients randomized 1:1 ribociclib plus NSAI as compared to NSAI. Premenopausal females also were taken into this, and they were given adequate suppression for making them postmenopausal. Primary endpoint being IDFS, and secondary endpoints were recurrence-free survival, distant disease-free survival, OS, and safety and tolerability. So IDFS in high risk N0 EBC, as we can see, 93 versus 90. In the adjuvant trials, the difference will not be very high. We need to understand that there are potent drugs being given to these patients, and this also clinically significant at the end of 36 months and at the end of 60 months. That is 3-year follow-up and a 5-year follow-up. 5-year IDFS rates significant and the hazard ratio being significant. So there was almost a 40% reduction in the risk with this combination as compared to only the NSAI arm in the IDFS. So how do you explain this patient in your clinic, and what is your take of in terms of explaining to the patient premenopausal or postmenopausal who comes to you with this kind of a scenario? What are the challenges that you face while conveying this information? And what are the gaps involved in the what we say as treatment decision making?
Yeah, so when we discuss this kind of data with the patient, the reluctance comes from the patient because there are 2 to 3 factors we can consider. One is that this tablet also have side effects. They, for next 2 to 3 years, facing side effects again, maybe a little they are not ready to accept because they are already gone through chemotherapies and side effects. Second thing is as these drugs are just introduced, sometimes financially also it's a financial toxicity also may be problematic for them. And the last one is that sometimes the recurrence, when we explain them in terms of single digit number of recurrence, they may underestimate the chance of recurrence.
Absolutely.
So why to take it if the chance of recurrence is so small? So
yes,
that might be some problem.
I think so. What we probably have to impress upon is that it's not just one patient, that patient or the number 3% or 4% increase. It's an overall impact that is going to make, especially in the earlier or what we say as younger population. So younger population living longer, we are trying to make their survivals better. Probably they are at a much higher need of these treatments as compared to a much older population of patients. So somebody who's 45 and somebody who's 75, there will be a difference, of course, in terms of tolerability, in terms of the survival extension, IDFS extension, as well as the understanding. So that is very important. What do you think could be the reasons why this natalizumab data is so strong and very convincing as compared to the other drugs which are there? What could be the reason? I find personally 2 or 3 reasons which are there. One is that they played around with the dose. So instead of 600, the dose was brought down to 400. There was further dose reductions which were allowed, and which allowed for what we say is improving the patient QOL, and the dose reduction did not change the efficacy of this drug. And second is probably the extended duration. So I think abemaciclib was used for 2 years and ribo was used for 3 years. So giving it a little more in terms of duration for a high risk population probably improved the IDFS rates overall is what is my understanding about these trials. What are the key takeaways? We have newer treatment options which are available for HR positive, HER2 negative, EBC, which fall into a high risk criteria. Though the treatments have not changed in the last 2 decades, but newer approval options are changing the treatment landscape. There is always a risk of early and late recurrence that Kshitij had already pointed out, that there is a greater risk of recurrence in the 3 years of diagnosis, but more than 50% of all recurrences occur late also, that is beyond 5 years and 20 years. And risk exists even in patients with lower nodal status, while the risk is correlated with nodal involvement in the most of the cases, but even in N0, there may be a higher risk of recurrence based on the gradation, based on the genomic profiling of this tumor, which we need to understand. And trials have shown similar efficacy and safety profile in approved CDK4/6 inhibitors in EBC. However, the symptomatic and asymptomatic AEs, which may have an impact on the patient decision making and even eventually our clinicians' decision making, we need to follow this, what the benefit that the patients may arrive and what the cost they may have to pay for. There is a robust clinical efficacy noted with these CDK4/6 inhibitors, and global guidelines are constantly getting updated with the consistent IDFS benefit which is noted with the addition of these drugs in the respective patient population. So overall, compare, I think just last one word, if you have the choice of giving both the drugs, in which patient population would you prefer what? Kshitij and Ashwin, both of you?
So because of the broader eligibility, patients definitely with node negative, we don't have another option. Ribociclib, I think the only option available.
Yes.
So in those patients, we would definitely go ahead with ribociclib. Yes.
Correct.
In node positive, yes, abemaciclib versus ribociclib, we may have to discuss the side effects. But looking at the side effect, or these are long-term medications which patients would be. Again, ribociclib would be a fair option in those population as well.
Absolutely. Kshitij.
I perfectly agree with Ashwin. Nodal positivity, we have 2 options, and negativity, we have only 1 option. Then comes to the patient's criteria, so depend on the patient to patient, depend on the side effect profile, depend on the patient's preference, and all other factors. We can decide which is better. I am not biased for that. But if the toxicity profile wise consider the ribo, they might have a better toxicity
Absolutely.
profile.
I think that matters. If there is a patient who is already suffering from a GI, like ulcerative colitis, Crohn's disease, probably makes sense that we will not be able to use abema like a drug. Whereas a patient has cardiac related issues, QT prolongation which is seen, ischemic heart disease, and there is a compromised LV, will not be able to use ribociclib. Otherwise, probably both these drugs are equivalent in their efficacy and have shown robust data. With this, we end our panel. I thank all both of my panelists for this excellent discussion. And over to the announcement.
Thank you, Dr. Tushar. Dear faculty and delegates, before we officially conclude the entire scientific journey, Prince, it is time for a very special segment, our valedictory function. I would call upon Dr. Tushar Patil, our program director for Onco360, for the valedictory address.
I would just take 2 minutes. I would not stand between you and your lunch. This is about the preparations that were going on since last almost 6 months, and constantly getting in touch with so many people. One end was the organizing team from MOC, which helped build up this program, look after all the requirements for the program that was there, and I think Saurabh and team did the wonderful job. The organizing team also made sure that they were in constant touch with the session coordinators, session directors, panelists, moderators, getting their last minute details of booking, flight tickets, car arrangements, everything. I would like to thank all the faculties that came into this for this conference. This was first of its kind, MOC conference Onco360, which we organized at our level, and we want to or wish to make this as an annual event, preferably the same days and same time during December when no other conferences are placed, and definitely we'll keep changing the venues so that it will get more interesting day by day or year by year. Would thank all other people involved in this conference, including what we say as our announcing team, which is there, Radhika, which is there, and we'd like to thank the entire Pune MOC team of consultants and our support staff, which has helped us in carving out this program, which has become so interesting. And at the end, we would also like to thank the pharma people for their entire support throughout this program. We've been constantly nagging them with our demands since last 3, 4, 5 months, and they've really pushed their limits for this conference. Overall, it has been a good, successful outcome for us, and a lot of learning points from this conference to take to the next, and we want to build this to a next level. And definitely with your efforts and our minds, this will be a possibility. Thank you, and thank you all, and have a great Sunday evening. Thank you.
Thank you, Dr. Tushar. It is really great to be associated with a conference of such a stature, and I thank all of you to having bared with me and my bells, the constant ringing of bells to remind you for your time. Lunch is now served. Please join us, and thank you once again for being a part of this conference. We wish you safe travels ahead.